So if we'll sit down quietly and then the program will start, please. Kindly find a chair and then sit on, and then we can start with the program, please.
Good morning once again. Could you please find a seat, settle down so we can start? There are many seats available. Please settle down and we'll be starting soon. It's really wonderful to see you all, and we thank you for gracing us with your presence. We will set the ball rolling, and those of us who are going to be moderating this August event are here. I'm in the person of Dr. Florence Akomia. I'm a cardiology fellow in training at the Kolebu Teaching Hospital, and this is my co-MC.
I'm Dr. George Pepra, a cardiologist from the western region of Ghana. So to kick the ball rolling, we'll invite Dr. Proficiency to give us an opening prayer. Let's welcome him as he comes to give us the opening prayer.
Good morning, everyone, and you're welcome to today's program. Shall we close our eyes and share a word of prayer? We thank you, Father, in Jesus' name, for your grace and mercy, and we thank you for seeing us through another year since our last AGSM and bringing us together for yet another one. We commit the entire program into your hands, and we pray that as we go, we all learn salient things that will impact on the quality of cardiovascular care that we offer to our patients, overall improving quality of life. We commit those who are yet to come in, asking that you extend your journeying mercies towards them so that they come and join us, and then together we learn how to move our cardiovascular care forward. We thank you in Jesus' name. Amen.
Amen. Thank you very much, Dr. Techi. So because of time, we'll try and go very fast. We want to know the purpose for our gathering. We're going to be here today and tomorrow. And to do that for us, we invite the LOC chair in the person of Dr. Foster Foucault to give us our purpose for gathering and also to introduce our chairman. Let's welcome him.
Thank you very much. Good morning, everyone. Distinguished guests, ladies and gentlemen. My name is Dr. Foster Foucault. I'm the LOC chair for this particular AGSM. I have the pleasure and honor, and on behalf of the Ghanaian Society of Cardiology, to warmly welcome all of you here to the 6th Annual General Scientific Meeting of the Ghanaian Society of Cardiology. I must say, I thank you all very much for taking time to come and grace the occasion in spite of your heavy schedules. The Ghanaian Society of Cardiology, as you are aware, was formed in 2017. We had our first AGSM in 2018. And this year, the theme for the annual General Scientific Meeting is titled Atherosclerotic Cardiovascular Disease, a Silent Killer. The Ghanaian Society of Cardiology's main goal is to help in the advancement of cardiovascular training and then cardiovascular practice and care in our country. And as part of its mandate, has selected distinguished personalities in the field of cardiovascular medicine who are going to help us understand atherosclerotic cardiovascular disease. Apart from the various presentations that will be done, this particular AGSM has also been included abstracts for the first time. There will be, there will be workshops for ECG training, and then there will also be workshops for basic life support training as well as advanced life support training. I will encourage all participants in this particular AGSM to endeavor to take part in the various activities so that we will get the benefit of the program. It is our hope that after this particular AGSM, participants will be empowered as to how to manage individuals with atherosclerotic cardiovascular disease. I would like to take this opportunity to thank the Ghanaian Society of Cardiology executives, the chairpersons for the program, the members of the local organizing committee, our various chairpersons, and then our sponsors for assisting us in putting up this particular program. We started a long time ago, and today is the day. Once again, I'm happy that you are here in spite of your heavy schedules to help us make this program a success. You're all welcome, and I wish you fruitful deliberations in this two-day scientific event. Thank you very much. I'll introduce the chairman for the program. The chairman for today's program is in the person of Professor Isaac Owusu. He's a consultant cardiologist and the head of Department of Internal Medicine at the Confanachi Teaching Hospital. He used to be a past president of the Ghanaian Society of Association, and I must say he was very instrumental during the formative stages of the association. He has a lot of experience in training medical students and then training cardiologists. And he has been very instrumental in the activities of cardiovascular medicine in the country. Ladies and gentlemen, let us welcome Professor Isaac Kofi Owusu as our chairman for the program.
Thank you very much for your nice words. The guests of honor, Dr. Insia Sare, the Presidential Advisor on Health, President and Executive Committee of the Ghanaian Society of Cardiology, members of the Ghanaian Society of Cardiology, ladies and gentlemen, it is my pleasure to chair this program. And I also add my voice to the chairman of the LOC in welcoming every one of you to our 6th AGSM. For the first time, we are going to have a true scientific meeting. We are going to have presentation of 5 scientific abstracts. I would like to say that the society has grown from strength to strength since its inception in 2017. Let me comment on the theme of this 6th AGSM. That is atherosclerotic cardiovascular disease, a silent killer. This theme is very appropriate, and it is also very true. This is because the burden of cardiovascular disease in this country is increasing rapidly. And as we are all aware, this increase that we are seeing is being driven by the high burden of the risk factors for the cardiovascular diseases. And the main risk factor, when you think about risk factors for cardiovascular disease, the main risk factor is hypertension. Various studies in the country have shown prevalence of hypertension as high as 30% among the Ghanaian population. In some cases, prevalence of about 40%
have been seen. Studies have also shown that risk factors such as dyslipidemia is also a problematic in the Ghanaian population. And as we are all aware, atherosclerotic cardiovascular disease, by the time it becomes manifest in a patient, by the time a patient comes to see us, this patient is already in a critical condition. And this makes this meeting a very important meeting. I am very happy that the society is focusing on atherosclerotic cardiovascular disease. And it is my hope that at the end of this meeting, we would all learn something and will be able to prevent the high burden of cardiovascular disease that we are seeing in this country. On that note, I would like to wish you all a very successful and happy meeting. Thank you.
I think we can give a more resounding round of applause for our chairperson. Thank you very much, Prof. Usu. So we'll also be inviting the president of the association, Dr. Collins Kukru, who will be giving us a welcome address.
Thank you very much, Madam MC. Good morning. Let me put the protocols in place. Professor Chairman, Honorable Presidential Advisor on Health, Dr. Anthony Isiasari, who happens to be my former CEO, seniors of cardiology, Professor Podonu, Dr. Eugene Amable, and who all happen to be my teachers, representatives of sister societies. We have the president of the Stroke Society, Professor Albert Apalu, my teacher and friend. We have president of DEMSOG, Dr. Mrs. Josephine Apalu, and other sister societies. We have some online, the Nigerian Cardiac Society, the Kenyan Cardiac Society, and all invited guests, fellow cardiologists, non-cardiologists, the media, and our sponsors. Good morning. I'm very excited that we have all lived to partake of this much anticipated 6th AGSM of the Ghanaian Society of Cardiology, which is happening now. The Ghanaian Society of Cardiology was rebirthed in 2017 after some seniors, very key seniors, Professor Akama, Professor Jenin, and Dr. Cyril Fori, and some very good seniors came together and started discussion to have a cardiovascular society that would drive home the importance of the much needed attention on non-communicable diseases and cardiovascular disease in particular in Ghana. At a meeting in 2017, an interim executive body was formed, and it was headed by our chairman for today, Professor Isaac Owusu. And they worked very well and set the ball rolling. So in 2018, we had our first AGSM. And the first president of the society also happened again to be Professor Isaac Kofi Owusu. So from the few foundation members within the 20s, today our membership is over 50, together with our trainees. And we have our diasporan people also with us. For the Ghanaian Society of Cardiology, our motto, or our theme is touching hearts, shaping practice. And we have stood by this over the years to today we have continued to touch the heart of Ghanaians and shaped the practice of cardiology in Ghana. We are labeled as official stakeholders of the Ministry of Health, Ghana Health Service, the NCD program, the Ghana College of Physicians and Surgeons, and other colleges and training institutions. We are bona fide members of the PASCA, that is the Pan-African Society of Cardiology, World Heart Federation, and other important cardiovascular and non-communicable disease forums. And I am proud to say that 2 of our members are leading committee members of the Ghana Non-Communicable Disease Advisory Committee of the Ghana Health Service. And the Ghanaian Society of Cardiology is also an official cardiovascular disease advisor to the Ghana Health Service and the NCD program. And we are invited as a group to all official programs of this committee. In July 2023, the Ghanaian Society of Cardiology was invited as a stakeholder, major stakeholder for the African control of hypertension through innovative epidemiology and vibrant ecosystem. That's the Achieve conference in Ibadan, Nigeria, which was also attended by all the top-notch academic and policy makers and health ministers across Africa. The conference was convened by an eminent researcher and renowned neurologist, Professor Mayowa Owolabi, the pioneer director of the Center for Genome and Precision Medicine, and also the director of AROA NCD Center of Excellence, in partnership with the World Hypertension League, WHO, and the Ministries of Health of Africa. I'm happy to say that Professor Owolabi is our international guest speaker for this AGSM, and he is here with us. In line with our fundamental goal of driving the acquisition and advancement of knowledge in cardiology and its subspecialties and in the basic science that are relevant for the training of Ghanaians, we have set up a robust training program for our trainees to help them acquire the necessary knowledge and requisite skills to finish their programs in record times. We have reached our target of 1 region, 1 active cardiologist, even though distribution is a major thing that we need to talk about. Our next target is 1 district, 1 cardiologist, and that is where we are heading towards. In Ghana, you can confidently call for cardiovascular assistance from anywhere in the country if you are a medical practitioner through the 24-hour cardiology call center, which was initiated by the Ghana Heart Initiative together with the Ghanaian Society of Cardiology. In 2024, the GSC in 2023, the Ghanaian Society of Cardiology undertook major cardiovascular education and screening programs across the length and breadth of Ghana. In May last year, as part of the May Measurement Month, we were in almost every corner and cranny of this country, educating our communities through churches, mosques, traditional places of worship, and security agencies' office to educate them on hypertension and also screen them in a program that we dubbed May Hypertension Campaign as part of the May Measurement Month. Our members were on all the major and minor electronic media, both radio and TV, educating the Ghanaian on hypertension and the need to know their numbers and status to prevent complications of hypertension. Similar programs were done during the World Heart Day in September, and we also organized CPDs for non-cardiologists on pertinent major cardiovascular disease in both children and adults. All the GSC zones, our major 3 zones, Tamale, Kumasi, and Accra, and now with Takoradi, Cape Coast, and Ho, were involved with this major activity. So every year, the GSC carefully selects an important yet pertinent theme for discussion at our annual general and scientific meeting. Last year in Kumasi, we looked at gender and cardiovascular health, and you all agree with me that our speakers and our leaders did justice to that topic. Today at the AGSM, our theme is Atherosclerotic Cardiovascular Disease, a silent killer. And the LOC have done well, and let me commend the LOC chair and his committee for the wonderful work that they have done in bringing us to this forum today. I wouldn't want to take all the spice out of what is going to happen at this AGSM, but like the LOC chair said, it is important for us to note that we are not only cardiologists here. For our meeting today and tomorrow, we have an eminent neurologist who have already introduced, Professor Mayowa Olabi. We also have a consultant vascular surgeon and endovascular interventionist, Dr. Liliu. And in addition to that, we have our we have our speakers who are going to be online, Dr. Fafa Zemeku, who is a multi-modality cardiovascular imaging expert. In addition to this, we have our own Professor Akama, Professor Nikose Jenin, and Dr. Doku, who need no introduction when it comes to cardiovascular health in Ghana. I want to thank our guest of honor and keynote speaker, Dr. Anthony Siansari, the Presidential Advisor on Health, for agreeing to be here in spite of his many busy schedules and tasks. Sir, we thank you so much. I also want to thank our panel of speakers and our chairpersons for agreeing to take part in this AGSM and also take up their respective roles. I want to thank the representative of our sister associations, DEMSOC, Stroke Society, and the other societies, the Nigerian Cardiac Society, the Kenyan Cardiac Society, PASCA, and the World Heart Federation, for all being part of this program. And I want to thank again the LOC chair and his team for this splendid show. And a big thank you to our sponsors. Without them, I'm sure we may have crashed. AstraZeneca, Bayer, BI, Severe, Novartis, Denk Pharma, Warm Pharma, and the many. We say we are so grateful to you for your commitment with us every time we follow on you. And I want to thank our cherished GSC members and our trainees who are here and those online for your continued support and commitment that you give to the society. Then finally, all our participants, both in person and online, for the time that you are going to spend to be with us. Let me say that it is not going to be a waste of time. Like the chairman said, this topic has been well crafted. I will want to wait and see the solutions that will be proffered for erectile dysfunction in this meeting. Just relax. Make your pens and notebooks ready to add to the knowledge that you have. Thank you all very much, and may God bless us all. Okay, so I've been tasked again to stand here and introduce our guest of honor and keynote speaker. Our guest of honor and keynote speaker is Dr. Anthony Nsiansari, who is the Presidential Advisor on Health for Ghana. So you can see that we are trying to get closer to the Jubilee House, to the President, so that whatever we say here will directly get to the President. And this is actually a planned work that have worked. Having worked in leadership role as medical superintendent at district hospital, medical director at regional hospital, chief executive at the teaching hospital, Konfanochi, where I work, and director general of the Ghana Health Service, Dr. Nsiansari has created a balance of strategic operational health service, business, clinical, and health system reform experts. Dr. Nsiansari qualified from the University of Ghana Medical School with MBCHB so many years ago. I was just a little boy in 1980. He is a consultant general surgeon and alumni of the Boston University School of Public Health in the USA, where he obtained his certificate in management methods in international health. He's a fellow of the West African College of Surgeons, fellow of the Ghana College of Physicians and Surgeons, fellow of the International College of Surgeons, and fellow of the Ghana Medical Association. He served as member of the Ghana COVID-19 Task Force, Presidential Vaccine Production Committee, Garden City University College Council, and so many, including the Insurance Board and Chairman of Health GIF a board. So many of them that because of time I will want to skip. But there's one that I cannot skip. He's the main brain behind Agenda 111. And in fact, let me confess that had it not been our meeting today, he would have been on his official tours for inspection of the Agenda 111. He has served on so many committees. So for the sake of time, I will cut it. But I want to say that Dr. Nsiasare is married with 4 children. Chief, we thank you so much for being here. And it is my honor to introduce you as a guest of honor and keynote speaker. Thank you very much.
Thank you very much, Collins, for the kind words that you've said about me. But before even I start, I'm very happy to hear that during my days in Konfanochi, in fact, we didn't have any cardiologists. Prof. isn't it? So we were wondering what we should do with cardiology. The only thing we could do was to work closely together with cardiostat, who were coming twice a year. And luckily, we also got the Boston Children's Hospital cardiothoracic surgeons to also be doing cardiothoracic surgery twice a year. I remember the first day we did 24 children open heart surgeries. Everybody there wept when the first person came out. So we decided that we will send some people to go out to go and train. And Prof. Usu was the first person that the hospital sponsored this Prof. Usu from our own resources to go to Belgium to go and do cardiology. And I'm very happy. I think during our school days and our early days as medical students, I know Professor Podonu. Prof, you were about how many cardiologists in Ghana? About 3 or 4? About 3. Yes, and they were all in Kolebu. So if you have an acute cardiac problem, that time the planes were not working very well. So by the time you reach Accra, you'll be gone so soon and you'll be brought back. And Konfanochi didn't even have one. So I'm happy that from the initial stages of 3 people, now you have an association, or Ghana Society of Cardiology, of how many people? More than 50 membership. And I become so happy when I see our young members who are doing cardiology. And if you ask anybody, say I'm doing cardiology. I've seen Wilhelmina here. It's my able PA. I traveled with her recently. And I was happy that he started doing fellowship in cardiology. So Prof Podonu and the rest, thank you very much for what you have done for Ghana. And I'm hopeful that, as the president said, very soon there will be 1 district, 1 cardiologist. And it is possible. It shall happen. Because of Agenda 111, where we have hospitals in all the districts, with accommodation attached. So when you go, you have your free accommodation, well furnished. So you move to accommodation, and we start training also cardiologists at the district level. Because we want to decentralize postgraduate training. That is our aim. So that every hospital will have at least all the specialists that we need in the district level. And maybe one day we shall even send cardiologists to the CHIP center so that we can achieve our aim. Professor Chairman, Professor Ezeku, Professor Podonu, Dr. Amabel, and the rest who are watching us, the President and executives of the Ghanaian Society of Cardiology, the Chairman and members of the LOC, fellow colleagues who are here with us, distinguished invited guests, the media, ladies and gentlemen. It is a great pleasure to welcome you to the 6th General Scientific Meeting of the Ghanaian Society of Cardiology on the theme, Atherosclerotic Cardiovascular Diseases, a Silent Killer. As you are aware, cardiovascular diseases are the leading cause of death worldwide, claiming about 20.5 million deaths in 2022, due mainly to atherosclerotic cardiovascular disease, such as heart attack and infarctive stroke. About 80% of these deaths, unfortunately, occur in the lower middle income economy, like us, including Africa, and 40% being premature deaths. Atherosclerosis is increasing at alarming rate in Africa due to urbanization, increased cardiovascular risk factors such as hypertension, diabetes, dyslipidemia, and the rest. Cardiovascular diseases, including atherosclerotic cardiovascular disease, are the main causes of premature death in adult Ghanaians. And hence, I find the theme of this year's AGSM appropriate and timely. I want to thank the GSC and the local organizing committee for highlighting this emerging pandemic in sub-Saharan Africa and complementing the efforts of government to tackle it. Ladies and gentlemen, cardiovascular diseases are a major threat to our society as they affect the productive age group, the breadwinners in families. I think we all go around and see obituaries or notice boards around the country, which says, "What a shock, gone so soon." These tell the story. They tell us that deaths are sudden and premature. And in fact, families normally don't even understand why the young people are dying like that. And heart diseases, as well as associated chronic diseases, are causing all these issues. Unfortunately, our culture and belief systems still encourage unevenly the very learned, and even the very learned, to attribute these deaths, which can be prevented, to superstition, bewitchment, and curses. If you are unlucky, and there's an old lady in the house with the teeth gone, you see that he is the one who is killing the young people in the house. In Ghana, institutional data show that cardiovascular disease is the main cause of deaths in adults. The whole society of Ghana, as well as the rest of sub-Saharan African countries, have not woken up to the realities that these deaths are preventable through lifestyle modification and risk factor detection, early treatment, and modification. Certainly, healthy diet, smoking, especially now smoking shisha by young people, and physical activity, as well as regular medical screening to detect hypertension, diabetes, and dyslipidemia are the major steps in preventing these sudden and premature deaths caused by cardiovascular diseases. Prevention of disabilities and deaths from cardiovascular disease should be a concern for all. The teaching and the regional hospitals manage the complications from uncontrolled hypertension, diabetes, and high cholesterol, such as stroke and heart failure. Even in a well-resourced countries, the outcomes of these cardiovascular diseases are not always the best. For us in Ghana and sub-Saharan Africa, the best way is prevention and early detection and early treatment. Ladies and gentlemen, lifestyle modification interventions at the community levels through our community health nurses who could be found throughout the country, as well as early detection of cardiovascular risk factors at the basic levels, are the way to go. CHIPS compounds and health centers, through the measurement of BMI, blood pressure, blood sugar, for the potential of cutting down cardiovascular deaths significantly, is what we should target. Early detection of the complications of these risk factors, such as retinopathy, proteinuria, and left ventricular hypertrophy at the district, general, and regional hospitals, of prompt early appropriate interventions to arrest progression of cardiovascular diseases which causes these deaths. Professor Chairman, allow me to also comment on other non-communicable diseases in general, which is the main health challenge in Ghana and sub-Saharan Africa. Deaths from non-communicable diseases, including cardiovascular diseases, have more than doubled in the last 20 years in the sub-Saharan Africa and Ghana. This is due to more adaptation to migration and urbanization, leading to lack of exercise and poor eating habits. Hypertension is the single most important risk factor that has risen out of this more adaptation, leading to stroke, heart disease, and kidney failures. If you don't try to solve this, Kolebu will always be having problems with renal dialysis machines. When one talks about increased urbanization and industrialization in Africa, giving rise to non-communicable disease, it gives the impression we have eradicated communicable diseases. Professor Chairman, that is not the answer. The epidemiological transition is not complete, as in the Western world, but we are still in transition. Majority of Africans are still poor. We are still battling with communicable diseases such as malaria, tuberculosis, and HIV, as well as maternal and infant diseases and malnutrition at the same time as the emerging cardiovascular diseases. This is a very great and big challenge for our health systems. Globally, the World Health Organization estimates the mortality of non-communicable diseases will increase overall by 17% in the next 10 years. The largest increase in mortality will be seen in our developing countries. About 27% of it will be in African region. Global cardiovascular deaths from 17.1 million in 2004 has risen to 23.4 million in 2030. Much of the increase in non-communicable disease is due to globalization, rapid unplanned urbanization, population aging, and lifestyle changes such as tobacco use, decreased physical activity, and increasing consumption of unhealthy foods. In Ghana, for example, institutional deaths from cardiovascular disease have increased from 8.9% in 2002 to 22% in 2020. Currently, cardiovascular deaths continue to lead in institutional deaths in Ghana. It's no more malaria. Hypertension prevalence has increased significantly from 17.5 to 32% of the adult population have hypertension. However, over 70% of these hypertensive patients are not even aware that they have hypertension. And only 5 to 13% of those on treatment are controlled. So over 70% of those who don't know that they have hypertension don't even have treatment. And nearly half of the hypertensives have target organ damage before they even know about it. That's other complications. So if you look at these statistics, Professor Chairman, it's very daring. That's the reason why we as government have started introducing what you call wellness clinic. We have wellness clinic, for example, at Gao Sudoku Hospital. So I call it adult weighing, because children don't have to be sick before they go for weighing, isn't it? So adult, at the month or the week of your birthday, you just get up and go to any clinic that you are not sick, but you are coming to check yourself. They will check at least your BP. If you have white beard like me, they will check your prostate. And the women also, they will check your breast and your cervix. This is the way to go. So as a government, we want to put it as one of our policy state directives that from next year, God willing, when the continuity continues, we shall institute that in our policy and move forward so that maybe health insurance have been asked to cost it. And that will be a very great way to reduce even reimbursement of health insurance. Because you don't have to have end-stage renal disease before you are treated. You see it early, you manage your hypertension, you manage your diabetes. You may not even take any drugs at all. You may maybe change your diet and exercise, and health insurance will not pay for diet. So to me, that's the way to go, so that we cut down the unnecessary deaths, and then we can at least mitigate the effects of non-communicable diseases. Non-communicable disease, ladies and gentlemen, has a high economic burden and have the potential of tipping households into poverty and maintaining them in it. The WHO estimates that in developing nations experiencing rapid economic transition, heart disease, stroke, and diabetes alone reduces gross domestic product, GDP, by between 1 to 5% in the lower middle income economy. In a study of 23 low middle income countries, it was estimated that about $84 billion of economic production are lost from heart disease, stroke, diabetes alone between 2006 and 2015. Despite the increasing importance of non-communicable diseases, including cardiovascular disease, it has not received the necessary support globally, regionally, and even nationally compared to communicable disease. All our attention over the years have been on communicable diseases, to the extent that I know Global Fund doesn't even support any non-communicable diseases. It's malaria, TB, and HIV/AIDS. A study of estimated donor spending on non-communicable disease from 2001 to 2008 in developing countries revealed that less than 3% of the overall global development assistance for health was dedicated to non-communicable diseases. The disparity has even worsened today after the COVID pandemic and the Russia-Ukraine war. Since 2015, ladies and gentlemen, Ghana has aligned itself with the MDGs and on non-communicable disease on these three issues. By 2030, whether we like it or not, we are supposed to reduce by 1/3 premature mortality from non-communicable diseases. It's a huge task. 2, we have to substantially increase health financing and recruitment, development, training, and retention of health workforce. I'm happy from what I'm seeing today that at least we are doing something about training, and maybe we have to do extra thing about retention. And 3, we have to strengthen the capacity to identify early warning, risk reduction, and management of health risk. That's why we are here today, to deliberate and make sure that we come out of blueprint to assist in this direction. One of the goals of the medium national health plan is to enforce a national policy for prevention and control of chronic non-communicable disease in Ghana, which was developed in 2011 and updated in 2022 to help reduce the burden of non-communicable disease in Ghana. The policy looks mainly at primary prevention of non-communicable disease risk, as well as early detection and clinical care of non-communicable disease, especially cardiovascular disease, through early detection of complications of hypertension and proper management of hypertension. In addition, access to health, quality and care, and equitable distribution of health services have been identified as important in the fight against non-communicable diseases. That's why government is doing something about the equitable distribution of healthcare services. We found out that 88 of our 216 districts in Ghana, they didn't have anything that you can call a first primary referral center, district hospital. That's the reason why Agenda 111 was introduced. We are going to make sure that all regional hospitals, including the 6 new regions, have what you can call a secondary referral center. And then all districts in this country will have 60 to 100 beds, depending upon the population of the district, proper state-of-the-art, fit-for-purpose district hospital. I'm happy to say that about 90% of them are now ongoing. Some of them have reached about 90% construction completion. We are hopeful that come July this year, God willing, when we are all alive, you will see the commissioning of these hospitals. All what we have started, we will finish, and those who are yet to come on board, the continuity will continue and continue to finish it. Certainly, ladies and gentlemen, it's beyond the capacity of our incomes that in the lower middle income countries to achieve NCD goals and objectives if you go about it the way that we are going. Partnership, therefore, for health is the way to mobilize network and support from stakeholders in the health to achieve these objectives. This is one of the important objectives of the 2022 non-communicable disease policy and strategy, that is multisectorial support for non-communicable disease prevention and management. Professor Chairman, distinguished colleagues, ladies and gentlemen, let me comment on the concerted efforts being made in the health system to address the emergency cardiovascular disease such as atherosclerotic cardiovascular disease pandemic in Africa and in Ghana. I think all is not yet lost. On the continent in Africa, WHO, Pan-African Society for Cardiology, World Health Federation, International Society of Hypertension, and other bilateral and multilateral agencies have been supporting the prevention, detection, and management of cardiovascular care. The heart package from WHO, the hypertension guidelines from ISH, of recommendations for resource-poor settings, the roundtable discussions on hypertension and diabetes in Africa by WHF, as well as the effort by ISH Regional Advisory Group of Africa's efforts to develop hypertension guidelines for Africa has been done. These efforts are beginning to bear fruits, you all agree with me, with greater awareness and agency to support cardiovascular care in Africa. In Ghana, these efforts are also being seen on the ground. We have a national cardiovascular management guidelines. We have national diabetes guidelines. We have a training manual for cardiovascular disease capacity building and training. We have equipment support to address cardiovascular disease and the risk factors. These are things that we are doing to reposition of primary health care through, as I said, Agenda 111, so that they will support the lower levels, the network of practice and universal health coverage which Ghana Health Service has introduced with renewed focus on non-communicable disease and cardiovascular diseases. There is a general commitment to improve primary health care, to improve integrated screening and management risk factors of cardiovascular diseases. These efforts, ladies and gentlemen, in the health system of Africa and in Ghana in particular, there is a huge gap, though, at the population and the community level. Atherosclerosis, and for that matter, atherosclerotic cardiovascular pandemic, is a chronic, progressive, and preventable disease. Population-based awareness and positive lifestyle adjustment are necessary for effective primordial and primary prevention of atherosclerotic cardiovascular disease. Africa does not have the resources to manage strokes and heart attack. We need, therefore, to prevent it, because the saying is that prevention is better than cure. The key messages from this AGSM, therefore, should be expressed in very simple language and disseminated throughout the country and Africa for the ordinary person on the street to appreciate and to change their health choices. When the ordinary person comes on board for us to fight the atherosclerotic cardiovascular disease, ladies and gentlemen, we are destined to win. And I say that if you all collaborate and put our hands on the deck, it is possible. I wish to wish you a successful AGSM and a fruitful deliberation, and congratulate the Ghanaian Society of Cardiology for all these efforts to address cardiovascular disease in Ghana and non-communicable disease as a whole in the country. I wish you all the best. We will be at Jubilee House, and I hope that you send us the blueprint and a copy of what you are doing immediately you finish, so that we look at it and use some of them to inform our policy document. I will say once again, thank you for inviting me. I will let the president know that there are people here who are caring about our heart. And we're hopeful that with what we are doing here, we shall all succeed. And I will say once again that if you all put our hands together, what we are doing is possible. Thank you, and God bless all of you.
Thank you very much, Dr. Insiansari. And I think he deserves another big hand clap. It's good to know that there are various policies to address this silent killer. And we are happy about all that we have heard today. We also want to thank, in fact, when the president was speaking, he mentioned some names, teachers. I mean, we have teachers in this room. We have Prof. Podono, we have Prof. Ousu, Dr. Amable, Dr. Doku, Prof. Apalo, Mrs. Apalo. Please, shall we put our hands together for these people? These are the people who are actually doing the work. Dr. Jekum, Dr. Lambert, Dr. Okro. These are our trainers, our teachers, and they are really moving cardiovascular training in this country, and we appreciate the work that they do. And then we also heard of wellness centers. Dr. Nsiasari is very busy, so being the MC and also a medical superintendent at Atherosclerotic Hospital, I heard wellness centers, and I think it is a very good initiative. But I think we don't speak much about if there will be a lot of advertisement about these adult weighing centers, so that people will go there and then check their cardiovascular risk factors, so that at least, I mean, wellness center is everywhere. It is very basic, and it can easily be used to catch people with hypertension and other risk factors very easy. I'll give to my co-MC.
So we have one last task for Dr. Nsiasari. We need you to come and declare the Congress officially open. So.
Thank you very much. On this note, ladies and gentlemen, fellow colleagues, I want to take this opportunity of the powers given to me to officially open the annual General Scientific Meeting. Thank you very much.
Thank you very much. And the Ghanaian Society of Cardiology does not exist in isolation, and we have been honored to have representatives from other fraternities who are here, and so we would invite them to give us their message. We'll start with the Neurology Society of Ghana, and we invite Prof. Akpalu to do so.
Thank you very much. It's a pleasure to be here and to see our very good friend and collaborator, Dr. Nsiasari. Neurology Society of Ghana was finally formed in 2022. We have 40 members. At the end of this year, we'll have 2, so we can cover one region, one neurologist. We're very happy to have a lot of collaborations in investigations and major studies with members of the Ghanaian Society of Cardiology. Prof. Maiwa is our collaborator, and both in Kumasi and Accra, we've led the largest study on stroke in sub-Saharan Africa, that's Cyrene SIBS. There's still a lot of collaborative work to be done. Atherosclerotic cardiovascular disease, a silent killer. But what is the true burden of this? So this is work that we have to do. I want to congratulate members of the society for leading the CVD guidelines for Ghana. We wish you a successful AGSM. But the debate still continues. Brain versus heart, or I think brain and heart. And I want to add to Dr. Nsiasari's blueprint that they should add 1 CT scan per region, because we need to diagnose stroke. Without a CT scan, cannot diagnose stroke. Before I call Dr. Nkama to tell me what the cause of the stroke is. So I think it's brain over heart. So thank you very much. Have a successful AGSM.
And we'll invite Dermatology, Endocrine and Metabolic Society, Dr. Mrs. Apalo, to also give us their fraternal message.
So thank you very much. Please permit me to stand on the existing protocols, and even as I deliver our message. So I'm grateful for the opportunity to say a few words on behalf of Diabetes, Endocrine, and Metabolic Society of Ghana during the 6th AGSM of our sister society, the Ghanaian Society of Cardiology. So atherosclerotic cardiovascular disease, which is the focus of this AGSM, is quite dear to the heart of DEMSOC, considering that a number of the risk factors for this non-communicable disease is within our purview. That's our subspecialty of endocrinology, diabetes, and metabolism. With diabetes, dyslipidemia, and obesity among the most common examples. Cardiovascular health concerns everyone, and as healthcare providers, researchers, and advocates, we are to champion the cause of achieving cardiovascular health for all. With the Ghanaian Society of Cardiology, ably supported by other related professional societies leading this campaign. In this regard, DEMSOC is happy to collaborate with the Ghanaian Society of Cardiology to ensure that Ghanaians have access to the care and treatment they need to reduce the burden and impact of atherosclerotic cardiovascular disease in our communities. In doing so, we will also be working towards achieving the Sustainable Development Goal 3, which aims at reducing premature non-communicable disease mortality by 30% by the year 2030. We should, however, not forget the bigger burden of primordial prevention, which our special guest of honor also touched upon. And it requires a collaborative effort of multiple sectors in the country to achieve that. These sectors, apart from health, may include education, the local government, town and country planning, so many other sectors, to ensure that we all play our unique roles to ensure that we have appropriate policies and strategies which will be implemented to reduce the chance of developing the cardiovascular risk factors in the first place. The key steps towards this achieving primordial prevention are very basic and very simple, including following a healthy diet, exercising, maintaining a healthy weight, not smoking, and improving sleep health. These must be encouraged in the general public to reduce the health and economic cost of the associated cardiovascular risk factors and their consequent atherosclerotic cardiovascular disease that we are talking about today. In closing, I would like to urge those of us who are involved in research to also focus on ensuring that we translate the science that we are engaged in into policy and also awareness creation, so that together we can build a stronger health system to deliver cardiovascular health for all. So on this note, I'd like to congratulate the Ghanaian Society for Cardiology, and I also wish them a successful deliberation during the AGSM. Thank you.
Thank you very much, Prof. Akpalu and Dr. Mrs. Akpalu. So we don't want to wait till your makeup wears off and your suits get crumpled. We will take a few minutes of your time and have a photo session outside at the foyer. We'll start with the executives and the guest speakers, and then all of us are going to join them for some photo sessions. So please, let's go out for that. After that, we'll continue with a coffee break also served out at the foyer. Thank you very much.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo. CKD. Are you seeing the full picture? CKD is a life-threatening condition that is vastly underdiagnosed. Even at stage 3, as few as 10% of patients with CKD are diagnosed. By identifying patients early, you can improve outcomes, delay disease progression, and prolong dialysis-free survival. Screening should focus on patients with risk factors for CKD. Those with high blood pressure, diabetes, cardiovascular disease, and a family history of CKD are at higher risk. eGFR is a critical test that measures kidney function. Measurements below 60 for more than 3 months signal CKD.
presentations. Please, can we be seated? Hello, can we all be seated so that we start the next section of presentations? We're going to have a series of very important topics about atherosclerotic cardiovascular disease. Hello. And the topics that are selected are very interesting and very important. The brain, the heart, and the erectile function, and then the causes of these. So without wasting time, we will invite our chairman, Prof. Isaac Osu, to come and chair this section for us. Please, let's invite him with a clap.
Yes, good morning. Yeah. So we want to start immediately. We are somehow late, more than an hour late. And we are going to take our first presentation, which will be on atherosclerotic cardiovascular disease, focusing on the epidemiology, risk factors, pathophysiology, primary and secondary prevention. And the speaker for this presentation is Dr. Alfred Doku. Dr. Alfred Doku graduated in 1997 with MBCHB at SMSK and UST. He trained in internal medicine and in cardiology, and is a fellow of the West African College of Physicians, a fellow of the Ghana College of Physicians and Surgeons. He holds membership in several professional societies. He has been involved in healthcare system strengthening, and he led a team of cardiologists to develop the first ever national guidelines for the management of cardiovascular disease in the country. Ladies and gentlemen, our speaker, Dr. Alfred Doku.
Thank you very much, Prof. Good morning, ladies and gentlemen. Dr. Nsiansari, our special guest of honor, my trainers, Professor Podonu, Dr. Mable, colleagues, ladies and gentlemen. I'm very grateful to the LOC for inviting me to give this talk. Cardiovascular disease is a major problem. It's the main cause of death in Ghana and across Africa. And atherosclerotic cardiovascular disease is evolving. Okay, previously, we learned more from infectious causes of cardiovascular diseases, and also from cardiomyopathy, rheumatic heart disease. But at the moment, the atherosclerotic component of it is increasing, and so it's important that we address it. We're getting a lot of infarctive strokes, a lot of heart attacks, and so it's important that, yes, this AGSM, split emphasis on it. So we're going to discuss the epidemiology, the risk factors, pathophysiology, a lot, but I'll try and make it brief so that we can finish on time. So the theme is appropriate. Every now and then, Francis and I are called to address or to handle a patient with a heart attack. We call the stroke units with a stroke. And then we have thrombolytics in Kolebo, and we keep it at the stroke units. They have 2 valves every now and then. 2 days ago, we're called to manage a patient. And so we had to go to the stroke unit to get a thrombolytics. And I think last year, we also had a national campaign. So across the country, we have thrombolytics in some of the major hospitals. This is relevant because we're getting a lot of atherosclerotic cardiovascular diseases, getting MIs. Some facilities have capacity to manage, others don't. So once we have patients coming in at the right time for STEMI, infarctive stroke, at least something can be done about it. So it's important that we discuss this. So let's go to my outline. Talk about epidemiology, risk factors, pathophysiology, and then we'll look at the prevention, and then we'll conclude. As has been mentioned several times, yes, as poor countries, we bear the brunt of the cardiovascular disease, NCD burden, over 80% of morbidity and mortality from NCD, okay, in these parts of the world. Yet, we don't have the capacity to manage it. We don't have the resources, so the only way will be to prevent it. And out of the NCDs, about 50% come from cardiovascular disease. And if you look at global mortality, that's cardiovascular disease constitutes about a third of the global deaths. And around the world, as I mentioned, we are bearing the brunt of it. But 12 million people die from atherosclerotic cardiovascular disease. Now, if you look at the total burden of atherosclerotic cardiovascular disease as part of the CVD, morbidity and mortality, ASCVD consists about 2/3, and the number is increasing. In the Western world, they also went through the same epidemiological transition, where initially they were, dying more from hypertension-related and other CVDs, but now about 70% of their CVDs are from atherosclerosis, and we are also getting there. Sub-Saharan Africa, CVD burden is increasing. Let's look at Ghana. For the last few years, in the past, we were thinking more of infectious diseases, but slowly our lifestyles are changing. Akama has moved from Bongo to Accra and then now to the US and back to Ghana. And so our lifestyles are changing. What we eat, our mobility, everything has changed. Bongo Chief. I'm from Sugakofa. And if I look back, Dr. Siasari, and I went to school without slippers. Primary school. Our parents would walk to the farm 2 kilometers, 3 kilometers. But now, as Adade is aware, I don't drive. I use Uber all the time. And so I don't walk those 2 kilometers anymore. So I'm getting all the pot belly and all that. So the cardiovascular disease burden is increasing because of these risk factors: diabetes, hypertension, dyslipidemia, obesity. And so it's a major problem. So as our lifestyles change, the disease burden also increases. So as you can see, non-communicable diseases are increasing, and then infectious disease components, infectious diseases are coming down. But we are dying more from cardiovascular disease from NCDs. And if we look at the disease burden in Ghana, the bulk of the deaths are from cardiovascular diseases. And as has been mentioned by the speaker, less than 10% of the global support for diseases in Africa, in Ghana, go to NCDs. What's the number one cause of death? Cardiovascular disease. So it's a major problem that we need to address. And if you look at the diseases that will send somebody to the OPD, maybe a cold, a cough, a fever, a headache, usually it's not a problem. The person is treated and the person goes home. Now, if the disease is severe enough for the person to be admitted, then you're looking at cardiovascular disease as one of the components of these admissions. So you're looking at hypertension, diabetes, hypertension-related, either a stroke or heart failure. Now, if the disease is severe enough for the person to die from, then the cause of death is no longer the malaria or the respiratory tract infection, but rather cardiovascular disease. So it's the number one cause of death in Ghana. So what's the pathophysiology of ASCVD? This lipidemia is an important component. Diabetes, obesity, physical inactivity, and several of these factors come together to cause the problem. And ASCVD, it starts right from childhood. Right from childhood, and the plaques start building up. So when you hear somebody has died from a stroke, from heart attack, yeah, what shock. This is new, but the problem has been going on. And atherosclerosis and how it presents. You can have a plaque or the size of maybe occupy maybe 5 to 10% of the lumen. But that can be dangerous because it depends on the morphology of that plaque. So you can have a plaque rupture, and then with a clot formation, that can cause a stroke or a heart attack. So this is what I was referring to. So you could have just maybe 30% or 20% of the lumen, and you can have a plaque rupture. But this can go on for years, worsen, and the person can have chest pain, maybe on exertion. But this may not kill the person. Even this can kill the person because this plaque, if it's not stable, can rupture to cause a CVA or a heart attack. So the coronary syndrome is a progressive disease. Several factors come in. The risk factors, hypertension, dyslipidemia, very important, diabetes. And then slowly have endothelial dysfunction, the atherosclerosis. And then you could have acute events, chronic, build, which can also become obstructive coronary artery disease. Dangerous, which is the one cause of death. Why? It is acute, stable plaque that in acute coronary syndrome. So you can see here, the plaque ruptures, it grows and then ruptures. And then there's a clot formation, and this clot that which causes the AS, acute coronary syndrome, that we are all afraid of. Cardiovascular disease is a major problem. I want to present one case. And data in Africa shows that a lot of us have atherosclerotic subclinical type. So we have plaques in our carotids, plaques in the coronary arteries, and the plaques in our legs. It's not just one country, several countries in Africa. This is across the world. In the past, people in Africa would die from hypertension-related complications. Now the hypertension is adding to the risk factors for atherosclerotic cardiovascular disease. So you have infarctive stroke and ischemic heart disease as the main cardiovascular diseases in Africa. Now, how did we get here? Now, if you look at from 1990 to 2019, cardiovascular ASCVD has really increased in frequency. So you have peripheral artery disease, infarctive stroke, and ischemic heart disease. These numbers have more than doubled over the period. So this work done by Professor Mensah, which shows that the last 20 years, ASCVD has actually doubled in sub-Saharan Africa. And it's increasing because of this changing lifestyle. We all move, we're not eating right, we're not exercising. And so the risk factors are increasing. That is what is driving the burden here. And this is work done by Professor Olabi, which shows that, in the past you had hemorrhagic stroke, the main cause of stroke. Now it's more of atherosclerotic, that's infarctive stroke. So he was able to demonstrate that 68% of strokes in Africa are infarctive. So it means that things are changing. If I look back some of the data by Professor Ray Drew, about 60% of strokes, about 20 years ago, were hemorrhagic, but now they are infarctive because of the plaque. If you look at the Saharan study, the risk factors for stroke are all over the place. And so we need to address these risk factors. So atherosclerotic cardiovascular are increasing, and it's going to even increase the more unless we improve on the risk management and be able to address the problem. So how do you prevent? And that has been mentioned by the chairman. We don't have the resources. How many people can afford heart attack management? Coronary angiogram with the stents is about $3,500. And I think it's about the same across board. Kumasi, Tamale, and several other places, we don't have functional cath labs. So what happens to somebody with MI? A lot of us don't have thrombolytics. What happens when you have an infarctive stroke? And even when they diagnose it, some of them are diagnosed about 2 days later, 4 days later. So as a continent, as a country, the only way is to prevent it. There's primordial prevention, primary prevention, and for those who have suffered an event, then secondary prevention are very important. WHO has developed a simple tool to risk stratify the patients we see. And this is something everybody should do by the clinic. It's a simple tool. You don't need to have an app for it. So you have this chart. The previous, which was developed about 4 or 5 years ago, hasn't been modified. So there are two of them. One with the LDL level, or total cholesterol level. The other one, if the person doesn't have the results, you could still use it. So this is a non-lab risk calculator. So all you need is a BMI, blood pressure, the age, the gender, and then whether the person is diabetic or hypertensive or a smoker. And then it's able to calculate the risk. And it's very sensitive and it's very specific. And for those who have their lab results, yes, so you could also use this one when you have the LDL level or total cholesterol. So you can use the same chart, and I advise that we all have this in our consulting, so that our nurse, even before the patient see you, the nurse can just chart the risk, for the patient, looking at the age, the gender, looking at the blood pressure levels, the cholesterol level. If they have, even if they don't have, you could still have an instant risk calculator. So it's important to evaluate our patients. When the patient comes to us, this patient likely to have an ASCVD. And we have different types of patients. Those patients who are healthy, seemingly healthy patients, today everything is okay. And then we have those who have had previous events and those who have maybe end organ damage. For example, they have CKD, they have other events in the past. So my emphasis on those seemingly, healthy patients. So these are, you need to calculate the risk factors, and then are they mild? Do they have mild factors, moderate risk factors, or severe or very severe risk factors? And then you looking at what's the problem they have, then you can institute other lifestyle modification, which is very important, and then you can also add medications to manage some of the risk factors. It's also important to also look at the environment, the population as well. I think the guest speaker mentioned it. It's population-based intervention. We need to prevent that. We need to focus on the population. We all think we are healthy, or everybody in the country thinks he or she is healthy, and then you hear, oh, what a shock. This plaque ruptures, and then there's an infarctive stroke or a heart attack. Oh, he was okay. I mean, yesterday he just arrived from so and so, or he went to visit the mother. That's how ASCVD kills. The person is stable. But if we don't recognize their risk factors and then intervene, lifestyle modification, appropriate medication, then there's a problem. So in risk stratifying these patients, you have patients with low risk, moderate, high risk, very high risk, and very, very high risk, if I may say so. That's patients who had events maybe 2 times in the last 2 years. So once you do that, then the appropriate therapy then can be given. So there's been a bit of fight between the Americans and then the European. In 2018, the American came out with this lipidemia or primary prevention guideline, and the following year, the Europeans also came out with a guideline. And then the European added this component. Those who have had 2 events or so in the last 2 years, the Americans were looking at patients with events to say they have very high risk, but the Europeans said no, you have diabetes, then you have very high risk. If you had CKD, you have very high risk. So we need to really appropriately classify these patients and manage them. If you don't manage, then you get that call. You get that call that the person has a stroke or a heart attack. And in managing these patients, we need to give the appropriate therapy. So there's moderate intensity statin in addition to all the other medications that you have to give to bring the blood pressure, the blood sugar. But statins are the cornerstone, okay, in managing this lipidemia, which is one of the main causes of atherosclerosis. So you have high intensity, but if patient is not able to achieve the target, they may have to bring in, for example, ezetimibe, add it to the statin. The statin, how much can this patient tolerate? Let's say atorvastatin 40 milligrams or 80 milligrams. If you're not able to achieve the LDL cholesterol level, then you have to add another agent. Indeed, there are combination therapies, atorvastatin with ezetimibe, fix dose combination that can be given to the patient. Some patients, unfortunately, because of their high risk, if you're not getting to target, you may give ezetimibe to atorvastatin or rosuvastatin. You may have to add the PCSK9 inhibitor. So they have 3 drugs adding to the other medication that this patient, because it's important. Because if you don't do that, the patient still have high risk, then the chance that the person coming with an event is a bit high. So we need to really look at these patients and manage them very well. I mentioned earlier on atherosclerosis is a progressive disease. In between, if these patients are not managed well, they can have an event. So this picture tells us that we have Adade and Doku, okay? Martin, which one do you want to be? The one who had the risk factors controlled, or you select one. Okay, so let's say this is Doku. Okay, we all started with moderate risk. Now Adade had the risk factors controlled by his doctor, who is more concerned. He's lost weight, and he's lost a lot of weight since he left cardio. And so the chance of Adade getting an event is reduced. Alfred is not well controlled. His cholesterol is still high. Sugar is not controlled. Then the chance of getting a heart attack increases. I think we should all try to bring our patient to this green line here. We can choose to keep the patient still here or up there, but the best way is to bring the patient down. And so we need to manage them appropriately, lifestyle modifications, appropriate medications. We need to educate our patient. We are quick to write prescription for our patients. The patient probably doesn't understand what they are taking, why they are taking these medications. So it's important that we manage them appropriately. So to conclude, ASCVD is a common problem in Africa. It's the main cause of patient outcomes. The risk factors are there in the community, and these numbers are increasing. And if we don't do something about them, we're going to have more people dying from strokes, more people going to die from heart attack, and more people are going to have peripheral artery disease. So it's time to really address the issue. So I'm grateful for the opportunity to talk about this. The burden is in the community. The risk factors are there. We don't have the capacity. Okay? 2 days ago, I slept in my office at my age because we were called at 10 o'clock. By the time we finished, taking our patient, it was 2 a.m. We are not many. We have only few cardiologists here. So we need to address the problem in the country. And primary prevention, primordial prevention is key. Thank you very much.
Yeah, let's do it more. Let's give him a round of applause. Yeah. Yes, so with the overview of atherosclerotic cardiovascular disease done, we are now going to focus on some of the important diseases that this condition causes. Now, our next speaker is Professor Joseph Akama. He graduated in 1993 from UGMS, and he went to the United States to do his residency in internal medicine and cardiology, and he finished it up with interventional cardiology. He's a fellow of the American College of Cardiology, fellow of American College of Physicians, fellow of the Ghana College of Physicians and Surgeons, and he holds fellowship and membership of several professional societies. Professor Kama is going to speak on chronic coronary syndrome. Professor Kama. Yeah.
So, whilst they are connecting my computer, Doku revealed that my lifestyle changed. It did indeed change. Can you hear me? All right. Maybe I should stand here. What is recording? This one? Okay, so I had challenges. First, I don't believe in superstition. There's an echo. It's okay now. I don't believe in superstition. But when Dr. Esteemed mentioned that there's some superstition, I started thinking. So I left Nashville with my computer at the back of my wife's car, got to the airport, ran out to check in. By the time I could get back, she was gone. And it was traffic back home. She couldn't get her phone. By the time she got home to come back, my flight was about to leave. So I had to redo all of this, and the computer wouldn't allow me. One drive would not allow me. So I changed it to white color. You know, I've never presented with white color. You know, normally so white color is driving away the evil spirits and everybody. It's not. You haven't ever seen me with white, right? But I had to do that. Anyway, so we will discuss coronary artery disease. I made a coronary artery disease because the term is really huge. The stable, non-stable, Doku, which one? Yeah. Okay. Now the other man has beaten you. Yes. So somebody can do it for me, please. Can somebody do it for me? Can you change it for me? All right, that is good. So I have no disclosures pertaining to this talk in relation to Ghanaian Society and then also the Mehari Medical College. Next, please. So the topic will basically be discussed in these slides. Review coronary artery disease, stable and unstable, briefly, and not so much of unstable. I just mentioned it briefly. Discuss the diagnosis and risk stratification of patients suspected of having severe coronary artery disease. Review medical treatment, and then we'll also talk about the revascularization available in Ghana. Next. So this is a 73-year-old male who presented to Dr. Srebo after failing stress test. So he has the risk factors, TIA, hypertension, on guideline-directed medical therapy, blood pressure is controlled, heart rate is excellent, creatinine slightly high, he had an S4, and then he underwent stress testing, and it was positive. So they sent him over for further evaluation. Okay, EF was low. Next, please. So refer to Dr. Akama and team for coronary angiography and possible intervention, intensify medical therapy, recommend coronary calcium score. He is already high risk. He's on good medical treatment, so the next level is to assess his packet. If his packet is heavy, he goes for coronary angiogram. If his packet is not heavy, you stop there. Okay, don't raise alarm. You treat him medically. Okay, so this was his condition. Really, really severe. This is one of the angiograms for the left coronary artery. And here is the left main, the left circumflex, the left anterior descending artery. The left circumflex is subtotal and is failing from left to left collaterals. The LAD is also hanging on a thread. Next, please. This is a different view of the LAD. Next, please. The LAD shows a diagonal that is tight. This is a Medina 111 classification and very severe disease. Fortunately for him, there's not much of calcification. There's not much of calcification. Next, please. So we started injecting here. I think I was with Doku then. So I want you guys to tell me what happened next. Next. VF. So Prof. Jennings picked it.
This is what we look for when you are in the cath lab. Your eyes have to be trained and watchful. The reason why he went into VF was there was a disease in the ostium of the right, and the catheter was sitting there occluding the vessel. Conus was occluded. You can see the staining of contrast in the myocardium. This is a no-no. Okay? The next injection, you're going to cause problem. Okay? VF used to be very common in the older days because the contrast was heavy. Now the contrast is not. So mostly it is catheter-based, and this can kill the patient. Fortunately, we jumped on him, shocked him. There was no doom saw, so the machine worked, and, and everything went well. Next, please. So this is a Ghanaian. He's a Ghanaian. Last 3 months, I sent 3 people for bypass. One could afford, he picked his bag and went to US. But when he got there, he realized he made a mistake. The bypass would cost him an arm and leg. So he got to some Ghanaian doctors and they were able to do PCI, high-risk PCI. But others went to South Africa, India, and then Kolebu to do their bypass. So this is a serious condition. So don't belittle it. Don't say Ghanaians do not have CAD. So what is chronic coronary syndrome? Or the other term is stable ischemic heart disease. The other name will be chronic coronary disease. Whatever it is, you can name it. If you're European, this is what you name. And Ghanaians tend to go with the Europeans. If you're an American, you call it CCD. So if I interchange it, don't mind me. But it is a heterogeneous disease, but that encompasses any condition that results in a chronic or repetitive mismatch between myocardial oxygen supply and demand. And the myocardial ischemia most is due to atherosclerosis. That's why we're here. But there are other causes of atherosclerosis that you have to look for. Okay? Minoca. There is vasospasm. There is anomalous coronary arteries. Okay? There's LVH. Huge LVH can cause ischemia. So don't always blame it on, go back. Don't blame it all on atherosclerosis. Look for other things. There was a young lady, it was supposed to be part of this pictures, but it didn't show up. Zifa calls me. We said, do calcium score. Calcium score came back 8 or something like that. Okay? So this lady took the thing to the next level. She had class 4 angina, literally, to the level where she stopped working. Okay? So Zifa said, I'm done with you. Go see Dr. Kama for angiogram. After talking to her, I tried to get psychological counseling. The lady overtook me, landed in Accra, went to Bank Hospital, Ajekum cut her. Guess what? Clean. But she stopped working because we told her her calcium score was 8. Or she was already up there. Or was it vasospasm? You see, something like that. Such a person always look for these things. Next. So, history of cath lab in Ghana. Next. Yeah, just continue. So, I wanted to show this way there. I wanted to show this to see how things have progressed and the need for more specialization. So, before time, phase 1 cardiothoracic center, when it ended 2013, Dr. Tanko and Dr. Siribo were able to get a new cath lab. And that's phase 2. And that was 2016, September, to be precise. But before that, in between, Dr. Anaglate had an Indian purchased cath lab, and he was performing procedures. Then came Uracare. Uracare, I designed the cath lab. But guess what? The top professor came and kicked me out of the way. And I'll show you how he got me out of the way. Others, Kumasi Spectra, are helping design the place. Bank Hospital, in terms of the catheters and things, not the hospital, but the catheters. Bank Hospital, I designed the cath lab. UGMC, I designed the cath lab, gave it to Prof. Lawson. IMA, I have the blueprint of the original IMA was not supposed to be what it is now. I was supposed to be their cardiologist. So 3 hospitals were going to take me their cardiologists. Bank Hospital, UGMC, IMA. I had to pay school fees. I had to pay school fees. Then came St. Michael, then came Jeremiah Kretschy. So more are coming. Why am I mentioning this? But okay, so Jeremiah Kretschy, go to next. Jeremiah, let me conclude. This cardiologist traveled to Ghana to save the life of a man he had never met. Please, let's give a round of applause to Prof. Jenny. Look at the small print. It says, the hospital he arrived at didn't even have a place for doctors to scrub their hands. And I've been doing procedures there for 3 years. So I said, where was I scrubbing? But he was right. He was right. An epiglottis place is a hole in a wall. It's an American term meaning there's something going on, but it doesn't look nice. Okay? And he did a wonderful job with this patient. So Jeremiah Kretschy is a U.S. physician who has capability of doing echoes. And then he was able to start a program. So I think he has a cath lab. I haven't seen it. He has a cath lab. He told me. All right, next. So the procedures began and started coming to help Frimpong Boateng. Then Oliveira did 40. Doing interventions. They started doing interventions. Then 2014, that is when Carlos was around. He came back. He was able to do quite a number of interventions. 2 of them were filter. 2 came to coincide with my presence in Ghana. By that time, at the day, and to train. And see the number of procedures we started increasing. Okay. 2020, Prof. Jennings calls me and says, I had to go see my family. I said, you got to go. Okay, you got to go. And I moved to Uracare. Prof. Jennings, do you know the story was that I helped kick you out of Uracare? Nobody knew that we communicated, and he was the one who made me go to Uracare. So why do you spread wrong numbers and wrong information? So, but I knew that if Prof. Jenny is going to be coming back, he'll need a lot of helping hand. So I introduced Dr. Ajokum and then Dr. Adade to Uracare. And since then, they've been doing procedures across the country. Next. So that is the history. But the history doesn't end till you look at this presentation of Ajokum at the 46th WACP convention, where he was able to show these were the numbers we did. 779, 468 had significant, meaning more than 50%. How many did have disease but not significant? Quite a lot, but we don't have that number. So these are the things that we need to know. Next. So, next. So, West Africa falls here, and atherosclerotic disease is number 1. Leave it like that. It's okay. I need to go fast. Next. So, if you look at the map, West Africa is becoming colored. Okay, it's no more green. We're going to be moving towards the red colors. These are the high prevalence areas, and we're going to be going towards there. In the Western countries, they're becoming green because of statins. Prof. Jennings, how many STEMIs are you seeing now? Much less. When we're training, almost every day you see a STEMI. In Ghana, is the reverse. Okay, next please. So patients who have stable angina, stable coronary artery disease are not really stable. If you compare them to general population, they will die more than the general population. They will have problems more than the general population. In addition, you realize that, next, they usually may not come with sudden death, but they'll present with heart failure, unstable angina, severe hospitalization, and they will need coronary intervention. So it's not really stable. Next. So what happens, Dr. Doku mentioned this, so let me not repeat too much, but I will show you the fact that, next, atherosclerosis has different categorization, okay, 6 of them. It starts with the laying down of the foundation. Then you have the fatty streak. By the time you get fatty streak, it's too late. You can't stop it. Atherosclerosis is not stoppable. So you just have to control the risk factors. And at this stage, they can become very symptomatic. Okay. Next. So if you look at the complexity of atherosclerosis, you can't say it is stable ischemic heart disease. It's not stable. There's something going on. And the fellows need to know this, that the fact that the person is not symptomatic, he has 10% blockage, you have to take him serious. Okay, next. So you see the complexity of the disease. You have the lumen there with a very complex atheroma, okay, with a lot of calcification, some nodular calcification, and some can be very smooth, okay, without much calcification. So it's a range of disease. Next. This highlights the Glagoff phenomenon, where when you start having a blockage, the lumen gets bigger. When you start having a blockage, the lumen gets bigger until the disease burden is about 40%. When it's 40%, the lumen begins to get narrow. So that's the Glagoff phenomenon. So at this point, there is good compensation. The person will not have symptoms. But as soon as they pass the 40%, then they get more blockages. Next. I'm going to really speed through. Prof. Also is gesturing to me. Don't give me a big topic and then give me 1 minute to talk. Anyway, so, so it is a milieu of different things. Next, please. Next. So who are the people who get into trouble? We want them to stabilize. The people who get into trouble are the vulnerable plaque. Okay, these are the characteristics of vulnerable plaque. Next. So angina is the commonest presentation, but it's not the only presentation. There could be other presentations, sudden collapse, especially stable coronary disease, heart failure, left atrial, mitral valve regurgitation. When we do the echo and say ischemic cardiomyopathy, most likely it is because of the mitral valve. So they can present, don't say it is right-sided, so it's not. Next, please. Pathophysiology is ischemia-driven, okay, ischemia-driven with cytokine, chemokine production. Once ATP goes down, there's chemokine production, and the person will have chest pain. But it's a visceral pain. That's why you can't localize it. Next. So chest pain comes very, very late. Next. Classification of angina, let me not belittle you. You know all the steps. Don't go back one step. We try to move away from typical and atypical chest pain. Rather, use cardiac, non-cardiac chest pain. Next. So, differential diagnosis, non-ischemic heart disease, pulmonary disease, GI, chest, dermatological problems, musculoskeletal. In the outpatient, musculoskeletal is #1 differential for chest pain. Next. So the type of pain can dictate whether you should take the person serious or not. Okay? The person goes for a funeral, has a fleeting, go back one, has a fleeting chest pain, you ignore it. But you don't send them away. That's what I see a lot of young doctors do. The person came to you for a purpose. Don't say your ECG is normal, go home. Counsel, reassure, bring the person back. at least he'll pay you for your Momo charges, okay? And there you can take it there. Next. All right, next. We wouldn't go into this. So go next. So these are the factors you need, but mostly it is age. Mostly it is gender, a true man, and also type of chest pain, okay? So if the type of chest pain is angina and the person is old, take him serious. Don't ask, oh, I need to do stress test. Just treat him, okay? If it's a board question and they say, what is the next step? And the story is clear, please treat the patient. Next. Okay, so we know about the Forrester and Diamond classification of, using age, sex, and gender to and a type of chest pain to tell whether the person has a high propensity to having CAD. So if the person is old, he's a man, and he has typical angina 94. It is not, can I diagnose him? You've made a diagnosis. It is now, how can I prognosticate him? So if you do a stress test, it's not to diagnose, it's to prognosticate. Next. All right, this is in our guidelines. I was the lead author for this with Dr. Adade for the, so if you revise, this is one of the documents you should use for CAD and all the cardiovascular diseases, and obviously the US and then European guidelines. Next. Next. How many more minutes? 5. Okay, so I can slow down. All right. Okay, so risk stratification is very key. Next. If you risk stratify and the person has 1 vessel disease, the survival is good. If the person has 3 vessel disease, the survival is abysmal. Next. So this is a 65-year-old gentleman and a went stress test. 3 minutes, we had to stop it. And then in 7 minutes into recovery, he's still having problems. Show me the ECG. So if you, go back, please. If you have a normal baseline, you can do stress tests. And the truth of the matter is we're not privy, we don't have the privilege of having different stress tests in Ghana yet. The nuclear guys said they will do something, yeah, I don't know where it will happen. Here is the SC depression that you're looking for. Before, after. And he's still having problems. This is what you're looking for. Next. So what are the things to look for when you do a stress test? How soon he got positive ST depression? How long it took to go away? Okay? What was his blood pressure before and after? If it drops his blood pressure, bad outcome. Okay? If the ST segment is deeper, bad outcome. So those are the prognostic things that you're looking for. Next. So make sure your the techs who are here and the nurses, make sure you apply it properly so there's no artifact, because we need to know this ST depression. Next. So we know all about this. If you do a normal group of patients, the younger you are, the faster your heart rate. Okay? The older you are, like Doku and myself, we can only clock some amount of heart rate. Okay? Next. So there are different stress tests we can do, and even with the Bruce protocol that we use commonly in Ghana, you can have a modified Bruce for older people or somebody who is just lazy. You want to encourage an MP. The other day I changed you for an MP. I said I wanted to encourage him. Honorable. He did 10 minutes. Bruce, in my mind, is not much, right? I said, you did well. Start exercise. But you could use other things. If the person cannot exercise, we could use bicycle. Okay, next. All right, so this, we talked about this already. Don't say it is upsloping so you don't think about it, okay? The best one is the classic flat. Downsloping, upsloping, but mostly the upsloping ones we can dismiss if it is not very persistent, okay? But the flat and downsloping are the dangerous ones. But don't still miss the upsloping. Go next. Okay, We know the Duke score. Next. So we have additive information if you do exercise with imaging. Okay? So I think we've done myocardial perfusion at the day and night with the fellows. We tried using the bitumen, but it's so tedious to do. Very tedious. But I think now that we're so confident in echo, let's start venturing into getting exercise echo. But it's tough because you have to have the software. 2, you have to image the heart when it's very fast in 90 seconds. All the 4 quadrants, okay? Parasternal, short axis, apical 2, and apical 4 in 90 seconds. And the machine captures these as it's going on. So if you stay at one point, it will going to capture all the 90 seconds with that place. So it's a tough one. So the exercise stress test is not very good, but that's all we have here. So choose your patients very wisely. Next. All right. So this is about calcium score and then coronary angiogram. Dr. Doku mentioned that it is not good. So rarely, the fellows who tell you, I rarely use coronary angiogram. This is from Dr. Odoi's lab. Most of these patients were mine. Okay? I sent them to him. We started doing this, and I spoke with Frimpong, and then he also started doing them, and then he published his before us. But it is about the same. Okay? It's about the same data. It is prevalent. Next, you realize that if you look at the age, it goes. The older you are, the more calcium score you have. And then, sex-wise, males have more calcium score. Next. In terms of screening, we expect this to be a good screening tool because it is negative a lot of times when you can tell the patient you're sending for. Unlike Dr. Zifais has this patient who maybe the calcium score made the person really, really sick. Okay, so you need to know how to release the news to the patient. Next. Okay, so management, I'll just brush too quickly. Next. Treatment works. Treatment works. But it's not from you, maybe from God. But the patient, that's the key. So this is a very interesting professor who I did an angio. She was my patient. I did a stress test, calcium. She had calcium score, went for CT angio. Then we came for this. She won't stop disturbing. So we finally said, okay, let's go for this. The calcium score and CT angiogram said severe LAD. But rather, it was the circumflex. So you can see the disease there. And then we said, should we treat you or we should put stent? She said, no, I'm going to try medications. And last year, Dr. Adade performed an angiogram, and guess what? What did she do? She changed her lifestyle completely. She was not tolerating statins. I used ezetimibe with very low dose Crestor. She became a director of glycemic index, teaching her family members, lost a lot of weight, walked every day, and there was a randomized controlled trial. Her husband also started having chest pain. I will conclude soon. Unfortunately, calcium score showed 3-vessel disease. He refused angiogram because he was supposed to go to cerebral. I knew the way he had. His blood pressure was low. So we treated him conservatively. Dr. Adade, you know the story. Yes, he had massive heart attack and passed. The young lady is still walking around, and whether she... Okay, Prof. Chairman will answer that. Okay, so let me just conclude quickly. Go next. So medical treatment plus revascularization or without revascularization works. Okay, so your goal is to modify the person's lifestyle and then to make the person live longer. Next. So think about the global approach. Next. Improving quality of life, listen to the patient and work with the patient. So don't jump to the high levels, okay, use the basics. If the person is using Viagra, you can't help it. You have to go to these medications. But if it's not, beta blocker, CCB, and you can control the heart rate. You can decrease the heart rate further if the blood pressure is not allowing beta blockers and CCBs. You add avibradine, and the person will feel better. Then you reserve this. Next. So we know the effects of these medications will increase coronary flow, decrease heart rate, fertility, myocardial utilization is improved. These also help fatty acid oxidation inhibitor. Next. Next. Don't forget about your dual antiplatelet or single antiplatelet. Mostly it's a single, but if they are on dual, you have to know how to manage them. Next. Statins must be emphasized. The goal is to drop to 1.8. And Europeans are pushing it to less than 1.4 if the person has some problems. Next. I'm going to just show you an angiogram, and then I'll conclude. Next. So this is the gentleman I showed you. He was turned down for surgery. He didn't want it, but he preferred PCI. And he already died on the table, and we brought him back. So when he came, we had to do high-risk PCI. Next. So we realized that he was also becoming bradycardic. Okay, so we'll put a pacemaker. Next. Yep. So next. So this was his anatomy with a guide catheter. We stented the LAD, stented the circumflex. Next. Stented the LAD. Next. Stented the next. So you see circumflex is now open. LAD is open. Beautiful. And then we brought him back. You see there's a pacemaker in there. That was our highest level of support, Dr. Prof. Jenny. That because our balloon pump was not in working order. Next. So this is to conclude, PCI is not a panacea. It's not. It's expensive, the least to say. The man ran away before I could say this. We had to do something about this. Okay? Next. But I will send him the message. We need these added tools to make the work of Ajekum, Adade, Doku, and everybody who is coming up easier to support the patient. Next. Okay, so I'll conclude here by saying next. Angina might not be present, but a person may have other symptoms. It may be incidental. Okay? Know how to risk stratify the patient. We need training and capacity building. We don't need general cardiologists. At this point, we have how many general cardiologists? Too many. We need to go to the next level. Who is the CCU consultant that a person will not die from shock? Who is there? We need somebody, a critical care cardiologist, so that if we do PCI and the person is sick, the person can leave. Okay? So we need that. We need the technicians to help us. Some of them are afraid. They don't even know what you're doing. They can't even recognize the VFib. So you become a dangerous operator. Prof. Jennings, how is our technician at Dr. Anaglate's place? Okay? Yes. So these are things that we need to do. Okay? Thank you very much.
Good. Yes. Thank you, Professor Kama, for an excellent presentation. I'm sure we have many questions. So let's jot down our questions. There will be time for Q&A. For those who have joined us online, they should also put their questions on the chat box. When we are taking the questions, they can be addressed. Before we move on to the next presentation, we want to have a short presentation from our gold sponsor, AstraZeneca. Do we have the rep? Yeah. So 10 minutes, please. We are a little behind time. Then let me also add the LOC. Let's try and get a committee to draft a communique. We have to have a communique at the end of this AGSM. Our guest of honor has given us the opportunity to present something, and I think we can use that, and we also publish it. So the chair for LOC, let's take note of some of the issues that are coming up. I think some of the suggestions from Kama can be looked at. Okay. So as we sort out IT issues with the gold sponsor, let's take our third plenary presentation, and this is going to be given by Professor Mayowa Owolabi. He is a fellow of the National College of Nigeria, that's fellow of College of Physicians, and fellow of the West African College of Physicians. He's a consultant, neurologist, and he's been involved in a lot of research activities, and he has several publications to his credit. He is going to present on carotid artery disease and stroke. Professor Owolabi, over.
Thank you very much. Thank you very much, Professor Owusu. Thank you, Dr. Colin Kokuro. Thank you so much. And yeah, okay. Also thank the guest of honor in absentia. Thank you so much for the opportunity to be here to talk about carotid artery disease. The theme of this lecture, okay, yeah, I'll just go straight to my own slides. Let me try to advance the slide. Let's see. It's not moving. Can you help me advance it from there then? It's not moving. Okay. Okay. Okay, thank you very much. All right, so non-communicable diseases, as we all know, are now the leading cause of death globally. 74% of all deaths globally. That's 7 out of every 10 deaths. And 77% of them are in low and middle income countries. And is the fastest growing cause of death among NCDs are actually neurological conditions, out of which stroke costs almost $900 billion per annum globally, and dementia costs $1.3 trillion as of 2019. In the last 30 years, neurological conditions, including stroke, have increased. The number of deaths from neurological conditions, including stroke, have increased by more than 40%, and stroke remains the second leading cause of death globally and the third leading cause of disability. Now, in Africa, before, that was in 1990, this is GBD data, you would see that respiratory infections, TB, enteric infections, and all of that were the leading causes of death. But since 2019, this has changed. Cardiovascular diseases have become the leading cause of death. And of course, this is essentially atherosclerotic disease. Now, when you look at the trend between 1990 and 2019 on the global scale, looking at incidence, looking at prevalence and deaths, you will see that in the last 3 decades, there have been a 70% increase in the incidence, 85% increase in the prevalence, and 43% increase in deaths from stroke. And like we said, most of these are in LMICs, including countries in Africa, which are actually most affected in terms of disease burden. This is from the Lancet Commission on Stroke, which I shared. It took us about 6-7 years. The publication was launched last year, which coincided with the 200-year anniversary of the Lancet. Now, you would see that when we looked at the trend from 2019 up to 2050, we worked with the GBD group. You will see that it's projected that the number of deaths from stroke worldwide, which was 6.6 million deaths annually in 2019, will increase by almost 50% to more than 9 million deaths annually by 2050. DALIs are also going to increase. Now, about 12.2 million new cases of stroke are occurring every year. And 1 stroke is occurring every 3 seconds globally. And in Africa, every single minute 6 Africans are developing a stroke. And of course, we know the leading risk factors, which we are still going to talk about. They've been mentioned today. So when you look into the future, you'll see that the costs, the annual cost of stroke has been projected to almost $2 trillion per annum by the year 2050. Now, when you look at strokes generally, that's globally now, not in Africa specifically. 88% of strokes are ischemic. Only about 2 to 5% subarachnoid hemorrhage and 10% intracerebral hemorrhage. But in Africa, that is not the case. In Africa, from the Siren study, about 63 to 64% are actually ischemic stroke, while there are mixed. There are some patients who have a combination of ischemic and hemorrhagic stroke, and hemorrhagic stroke is about a third, about 33 to 35% of strokes. Now, among ischemic strokes, of course, we know there are lacunar strokes, there are non-lacunar strokes, and there are cryptogenic strokes. So ischemic strokes, one of the main risk factors for ischemic stroke, of course, is carotid atherosclerosis. 1 out of every 3 strokes, particularly ischemic stroke, is due to carotid atherosclerosis. When plaque reaches about 50% of the carotid lumen, it induces hemodynamically significant carotid stenosis, and for which management is currently at a turning point. I would explain what happens at the gray zone between 50 and 69%. I will talk about all of those later on. So the truth of the matter is that you can actually reduce the chances of developing a stroke to less than 1% if you deal with that carotid atherosclerosis in terms of controlling the risk factors. If in this study you see that those who smoked, who had a high blood pressure, who had LDL cholesterol above 100 milligrams per DL, who are not on statins, those who are the group 1, you can see they have a very high risk of stroke, TIA, or carotid revascularization, about 3.5%. And carotid stenosis progression also about 2.5 to 3%. But for those who are not smoking, whose blood pressure are controlled, whose SDL is down, who are on statin, you can see that their risk can be as low as 5% or even less than 5, actually less than 1% in terms of developing stroke, TIA, carotid revascularization, and progression less than 5%. So it's treatable. This has been discussed, so I'm not going to go into the pathogenesis of carotid atherosclerosis and the phases. I will just take you through some of the work that we've done in Africans on carotid atherosclerosis and the biomarkers of carotid atherosclerosis. You know, today we also talked about risk calculators. So we looked at risk calculators, the Framingham's risk calculator and the Omnibus risk calculator. And we found that carotid intima media thickness is actually a stronger predictor of stroke occurrence, even after adjusting for AHX, blood pressure, cholesterol, and blood sugar. Although the confidence interval was wide, probably because of the smaller sample size. These were just preliminary studies we did. But the odds ratio is as high as 11.71. So CIMT can help as an aggregate risk marker, at least in blacks, for risk of stroke. Bilaterally, we found that CIMT was significantly different from the 3 cardiovascular phenotypes. We looked at those who are hypertensive, those who are normotensive, and those who have had stroke. And CIMT was a very strong predictor. And if you look at the odds of being hypertensive versus being normotensive, we also saw that CIMT increased the odds by 3.47, and the odds of being a stroke patient versus normotensive by 5.95. Both on the left as well as on the right carotid. Now, the other thing we found was that CIMT improved the C statistic for proper classification when you are trying to compare hypertensive patients with stroke patients, or normotensive patients with hypertensive patients, or stroke patients with normotensive patients. So CIMT is probably something we should at some point be measuring routine, stronger than any risk calculator that we can do. And now with a point of care ultrasound, which over time is going to become more available, it might be something that will be part of what we will be doing in the routine clinic assessment of patients who have multiple vascular risk factors, as a way of checking their risk factors and aggregating their risk factor, the overall risk factor, and risk of developing a stroke. Now, we looked at the risk factors also for the carotid intima media thickness. And you will see that most of the risk factors, of course, include age, include male gender, include systolic blood pressure, diastolic blood pressure. Weight was also significant. BMI was actually not, but waist circumference was significant. Waist height ratio was significant. Fasting plasma glucose, fasting total cholesterol, and positive history of alcohol consumption and cigarette smoking. So if you address these risk factors, you are likely to reduce the chances of increased CIMT. That's not even yet plaques and a stroke occurring. But to make the CIMT to remain normal, if you address these risk factors, you are likely to maintain a normal CIMT. Okay, this angle. Okay, so we also explored different carotid sonography parameters that can be used to assess the risk of stroke. We looked at stroke patients we compare with hypertensive controls. One thing we found was that apart from CIMT, in fact, better than CIMT, we found that internal carotid artery diameter of greater than 6.3 millimeters was a risk factor. About 8.91. It increases the risk by about 8.91 in terms of odds ratio for all patients. For when you look at stroke patients and you exclude those with plaques, is about 8.91 and 7.18 for all stroke patients. So carotid diameter and carotid intima media thickness are some of the things we found. Then there is this interesting observation. We found that the relationship between flow velocity and vessel diameters in the anterior and posterior circulation were different. We're actually the first to discover this. We've not explored this further. You will see that there is a negative correlation between systolic and diastolic velocities compared with, that's the flow velocities. The correlation between flow velocity and vessel diameter was inverse in the anterior circulation, but was direct correlation in the posterior circulation. That's the vertebral arteries. And that's what is displayed there. I think it's hanging. Oops. Can you please help me change? Okay, now it's moved. So carotid artery disease and stroke, post-stroke carotid ultrasound. Now, in the past, it was thought that carotid artery disease is not common in Africa. Okay. It's not common in Africa, and that Africa probably has the lowest number globally. Large vessel atherosclerosis, ischemic heart disease, they were very uncommon. That was in the past. And they were also not very common as causes of stroke. The African region had the smallest share of cases of increased carotid intima media thickness, in the GBD studies. But that was in the past. This has since changed. Carotid artery disease and stroke in Africa, now in 2024, things has changed because of epidemiological transition, because of aging, and of course, availability of equipment for screening. So in the Siren study, we investigated stroke rigorously. We looked at the risk factors, checked the carotids as well, and I will tell you some of our findings. We found that in patients with ischemic stroke, about over 800 patients with ischemic stroke who are a subset of the Siren study, 84% of them had CIMT. So it's very common now. And 26% of them, over a quarter of them, had plaques. So it's no longer what it was thought to be previously when it wasn't common. And those who have HIV, this is another study, those who have HIV are also at a higher risk of developing carotid atherosclerosis. Of course, those who consumed alcohol, who had high cholesterol are also at a higher risk. I think this is hanging. Okay. So I already mentioned that HIV is one of the factors that increases the chances of developing thickened CIMT and also increased risk of stroke. Okay, so now let's look at patients who have carotid artery disease. Those who have symptomatic carotid stenosis, they require antithrombotic medications, aspirin or clopidogrel, or a combination of both in those who have already suffered a stroke. Anticoagulation therapy is not routinely recommended unless they have a concomitant atrial fibrillation. Now, endovascular therapy can be in form of, endovascular therapy is not routinely recommended. But carotid endarterectomy, which is one of the ways you can deal with this, is recommended in those with stenosis of 70 to 99%. And in those who have asymptomatic carotid stenosis, you also have to look at other factors in deciding whether they should have carotid endarterectomy or angioplasty and stenting. I'm going to show this in how to decide between patients in subsequent slides. So, but this is how to investigate patients who have suffered a stroke. This is from the American Heart Association guideline on secondary prevention of stroke. And of course, for patients who have a stroke, you want to evaluate them to know whether they have carotid atherosclerosis. Cervical carotid imaging can be by CT angiography, by MR angiography, or it can be by ultrasound. That's a class 1 recommendation in those who have ischemic stroke and you're trying to identify why they have that ischemic stroke. I think this is not connecting well. I think the battery might be very weak, so it's not functioning properly. Okay. I don't need to go through this. This is how to use the Doppler ultrasound to determine the degree of stenosis. Okay. Back one slide backwards, yeah. So ultrasound imaging, features associated with increased risk in patients with asymptomatic carotid artery stenosis. Those who have a contralateral TIA or stroke, those who have ipsilateral, okay, maybe this will be better. Do you want me to try it? Oh, no. Yeah, this is better. Excellent. So those who have large plaques, echolucent plaques, and then those who do on MR angiography, those who have intraplaque hemorrhage, lipid-rich necrotic core. This has been discussed already by the last speaker. So, and I'm grateful for that. Now, for patients who have a recent stroke or TIA, this is how to proceed. They should have imaging of the carotid artery, or, by duplex ultrasound, CTA or MRA. And if it shows that they have occlusion or near occlusion, then there is a class 1A recommendation for intervention. Now, for those who have 70 to 99, that's best medical therapy. Now, for those who have 70 to 99% carotid stenosis, who have had a stroke, who have 70 to 99% stenosis, they should have carotid endarterectomy combined with best medical treatment. That's a class 1A recommendation. For those who have between 50 to 69% carotid stenosis, they should have carotid endarterectomy or plus best medical therapy should be considered. In these cases, they are only to be considered, and I'll give reasons when they are recommended and when they are considered. If it's 70 to 99%, of course, they are supposed to be done. But there are conditions for doing them in this circumstance. Now, for those who do not have stroke, meaning they are asymptomatic, whose stenosis is between 60 to 99%, whose life expectancy is more than 5 years, then they should have carotid endarterectomy plus best medical therapy should be considered. But if carotid stenting and BMT may be considered, but for endarterectomy, which is considered safer, should be considered. I'm going to tell you the reasons for this in subsequent slides. Medical therapy includes antiplatelet statins or a combination of both. There are a lot of studies that have looked at asymptomatic carotid stenosis. I will not be going into details, but the current recommendations for asymptomatic carotid stenosis between 70 to 99% carotid stenosis in women whose life expectancy is less than 10 years use just best medical therapy. If the life expectancy is more than 10 years, with or without stroke risk factors, use best medical therapy and consider carotid endarterectomy or stenting. Now for men who are less than 5 years, with or without stroke risk factors, use best medical therapy and consider carotid endarterectomy or stenting if they are asymptomatic and the stenosis is critical stenosis. Now for those who are older than 75 years, older than or equal to 75 years, whose life expectancy is less than 5 years, only best medical therapy. But if the life expectancy is more than 5 years, with or without stroke risk factors, use best medical therapy and consider carotid endarterectomy or stenting. Now for intracranial stenosis, stenting and interventional procedures are not recommended. It is just best medical therapy. Optimal medical therapy for carotid artery stenosis, of course, I already mentioned, is antiplatelet therapy, usually aspirin or clopidogrel, or a combination of both in patients who have had a stroke. Antihypertensive therapy to reduce blood pressure to 140/90 or less. Statin therapy to reduce LDL cholesterol to less than 100. They say less than 70 in patients with diabetes, but there is something we found in the Siren study. Those who have an LDL level of less than 70 are likely, if they develop hemorrhagic stroke, they are likely to have a severe form of hemorrhagic stroke. So we might not go as low as that. Of course, controlled diabetes and smoking cessation. If there is tandem occlusion, acute ICA intervention could be done or it could be deferred, and those are the reasons that will guide you. Now, for clinical and radiologic factors influencing the decision to favor acute stent placement or no stent placement for patients with tandem lesions, there are several criteria that can be used. Stenting is preferred if there is atherosclerosis, but if there is dissection, of course, you can't go ahead with stenting. If the infarct is small and there is high aspect score, then you can do stenting. But if there is already downstream damage to the brain that is significant with a large aspect score, then there is no point going ahead with stenting. If there is poor collaterals, incomplete circle of Willis, then of course stenting may be useful. If there is active reocclusion, stenting may be useful. If you have not used IV thrombolysis, stenting may be useful. If there is very high risk of systemic bleeding, meaning you can't be very aggressive with medical therapy, then there's a lower risk, and that favors stenting. Indication for long-term anticoagulation, if that is absent, that also favors stenting. That helps you to decide. So in those who have severe stenosis who are asymptomatic, just to summarize, and they have a high risk for stroke, if they are asymptomatic and they have a high risk for stroke, then if they are asymptomatic, they have a high risk for stroke. Procedural death, if the procedural death or stroke risk is less than 3%, then you can go ahead and do endarterectomy or stenting. But if the procedural death or stroke risk for the procedure is higher than 3%, then it's conservative treatment. For those who have a high risk of stroke, who do not have a high risk of stroke, then it's just conservative treatment. Now, for those who have severe stenosis, who are symptomatic, and procedural death or stroke risk is less than 6%, then endarterectomy or stenting. But if the procedural death or risk of stroke is greater than 6%, of course, it's conservative treatment. Now, for those who have non-severe stenosis, who are asymptomatic, is conservative care. For those who have non-severe stenosis, who are symptomatic, procedural death for stroke is less than 6%, then, or stroke is less than 6%, then endarterectomy or stenting. So this summarizes what we do when carotid atherosclerosis has occurred. And of course, this is how endarterectomy is done, and this is the procedure for stenting. Yeah, thank you very much. endarterectomy is safer in those who are less than 80 years. As you can see, perioperative stroke is 1.9%, but is higher in those who are older than 80 years. Perioperative death is also higher in those who are older than 80 years. And the secondary outcomes, of course, is also better in those who are less than 80 years. So I won't go into details about that. So I'll talk a little bit now about pragmatic solutions to reduce the global burden of stroke, the Lancet Commission. And we came up with 4 pillars, which actually could be applied to all NCDs and indeed to atherosclerotic vascular diseases. And the first pillar, of course, is surveillance, meaning we need to count the numbers and be able to monitor the burden of not only carotid atherosclerosis, but also the risk factors. The second one, of course, is prevention, which a lot of us have spoken about today. The third pillar is acute care pillar. What should you do after the atherosclerosis has occurred or stroke has occurred? And of course, the fourth pillar is rehabilitation. And we also went into details about the primary prevention of stroke worldwide. This was in Lancet Public Health. And from the Siren study, we identified the risk factors: hypertension, dyslipidemia, which is second in rank in terms of population attributable risk here, diabetes mellitus, cigarette smoking, stress, cardiac disease, raised weight ratio, high meat consumption. Then we found something very interesting about monthly income. Those who had a monthly income between $100 to $250 were at a higher risk. Perhaps that affected sedentary lifestyle and their diet. Regular physical activity prevented stroke, protected against stroke, as was the regular vegetable intake. Of course, there are also genetic considerations. We found that those who consumed vegetable on a daily basis, this data is from Ghana and Nigeria, so it should be of interest. Those who consume vegetable on a daily basis were at a higher, were better protected against stroke compared to those who consumed weekly, with non-overlapping confidence intervals. So green leafy vegetable we found protected against stroke, hemorrhagic stroke, ischemic stroke, stroke in the young, in the old, in males, in females, severe stroke, stroke risk factors. We still don't know the mechanism. And we've also found that those who consumed 12 servings of vegetables per week were at a lesser risk of being hypertensive. And this is something that I'm sure is ubiquitous and is not expensive. So whatever we're doing for vascular health is also going to improve brain health. And it is achievable. There's a brain health and vascular health policy in Norway, which could be an example. Between 1990 and 2019, they were able to reduce the incidence of dementia by 5.4%, but more importantly, incidence of ischemic heart disease by 30% and incidence of stroke by 35.3% by prevention. So prevention is important. Primordial prevention, primary prevention, secondary prevention. Now, today we're talking about atherosclerosis, which causes stroke, ischemic heart disease, which are the leading causes of death globally and going to remain so for the next decades, the next 50 years. They're going to remain the leading causes of death. And they can be prevented by dealing with the intermediate risk factors like hypertension, obesity, pre-diabetes, diabetes, dyslipidemia. Then we can take a step back, and I think we discussed some of these today. These are not modifiable though, age, sex, genes, but there are political, legal, ethical, anthropological, and socio-educational, economic, and environmental risk factors, which we call PLIS. And one of the main risk factors, which is economic, is also commercial. It's been said that was last year. There was a series in the Lancet on commercial determinants of death. 1/3 of all deaths are from the commercial sector, from air pollution, from the oil industry, from the tobacco industry, and from the alcohol industry. Account for 1 out of every 3 deaths globally. So, and these are some of the things we need to look at. We need to look at tobacco, stress, air pollution, diet, alcohol, physical activity. Before we can prevent. There are genetic factors, some of which we've unraveled. This is the role of microRNA. This just got published from the Siren study, and Ghana was part of these as well. So primordial prevention, including LDCTs, including tobacco control, primary prevention, secondary prevention, using task shifting, mobile health. working with at the primary healthcare levels. These are all very important. And this has been mentioned today. The conference, which was also attended by Dr. Kokuro, is the accelerating African control of hypertension through innovative epidemiology and vibrant ecosystem. If we deal with hypertension, we are going to be able to control most of these prevent most of these outcomes, these deleterious outcomes. The target is to increase detection by 80%, and among those who are detected, increase treatment by 80%, and among those who are on treatment, increase control by 80%. And this is in collaboration with the World Health Organization, World Hypertension League, International Society for Hypertension, and so on and so forth. And this conference was attended in person for the 2 days of the conference by the Honorable Minister of Health of Ghana, and this is our communique that's published in Lancet as well. So population-wide strategies are very important. Reducing inequities in social determinants of health, reducing air pollution, healthy living spaces, good diet, nutrition, legislation against smoking, levies on alcohol, salt reduction programs, stroke awareness and education campaigns, risk factor screening, stratification, and lifestyle control. So it's important maybe at some point to be able to also do CIMT at the bedside or in the clinics. There are need for large population-based studies to determine age and gender-specific CIMT thresholds. Most of the thresholds we use are from the Caucasians. So more advanced methods of assessing carotid artery disease, with, like I mentioned, POCUS, which is pockets, point of care, ultrasound, CT, MRI. There are portable MRIs now, and even CT in ambulances. Genetic studies on carotid artery disease in Africans. So all of these are very important. So extracranial carotid artery disease is an important and preventable as well as a treatable cause of stroke. Patients with severe stenosis ipsilateral to a non-disabling stroke or TIA who are candidates for intervention should have the stenosis fixed, likely relatively early after their ischemic stroke, because if you delay more than 2 weeks, the chances of a better outcome compared to not fixing it is less. Patients with severe stenosis in the vascular territory of the ischemic stroke, you should consider angioplasty, stenting, and endarterectomy. So aggressive medical management of risk factors is important. Short-term dual antiplatelet therapy in those who have had stroke. And several studies in secondary stroke prevention have indicated that. So it's now considered reasonable to percutaneously close PFO in those who have PFO. So thank you so very much for this opportunity. Yeah. So just wanted to end with, okay, they've taken that out, with a picture of the launching of the Lancet Commission on Stroke. Thank you so very much.
Okay, thank you very much. Yeah, let's give him another round of applause. Yes. Very soon we'll have the Q&A sessions. AstraZeneca rep, are you ready? Yeah, so 15 minutes. And he will be followed by another presentation from our sponsor, BI. So the presenter should also be ready. Okay.
Good afternoon, everyone. My name is Kweku Apia. I'm a pharmacist with AstraZeneca. And at AstraZeneca, we believe in pushing the boundaries of science to deliver life-changing medications for patients globally. That's why we keep on partnering with societies such as the Ghanaian Society of Cardiology to improve the outcomes of our patients in Ghana. So I'll be presenting on the role of Forxiga beyond HbA1c control. I'm just here to reiterate what we already know. So from the DECLARE-TIMI trial, which was a landmark cardiovascular outcome trial to prove the cardiovascular safety of Forxiga in type 2 diabetic patients. Over 17,000 patients were recruited in the study. 40% of the patients had type 2 diabetes with an established CVD, and 60% of the patients had type 2 diabetes with comorbidities, with multiple risk factors. It was a randomized control trial, double-blinded, 1:1, Forxiga on the other arm. as compared to placebo in patients who are on the standard of care for type 2 diabetes. Looking at the primary endpoint for the study, the primary safety endpoint, looking at a 3-point MACE, so a composite of cardiovascular death, MIs, and strokes. So with there's results from the primary safety endpoints in regards to 3-point MACE. Forxiga showed non-inferiority placebo, meaning Forxiga was not causing any further cardiovascular adverse effects in our type 2 diabetic patients. Now moving on to the primary efficacy endpoints with regards to the composites of cardiovascular death and hospitalization for heart failure. With a hazard ratio of 0.83, there was a 17% reduced risk reduction in favor of Forxiga, and this was statistically significant. And also look at the secondary endpoints with regards to the renal composites. Forxiga also showed superiority in regards to slowing down progression to nephropathy. So that's where we realize the cardio-renal benefits of Forxiga in our type 2 diabetic patients. Hence, we thought it wise to delve deeper to assess the effectiveness of Forxiga in our heart failure patients with reduced ejection fraction, with or without type 2 diabetes. So that led to the DAPA-HF trial, which was also a landmark cardiovascular outcome trial, recruited out 4,744 patients. With the inclusion criteria were above 18 years of age, with or without type 2 diabetes. Patients recruited were in New York classification between 2 to 4 and eGFR of 30 ml per minute. With the primary endpoint for the study, we're looking at the composites of worsening symptoms of heart failure and cardiovascular death. And worsening symptoms of heart failure was defined as urgent HF visits and rehospitalization for heart failure. And it was a randomized control trial, double-blinded 1:1, Forxiga on top of the standard of care. So patients were on baseline MRAs, beta blockers, and ARNIs as compared to the standard of care. So these were the secondary endpoints. We're looking at a composite of CV death and hospitalization for heart failure, number of CV deaths and hospitalization for heart failure, change in the baseline KCCO score. We're also looking at all-cause mortality. So these were the inclusion and exclusion criteria. And also it's worth to know that majority of the patients in the DAPA-HF trial did not have type 2 diabetes or heart failure. So we had 55% of the patients had heart failure with no type 2 diabetes, and 45% had type 2 diabetes with heart failure. So from our results from the DAPA-HF trial, there was a 26% reduced risk reduction in favor of Forxiga. So patients who were on Forxiga on top of the standard of care had a 26% reduced risk of either developing cardiovascular death or having worsening symptoms of heart failure. And this was statistically significant with a number needed to treat of 21. And it's worthy to note that looking at the Kaplan-Meier curve, the curve started to separate as early as possible and continue to diverge. So this showed the evidence of Forxiga as early as 28 days in your heart failure patients. Now, looking at the subgroup analysis of composite of the primary endpoint. So taking just worsening symptoms of heart failure, there was a 30% reduced risk reduction in favor of Forxiga, and moving to cardiovascular death, there was an 18% reduced risk reduction in favor of Forxiga, and this was all statistically significant. Now looking at this forest plot, you could see that Forxiga showed benefits in worsening symptoms of heart failure as well as CV mortality. So they're all in favor of Forxiga. Looking at the forest plots, all moving to the left from the central line of unity. So that shows the benefits of Forxiga in cardiovascular death and also worsening symptoms of heart failure. So going to the secondary endpoint, taking the composite of CV death and hospitalization for heart failure, there's a 25% reduced reduction in favor of Forxiga. Also looking at the number of HHF and CV death, there was also a 25% reduced reduction in favor of Forxiga. And also looking at the health status assessed by the change at 8 months in KCCO score, it showed that patients who were on Forxiga were 18% more likely to have symptom benefits with a win ratio of 1.18. And also, the patients who had symptom benefits, it was more common in patients who were on Forxiga, and also deterioration was less. So when you look at the odds ratio, patients who were on Forxiga had a 1.15 odds of symptom benefits as compared to patients who were on Forxiga. And also, there was a 0.84 reduced odds of symptom deterioration in favor of patients who were on Forxiga as compared to patients who are on Forxiga. With regards to all-cause mortality, in the DAPA-HF, we also proved that Forxiga showed a 17% reduced risk reduction in favor of Forxiga, and this was statistically significant. So looking at the enormous benefits in regards to Forxiga in our HFF patients, now as we all know, the SGLT2 inhibitors like Forxiga are now incorporated as part of the 4 foundational therapies in the management of heart failure, and these medications should be started simultaneously. Now, we've also even looking at recent studies such as our DELIVER trial. This has shown the effects or the benefits of Forxiga in our heart failure patients with preserved ejection fraction. So across all spectrum of heart failure, now Forxiga is indicated in these managements. Now, moving on to the renal benefits from our DECLARE trial, we proved that Forxiga was slowing down progression to nephropathy. So we delved deeper to study the benefits of Forxiga in our chronic kidney disease patients with or without type 2 diabetes. So this led to our DAPA-CKD trial, which was also a landmark cardiovascular trial, and recruited about 4,304 patients. This was also randomized control trial, double-blinded 1:1, Forxiga on top of the standard of care, so patients with a maximum tolerable dose of your RAS blockers as compared to just patients who are on RAS blockers. So looking at the primary endpoint for the study, there was a composite of 50% or more decline in eGFR, end-stage kidney disease, cardiovascular or renal death. And these were the baseline medications the patients were on. And from the results from our DAPA-CKD, there was a 39% reduced risk reduction in favor of Forxiga. So what this means that patients who are on Forxiga on top of their maximum tolerable dose of RAS blockers had a 39% reduced risk of developing an end-stage kidney disease, cardiovascular death, or a 50% or more decline in eGFR. And this was with or without type 2 diabetes. And the number needed to treat was 19. So in our DAPA-HF trial, the number needed to treat was 21, but in the DAPA-CKD, we had a 19 number needed to treat. So looking at the subgroup analysis, patients with type 2 diabetes and CKD, there was a 36% reduced risk reduction in favor of Forxiga, and half of the patients without type 2 diabetes had a benefit when they were put on Forxiga. So this showed the consistent benefits of Forxiga in our chronic kidney disease patients, whether they have diabetes or not. So with Forxiga, as we all know, it's a simple dosing, 10 milligrams tablets once daily, regardless of meals, anytime during the day. Very easy to initiate for patients. So take-home messages. It's important that we start Forxiga early. We've shown that Forxiga has an effective glycemic control in our type 2 diabetic patients. Forxiga also helps to slow down progression to nephropathy and also reduces worsened symptoms of heart failure. And even in our dyslipidemia patients with type 2 diabetes, we have our Crestor, which has proven with the STELLAR trial, has proven to reduce superior LDL-C reduction as compared to vastatin, simvastatin, and pravastatin, also increases the patient's HDL. So in a nutshell, ladies and gentlemen, I want us to keep recommending Forxiga for our heart failure patients to save their hearts tomorrow. Thank you.
Okay, thank you. Yeah, so if you have any questions for him, please jot them down. We are going to have our next presentation from a sponsor, Novartis. 10 minutes presentation, please.
Thank you very much, Prof, for the opportunity. Okay, thank you. Okay. Yeah. So this is my disclaimer, and I'm very happy that what I have to share here today actually ties into what the theme for this conference or congress is. and we are focusing on atherosclerotic cardiovascular diseases. As mentioned by Dr. Doku earlier, we know that it is the number one cause of global mortality, and 1/3 of the world's population actually suffer mortality as a result of this condition. And then 80% of CVD deaths are due to heart attacks or strokes. So according to the World Health Organization, NCDs are estimated to actually account for 43% of all deaths globally, and then out of that, 19% as a result of cardiovascular diseases. So, we've started this Congress for about more than 2 hours now. And according to a study that was done, it's been shown that in every 60 seconds, 34 people, with atherosclerotic cardiovascular diseases will die. So we can just calculate how many people have died since the time we started this Congress, or even the time I started speaking till now. So it shows the burden that is on clinicians and the help that these people need to actually stay alive. So how do we help patients to help them stay alive? One key thing is to focus on how we can help them modify their lifestyles. And I'm very happy Dr. Doku mentioned risk stratification. That is one key thing that we want clinicians to focus on right now. And I know with cardiologists, it's something that we do routinely, but we wanted to trickle down to the health, the primary health care levels, where patients, a majority of these patients will be going to before they are referred to your end. How these people can also know how to risk stratify patients, which tools to use, individualizing the patients that are sitting in front of you, looking at the tool that best fit that patient, and then using it to help that patient to know that person's cardiovascular risk and help them appropriately. With that, I'll go to inclisiran, and then what inclisiran is as far as cardiovascular diseases are concerned. So we will just look shortly at phase 3 Orion trials 9, 10, and 11, and then the benefit that it actually brought to patients. Maximum tolerable doses of statin and are still not getting to go, and how inclisiran came in strongly to help these patients. Because of time, I've summarized it to just one slide, and how inclisiran actually is helping these patients. From the studies that has been done and the publication by the European Society of Cardiology, inclisiran is a 2-jab medication annually for patients, and is giving these patients as much as a 50 to 55% reduction in LDL-C levels. And with that, it's not only reducing LDL-Cs, but you're looking at other lipid parameters like total cholesterol, non-HDL parameters, ApoB, and what have you. And you can see that, in comparing it with placebo, inclisiran is actually bringing these lipid levels for patients. And with that, you can also calculate benefit that it will bring to this patient in terms of reducing their risk of strokes and other atherosclerotic outcomes. So this is a publication that I spoke about from the European Society of Cardiology, and I know that there are clinicians here who have already enjoyed the benefit of inclisiran for their patients, and that there are good outcomes that they are having for these patients as well. All right. Before I end, I'll just talk a little bit about a program that we have in Novartis. We've not been speaking a lot about it. So we've not had Dr. Light for. It's a managed program in Novartis where you can actually apply for a medication for your patient. If the medication is a Novartis program, it's not okay, it's working. All right. So it can be a pre-approved clinical medication that is still undergoing clinical trial, or a medication that has been launched in another country but is not yet Ghana. We have a program that helps patients in parts of the world that do not have access to these medications get access to it. So you can actually contest access a team for Novartis for such medications to be made available for your patients in Ghana. With that, I'll end my talk, and thank you very much.
Thank you very much. Yes.
Sorry about that. This takes just about 20 seconds. Sorry. Okay, so I'd like to cordially invite, my name is Emmanuel Ado, also from Novartis, and I'd like to invite you all to a satellite event that we will be hosting you on at 7 o'clock today over here. And at the satellite event, we'll be discussing more of some of our patients that will benefit from inclisiran in terms of having the secondary prevention of MIs and other form of ASCVDs, as well as our heart failure patients who would also benefit from the molecule that's Uperio as well. So we'd like to see you there at 7 o'clock, and we'll be honored by your presence. Thank you very much.
Thank you. Can we have the speakers with me at the podium? Dr. Doku, Professor Kama, and Professor Owolabi. Call him. He told me he was going to be here with us. Anyway, and they will break. Yeah. Okay, so questions. Can we have your questions? Participants online.
Hello.
We have questions from participants online. Who is gathering them? Okay, so. Yes, let's take your questions. We are far behind time. I want us to use about 50 minutes for this session. Do we have any questions from online participants? Yes. Okay. Tadade.
Yes, please. Oh, my name is Dr. Edu Adade, and I have a little, it's not so much of a question, but some suggestion to those of us in this room. You know, there are times that you may have a patient who has atherosclerotic, maybe has ischemic heart disease, and then you succeed by alleviating his symptoms with optimal medical therapy. But there's something that I observed at the end of last year. I think we should refer them for further investigation, because there's one particular patient, by the time he got to us, he already had multiple myeloma that was also being treated. Then I asked him, since when have you been having chest pain? Also, the year 2000. I said, oh, okay. So we look at the anatomy, and he had very critical lesions. So at this point, his platelets were then around 56. We couldn't even use dual antiplatelet if we were to put in a stent. So if he had been referred earlier, probably he would have had many years by which time he wouldn't need antiplatelets. Then the hematologist could then go ahead and treat him optimally. Now he had low platelet, he had severe angina, and then he had a secondary angina because his hemoglobin was low. So he was also, his oxygen carrying capacity was low, and it's worsening. Eventually he passed away. So I will encourage us not to hold on to a patient, even if you succeed. If the stress test suggests that, oh, it turned positive in the first 3 minutes, ST segment was so deep and took about 8 minutes to resolve. Even if you can get that person better on optimal medical therapy, you better refer for angiography. You never know, probably he will need an earlier intervention. Where the lesion is said that if you delay, the way we can help him. And then I also want to suggest that we have a registry of people who cannot afford. Because last year, there were this medical team from outside, and then they were begging me, they told me, look, if you don't get more than 15 patients, we are not coming. And when we came, within 5 days, we did about 15 cases for people. Some paid as low as 5,000 Ghana cedis for the stenting. So if you are sitting on them, probably you are sitting on their opportunities to get help. I hope we could get a registry so that when opportunities like this arise, we can look through them and then pick them up and then help them.
Okay, thank you. Your point is well taken. Any questions?
questions. Dr. Pepper, our online participants, we have any questions from them?
No.
Not yet.
Not yet.
Okay.
So I think Dr. Adade's point is well taken. As our team implies, atherosclerosis is a slow killer, right? Silent killer. Silent killer. We have to advocate. Before I came to Ghana, I went to India, and the Indian cardiologists were able to advocate. All Indians who get a heart attack are entitled to a stent. All they need to do is present themselves with a chest pain, ECG is done, there's a government physician on duty, the private hospital sends them an ECG, they send him a code, a number, he proceeds to perform the procedure. Done. So I think we have to hold these people to account. They are running out of the country and getting their stents and coming back. We know that. Okay? We have to advocate. We have to, because it doesn't make sense that there are 6 to 7 cath labs and yet nobody can afford. Even a doctor may not be able to afford a cardiac cath in the night. You'll be surprised. Do you have 3,500, how much is it now? In your house on Sunday, maybe your church, I can just go to the church, take the office and run to the cath lab. But we have to be serious about this. The stents are expensive, but guess what? If the government says Medtronic, drop it down, Medtronic will drop it down and then we'll buy in bulk. The pacemaker is expensive. Tanzania has done it. They came here, took our health insurance, and every Tanzania can get a pacemaker. They can get a stent. So we have to advocate, okay? Intermediate risk. Abnormal EKG. Most of our patients do LVH, T-wave inversion. Most likely, he is having chest pain. Those are the people you send for coronary calcium score, not angiogram. Because if you do the angiogram, he said they are not reliable. And I have seen it. I have done patients. We have correlation. We never wrote a paper on cath lab, but if I do that, then the radiologists will say we're killing their business, right? But we have a relation. Are they true or not? Cardiologists do risk stratification, manage the patient. If you do ischemic trial or courage trial on that patient, the person can do well. Now, if the person can afford and you want to go on to the next level, then you can send them for an angiogram, but it's not always reliable. The reason why it's not reliable, one, most Ghanaians have tachycardia. They have palpitations. Especially the honorables, they are sweating. The pastors are sweating. I'm telling you the truth. You've seen them. Okay? They come, they're tachycardic. So before you do the angiogram, you have to beta block them down. And when they go there, the labs, I don't even know if they have protocols to beta block them before they do the procedures. Are there cardiologists there to supervise? No. Radiologists are not physicians. So we are running into a dicey situation. So I use mostly calcium score. Now, have I ever sent a patient for CT angiogram? Yes. Like that lady, she had all the evidence, but she wouldn't believe me. She wouldn't take the statins. So I went on to do the calcium score, in the CT angiogram, and then confronted her. Then she agreed. So please, be conservative, at the same time, be aggressive. If you think that the person can afford, then you refer for early coronary angiography.
Thank you. Any other? I have a question.
Okay.
So my question is, during these presentations, we've known that these atherosclerotic cardiovascular disease, they lead into ischemic heart disease and then stroke. And then we are told that ischemic heart stroke, mainly ischemic heart disease, is the leading cause of death in our part of the world. And we know that these disease processes affect various vessels. And if it's leading to more stroke, is it that the coronary vessel is spared, or because we are not really having good diagnostics, that's why we are not picking the ischemic heart disease? Because my simple thinking is that if ischemic strokes are so high, so they are the leading cause of death in our part of the world, as opposed to the other parts of the world where the leading cause is actually the ischemic heart disease. Could it be that probably in our part of the sub-region it's also ischemic heart disease, but because we are not having good diagnostics, we are not picking them, and most of them are being treated as probably having peptic ulcer disease? Thank you. So my question is actually to all the panelists. Yes.
Thank you very much. That's a very, very interesting question. There are two ways of tackling that. But most importantly, what is needed is to even have the data to be able to give the right answer. Like I mentioned, the 4 pillars of the stroke quadrangle or the NCD quadrangle or cardiovascular quadrangle include surveillance. Without data, one can guess, one can pontificate. But if you look at what we see, if we're using hospital-based data, if we're just using hospital-based data, of course we know that stroke is more common than ischemic stroke. Stroke is more common than ischemic heart disease or coronary artery disease. But for us to be able to know exactly what is happening, we then need to go to the communities and do population-based surveillance studies that involves at least doing ECGs. At least those should be able to pick ischemic heart disease, and then calcium score, and some of those things that earlier on. And then for deaths, because some people may also have stroke and die suddenly, or some people may have a heart attack and die suddenly. Also, we don't have became weak on one side, unconscious, and died within a day or two, then that's more likely to be stroke than ischemic heart disease or heart attack. But if someone suddenly have very, very bad chest pain and then slumps and die, then that's likely to be. So, but the information that we have, from hospital-based study and community-based study so far, tend to favor stroke as a more common occurrence. Now, to be able to say whether is our own point or phase in the epidemiologic transition, because we may still be at a particular phase of the epidemiological transition whereby strokes are more common, maybe because of hemorrhagic stroke due to hypertension and all of that. Maybe at the point where we're able to control hypertension better and hemorrhagic strokes are less, perhaps at that point when, again, diet, even though adopted Western diet and dietary lifestyle and all that, Our cholesterol is probably still a major risk factor here, but maybe not as high as you have Caucasians. Perhaps the interplay between those risk factors, how much of hypertension, how severe, the interplay between that and diabetes and dyslipidemia and obesity and some of our diet too, like green leafy vegetable and all that, those interplay along with our genetics may be selecting us for more stroke right now, and the level of control of those risk factors here too, for more strokes than ischemic heart disease. But we should be on the lookout that there may be a transition down the line towards ischemic heart disease, even though what we have. But the truth of the matter is that we can tackle all of these together. Everybody is at a risk. 1 out of every 3 individuals is at risk of developing any of this. Lifetime risk. Already 1 out of every 2 have a risk for, they already have either hypertension or obesity or dyslipidemia or diabetes or a combination of those. And the number is going to continue to increase with urbanization, with more income, with westernization, and so on and so forth. You know, this is going to continue to increase. So the way to deal with this is what Norway has done. And many of these are really not something that you need to spend so much money on, really. You know, it's about ensuring that across the life course, from childhood to adulthood and even when you become elderly, people eat healthy, they exercise well, and they avoid smoking, avoid alcohol, maintain a healthy weight. So if we do this, and this involves, as has been said, this is no longer neurology, is no longer cardiology. This actually is a multi-sectoral thing that involves the agricultural sector in terms of what kind of food should they be growing. Involves the entire food value chain. Involves the food industry, including outlets where food are sold either in communities or in workplaces. Involves dealing with air pollution. Involves government policy. Is a multi-sectoral thing, and this is something that involves everybody, because health is the #1 wealth. Without health, none of the SDGs can be achieved. But it is an intersectoral effort that involves everyone. Involves the social media, involves the print media, the regular media, to tell people, you know, to maintain a healthy weight, eat healthy, and to check and be careful about their cardiovascular health. That's actually the only way to also prevent dementia, which is not treatable right now, you know, Alzheimer's and all of that. Prevent cardiac disease, prevent peripheral vascular disease, all at once. So this can be achieved. And then I mentioned the commercial determinant of health, that there are 3 or 4 industries that contribute to 1 out of every 3 deaths. So this has to be dealt with. Of course, African countries also have a dilemma in terms of tax, how much money they realize from those industries to fund their economies, and are they trading that for the health of their population? But Africa still has a chance, because we are the youngest. Mean age of African population is 19 years. So we can still prevent a lot of these deaths and stem the progression to worsening of ischemic heart disease, stroke, and all of that. Thank you very much.
Thank you. Yeah. So I think we've exhausted the time. We've exhausted the time. Just a minute, please.
1 minute. So ischemic stroke is not synonymous with atherosclerotic stroke. Ischemic stroke could be many other etiologies, just like the way we said coronary artery disease, angina, could be due to, atrial fibrillation, you know that one. But even intracerebral problems from sudden increase in blood pressure, vasospasm, can cause stroke in that location. Vasospasm with a clot can cause stroke in that area. Vasospasm or dissection from the blood pressure without rupture can cause a stroke. So all of those will qualify as ischemic. So they don't have atherosclerosis. There is also the small vessel, the intracerebral atherosclerosis without carotid disease. So we have patients who have intracerebral cerebral disease, MCA and others, but there's no carotid. So you look at their carotid, internal carotid is fine. Maybe some intimal thickening. So always look at it in that line. But if there's atherosclerosis in one area, know that it is the whole vascular burden that can happen. Mostly, the heart doesn't happen early. Unfortunately, that is what they die from. So we have people who have severe peripheral artery disease, lose their leg, you look at their coronary arteries, and it's clean. And yet, you have somebody with just a small blocked SFA, and then he has 3 vessel disease. So it's not 100% correlating, but it's a vascular disease.
My comment is a general one, has to do with what Martin mentioned. I think we need to build capacity to manage these diseases. Okay? I think as cardiologists, clinicians, we are so happy with what we do, you know, but there's so much support out there we need to tap into. For children, you know, the cardiothoracic center is not able to even keep up with the money that is coming in for heart operation for children. Recently, a company, you know, supporting them with $60,000 every month, you know, so that they can operate on children. If you look at the breast cancer space, the first lady has been an advocate. Now Herceptin, which used to be about 100,000, you know, in a year, it's free. You know, if you have National Health Insurance card, you can have it, you know, for breast cancer. So we need to come together, you know, it's advocacy, have that registry, data to support. Okay, across Ghana, in a month, we have this number of people coming in with ischemic stroke who needed thrombolysis, or the number of people came in with acute coronary syndrome who needed intervention. You know, once we can showcase these numbers, we can advocate. Otherwise, we'll continue, you know, we continue to have these funerals that are not necessary. So I think we should move beyond our comfort zone. Some of us are doing our best, but everybody needs to jump on board. You should not think about your wife and your children and where they go to school and the cars. And look, we've gone past that. As what you're going to eat, you'll get it. But let's team up together. You know, Akosia called me recently, somebody with a complete heart block. She had had cardiac arrest, resuscitated about 3 times. Okay, that's how we'll bring her over. I spoke to the team. He said, yeah, we'll go ahead. She doesn't have to pay $6,000. Probably would pay around 20,000 Ghana cedis, about $1,500. This was done. This woman has been saved. Where is the money? Now, I'm being told, yes, Kosia and I, so Kosia, please see me. The woman has been saved. She was having cardiac arrest from complete heart block. So she was moved from Rich Hospital to cardio. You know? So we don't need to do it. Let's team up together. There's a lot of support out there. When we are together, we can get endorsement. We can get people to support, you know, so that we can save our life. Tomorrow it can be you. You know, okay? The next day, Alfredoku, you know. I don't know whether I have $3,500. You know, some people have $1 million US in it, but most of us don't have. We don't have the money. So let's see how we can move ourselves with data, with registry, and government, not governmental agencies can support us so that we can have more cases, more devices for our patients. Thank you very much.
Yeah, so we thank you all, the presenters. We still have another thing to be done. So we'll thank you very much, and then we'll take that. Before we move into the next session, I would want every one of you to get up and stretch his or her feet. Let's take 5 minutes break to prevent, you know, venous thromboembolism. Oh, are we going for lunch? And then this will be. Let's finish.
This is for scientists and those who believe in the potential of science. It starts with... This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
People with certain common conditions, such as high blood pressure or diabetes, are often at risk for developing chronic kidney disease, or CKD. If you're at risk for, or have recently been diagnosed with CKD, you probably have a lot of questions. But first, let's talk about the kidneys. Your kidneys play a big role. They are your body's filtration system. Your kidneys filter your blood and remove extra water and waste in the form of urine. It's important that you do all you can to take care of your kidneys because they affect many other organ systems in your body, including your heart. Your doctor can diagnose CKD by using a blood test to measure your kidney function. He or she may also order a urine test to check for kidney damage. The EGFR blood test measures how much of your kidney function is left. The test calculation ranges from over 100 to 0. A higher number is better, and a normal score in adults is 90 or more. A score below 60 is a sign of kidney disease, and your doctor may want to continue to monitor your EGFR to confirm CKD. Your doctor may also perform a urine test to check for albumin or protein. This is called a UACR test. For this test, a score of 30 or more indicates the presence of kidney damage, while a score of 300 or more indicates severe damage. To keep an eye on how well your kidneys are filtering your blood, your doctor should periodically monitor your EGFR and UACR. If you have CKD, there are lots of things you can do to help prevent it from getting worse. Eating healthy and losing weight, exercising, stopping smoking, and taking the medication your doctor prescribes are some simple steps you can take. When you're living with CKD, being proactive is key. Make sure you visit your doctor regularly to learn and keep track of your kidney numbers. It's a great way to stay on top of your kidney health. Check your risk factors. Know your kidney numbers. Discuss with your doctor.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo. When it's CKD, are you seeing the full picture? CKD is a life-threatening condition that is vastly underdiagnosed. Even at stage 3, as few as 10% of patients with CKD are diagnosed. By identifying patients early, you can improve outcomes, delay disease progression, and prolong dialysis-free survival. Screening should focus on patients with risk factors for CKD. Those with high blood pressure, diabetes, cardiovascular disease, and a family history of CKD are at higher risk. eGFR is a critical test that measures kidney function. Measurements below 60 for more than 3 months signal CKD, but that's only part of the picture. To see the full patient picture, your screening should also include a urine sample where UACR is tested, which helps to reveal any potential kidney damage. The KDIGO guidelines show how eGFR and UACR can be used together to help understand risk of progression, frequency of monitoring, when to initiate appropriate management, and when to refer to a nephrologist. The numbers within the parentheses on this heat map, 1, 2, 3, and 4+, show how frequently to measure eGFR and albuminuria per year. The rows on the left describe the level of kidney function based on GFR stage. The columns on the right describe the level of kidney damage based on albuminuria. The eGFR and UACR readings intersecting in the green are low risk and can be monitored annually. Readings in the yellow areas indicate moderately increased risk, should be assessed once per year and managed appropriately. Readings in the orange areas indicate high risk. HCPs, regardless of specialty, should initiate appropriate treatment for these patients, assess them twice a year, then refer them to a nephrologist when albuminuria levels are greater than 300 milligrams per gram. Readings in the red indicate a very high risk and usually should be referred to a nephrologist. Based on the severity, the patient should be assessed 3 or 4 times per year. By looking at both the eGFR and the UACR, you'll have a more complete picture to diagnose and manage CKD earlier and provide better outcomes for your patients.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right, once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
People with certain common conditions, such as high blood pressure or diabetes, are often at risk for developing chronic kidney disease, or CKD. If you're at risk for, or have recently been diagnosed with CKD, you probably have a lot of questions. But first, let's talk about the kidneys. Your kidneys play a big role. They are your body's filtration system. Your kidneys filter your blood and remove extra water and waste in the form of urine. It's important that you do all you can to take care of your kidneys because they affect many other organ systems in your body, including your heart. Your doctor can diagnose CKD by using a blood test to measure your kidney function. He or she may also order a urine test to check for kidney damage. The EGFR blood test measures how much of your kidney function is left. The test calculation ranges from over 100 to 0. A higher number is better, and a normal score in adults is 90 or more. A score below 60 is a sign of kidney disease, and your doctor may want to continue to monitor your EGFR to confirm CKD. Your doctor may also perform a urine test to check for albumin or protein. This is called a UACR test. For this test, a score of 30 or more indicates the presence of kidney damage, while a score of 300 or more indicates severe damage. To keep an eye on how well your kidneys are filtering your blood, your doctor should periodically monitor your EGFR and UACR. If you have CKD, there are lots of things you can do to help prevent it from getting worse. Eating healthy and losing weight, exercising, stopping smoking, and taking the medication your doctor prescribes are some simple steps you can take. When you're living with CKD, being proactive is key. Make sure you visit your doctor regularly to learn and keep track of your kidney numbers. It's a great way to stay on top of your kidney health. Check your risk factors. Know your kidney numbers. Discuss with your doctor.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo. When it's CKD, are you seeing the full picture? CKD is a life-threatening condition that is vastly underdiagnosed. Even at stage 3, as few as 10% of patients with CKD are diagnosed. By identifying patients early, you can improve outcomes, delay disease progression, and prolong dialysis-free survival. Screening should focus on patients with risk factors for CKD. Those with high blood pressure, diabetes, cardiovascular disease, and a family history of CKD are at higher risk. eGFR is a critical test that measures kidney function. Measurements below 60 for more than 3 months signal CKD, but that's only part of the picture. To see the full patient picture, your screening should also include a urine sample where UACR is tested, which helps to reveal any potential kidney damage. The KDIGO guidelines show how eGFR and UACR can be used together to help understand risk of progression, frequency of monitoring, when to initiate appropriate management, and when to refer to a nephrologist. The numbers within the parentheses on this heat map, 1, 2, 3, and 4+, show how frequently to measure eGFR and albuminuria per year. The rows on the left describe the level of kidney function based on GFR stage. The columns on the right describe the level of kidney damage based on albuminuria. The eGFR and UACR readings intersecting in the green are low risk and can be monitored annually. Readings in the yellow areas indicate moderately increased risk, should be assessed once per year and managed appropriately. Readings in the orange areas indicate high risk. HCPs, regardless of specialty, should initiate appropriate treatment for these patients, assess them twice a year, then refer them to a nephrologist when albuminuria levels are greater than 300 milligrams per gram. Readings in the red indicate a very high risk and usually should be referred to a nephrologist. Based on the severity, the patient should be assessed 3 or 4 times per year. By looking at both the eGFR and the UACR, you'll have a more complete picture to diagnose and manage CKD earlier and provide better outcomes for your patients.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown. fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right, once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science, in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
People with certain common conditions, such as high blood pressure or diabetes, are often at risk for developing chronic kidney disease, or CKD. If you're at risk for or have recently been diagnosed with CKD, you probably have a lot of questions. But first, let's talk about the kidneys. Your kidneys play a big role. They are your body's filtration system. Your kidneys filter your blood and remove extra water and waste in the form of urine. It's important that you do all you can to take care of your kidneys because they affect many other organ systems in your body, including your heart. Your doctor can diagnose CKD by using a blood test to measure your kidney function. He or she may also order a urine test to check for kidney damage. The EGFR blood test measures how much of your kidney function is left. The test calculation ranges from over 100 to 0. A higher number is better, and a normal score in adults is 90 or more. A score below 60 is a sign of kidney disease, and your doctor may want to continue to monitor your EGFR to confirm CKD. Your doctor may also perform a urine test to check for albumin or protein. This is called a UACR test. For this test, a score of 30 or more indicates the presence of kidney damage, while a score of 300 or more indicates severe damage. To keep an eye on how well your kidneys are filtering your blood, your doctor should periodically monitor your EGFR and UACR. If you have CKD, there are lots of things you can do to help prevent it from getting worse. Eating healthy and losing weight, exercising, stopping smoking, and taking the medication your doctor prescribes are some simple steps you can take. When you're living with CKD, being proactive is key. Make sure you visit your doctor regularly to learn and keep track of your kidney numbers. It's a great way to stay on top of your kidney health. Check your risk factors. Know your kidney numbers. Discuss with your doctor.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo. When it's CKD, are you seeing the full picture? CKD is a life-threatening condition that is vastly underdiagnosed. Even at stage 3, as few as 10% of patients with CKD are diagnosed. By identifying patients early, you can improve outcomes, delay disease progression, and prolong dialysis-free survival. Screening should focus on patients with risk factors for CKD. Those with high blood pressure, diabetes, cardiovascular disease, and a family history of CKD are at higher risk. eGFR is a critical test that measures kidney function. Measurements below 60 for more than 3 months signal CKD, but that's only part of the picture. To see the full patient picture, your screening should also include a urine sample where UACR is tested, which helps to reveal any potential kidney damage. The KDIGO guidelines show how eGFR and UACR can be used together to help understand risk of progression, frequency of monitoring, when to initiate appropriate management, and when to refer to a nephrologist. The numbers within the parentheses on this heat map, 1, 2, 3, and 4 plus, show how frequently to measure eGFR and albuminuria per year. The rows on the left describe the level of kidney function based on GFR stage. The columns on the right describe the level of kidney damage based on albuminuria. The eGFR and UACR readings intersecting in the green are low risk and can be monitored annually. Readings in the yellow areas indicate moderately increased risk, should be assessed once per year and managed appropriately. Readings in the orange areas indicate high risk. HCPs, regardless of specialty, should initiate appropriate treatment for these patients, assess them twice a year, then refer them to a nephrologist when albuminuria levels are greater than 300 milligrams per gram. Readings in the red indicate a very high risk and usually should be referred to a nephrologist. Based on the severity, the patient should be assessed 3 or 4 times per year. By looking at both the eGFR and the UACR, you'll have a more complete picture to diagnose and manage CKD earlier and provide better outcomes for your patients.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
People with certain common conditions, such as high blood pressure or diabetes, are often at risk for developing chronic kidney disease, or CKD. If you're at risk for or have recently been diagnosed with CKD, you probably have a lot of questions. But first, let's talk about the kidneys. Your kidneys play a big role. They are your body's filtration system. Your kidneys filter your blood and remove extra water and waste in the form of urine. It's important that you do all you can to take care of your kidneys because they affect many other organ systems in your body, including your heart. Your doctor can diagnose CKD by using a blood test to measure your kidney function. He or she may also order a urine test to check for kidney damage. The EGFR blood test measures how much of your kidney function is left. The test calculation ranges from over 100 to 0. A higher number is better, and a normal score in adults is 90 or more. A score below 60 is a sign of kidney disease, and your doctor may want to continue to monitor your EGFR to confirm CKD. Your doctor may also perform a urine test to check for albumin or protein. This is called a UACR test. For this test, a score of 30 or more indicates the presence of kidney damage, while a score of 300 or more indicates severe damage. To keep an eye on how well your kidneys are filtering your blood, your doctor should periodically monitor your EGFR and UACR. If you have CKD, there are lots of things you can do to help prevent it from getting worse. Eating healthy and losing weight, exercising, stopping smoking, and taking the medication your doctor prescribes are some simple steps you can take. When you're living with CKD, being proactive is key. Make sure you visit your doctor regularly to learn and keep track of your kidney numbers. It's a great way to stay on top of your kidney health. Check your risk factors. Know your kidney numbers. Discuss with your doctor.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo. When it's CKD, are you seeing the full picture? CKD is a life-threatening condition that is vastly underdiagnosed. Even at stage 3, as few as 10% of patients with CKD are diagnosed. By identifying patients early, you can improve outcomes, delay disease progression, and prolong dialysis-free survival. Screening should focus on patients with risk factors for CKD. Those with high blood pressure, diabetes, cardiovascular disease, and a family history of CKD are at higher risk. eGFR is a critical test that measures kidney function. Measurements below 60 for more than 3 months signal CKD, but that's only part of the picture. To see the full patient picture, your screening should also include a urine sample where UACR is tested, which helps to reveal any potential kidney damage. The KDIGO guidelines show how eGFR and UACR can be used together to help understand risk of progression, frequency of monitoring, when to initiate appropriate management, and when to refer to a nephrologist. The numbers within the parentheses on this heat map, 1, 2, 3, and 4 plus, show how frequently to measure eGFR and albuminuria per year. The rows on the left describe the level of kidney function based on GFR stage. The columns on the right describe the level of kidney damage based on albuminuria. The eGFR and UACR readings intersecting in the green are low risk and can be monitored annually. Readings in the yellow areas indicate moderately increased risk, should be assessed once per year and managed appropriately. Readings in the orange areas indicate high risk. HCPs, regardless of specialty, should initiate appropriate treatment for these patients, assess them twice a year, then refer them to a nephrologist when albuminuria levels are greater than 300 milligrams per gram. Readings in the red indicate a very high risk and usually should be referred to a nephrologist. Based on the severity, the patient should be assessed 3 or 4 times per year. By looking at both the eGFR and the UACR, you'll have a more complete picture to diagnose and manage CKD earlier and provide better outcomes for your patients.
want to continue. We have 2 more presentations, and we'll be done with the presentations and move on to the workshop session. Can I have your attention, please? There are a number of mini meetings going on. There should be only one meeting. Our next presentation is on erectile dysfunction and is going to be presented by an interventional cardiologist with expertise in the management of erectile dysfunction. Our speaker this afternoon is Professor Esteemed, who is a fellow of the Royal College of Physicians and a professor of practice, University of Wales. He's also a professor of cardiology in the University of Cape Coast, Ghana. He's a consultant interventional cardiologist. Ladies and gentlemen, Professor Esteemed, our speaker. Shall we give him a hand up?
Thank you so much, Professor. Also, it's great to be here. Can you hear me at the back? Right, I've been given the graveyard slot, and I've been given 30 minutes to present a topic which would normally take a couple of hours. So get up the loins of your minds and fasten your seat belts, because I'm going to go through this fairly quickly to cover as much of this subject as I can. Because I would imagine that not many of you here would have heard a subject like this, ED, erectile dysfunction, and as a silent killer. So here goes. I have, indeed, I have no conflict of interest with regard to this talk. Now, ladies and gentlemen, the definition of potency you'll see here was described by Leonard Simpson in 1950. And he talked about the ability to initiate, to sustain, and successfully conclude the sexual intercourse to the satisfaction of the male. Please don't shoot me. That was the definition in the 50s. Now, the ladies among us will be very happy to know that things did progress, and the National Institute of Health actually talk about erectile dysfunction as the inability to initiate, maintain penile erection for satisfactory sexual performance, recognizing that actually this job includes both male and females. First quiz. In medieval times, erectile dysfunction was thought to be caused by witchcraft, childhood experiences, overuse of the now flaccid organ, natural defects or coldness of nature, or all of the above. Oh, well done. Congratulations. Erectile dysfunction, ladies and gentlemen, can either be psychogenic, organic, or mixed. Psychogenic factors are listed here. Organic factors, I'll come to, there are multiple factors. In 1975, Martin Cole, who was a botanist, thought that perhaps the best way to distinguish between psychogenic erectile dysfunction and organic erectile dysfunction was to use surrogate partners. So if you came to him with your ED, he will send you to a room, show you this bombshell, and if you still couldn't get it out, you had a problem. Now, there are several conditions that have been associated with ED. Indeed. Indeed, exactly that. There's the aging process and chronic diseases that are listed here, endocrine abnormalities, neurogenic abnormalities, and as I said, there are psychogenic factors. But this list here, which is far from exhaustive, would immediately tell you that ED is a very complex subject and actually involves all specialties. There really isn't any specialty that is excluded in managing erectile dysfunction. Next quiz. On average, men without ED, so normal men, without ED will experience 1 erection per week, 2 to 3 erections a night, 4 to 6 erections a night, 10 to 20 erections per night, good Lord, and or none of the above. Anybody want to hazard a guess? Martin. Well, if you answered 4 to 6 erections per night, you were absolutely correct. Now, it's... All right. Ladies and gentlemen, I only have 30 minutes. I did actually say to the organizers I needed more time for this talk, and they flatly denied me. So it's not my fault that I have to rush through some of this stuff. Okay. So, Ismail Karkan, who was one of the godfathers of ED, was the one to describe this strain gauge method, and he employed an assistant who in the middle of the night, they would what they would do when you came in with your ED, they would wrap this strain gauge around your penis, and in the middle of the night, the assistant would take a Polaroid camera and film these nighttime erections. And of course, female assistant. And of course, what is fascinating is they were able to then tell these patients, particularly the ones with psychogenic ED, you don't have an organic problem. Your problem is psychological, because look at these fantastic photographs showing your very impressive erection. Now, is erectile dysfunction important? Yes, it is. And I've sat in my ED clinic with lots of patients coming to me saying, my marriage is at risk. I'm about to lose my partner because I can't get an erection. And it's an all too common problem. And if anybody here thinks this is not a serious issue, I can tell you it is. And people have been known to commit suicide as a result of this because their marriages are broken down. But 80% in a survey of ED sufferers did talk about some form of relational difficulty. So ED is a very serious problem. The corollary of what I'm talking about is that, of course, sexual function and normal sexual function is absolutely crucial for life. And in fact, I won't bore you with lots of studies demonstrating that you can reduce your cardiovascular health by having more sex. The more sex you have, the longer you live. Now, ladies and gentlemen, unfortunately, okay, all right. So, organize. Where are the organizers? I told them I needed more time. I told you I needed more time for this. Yeah. Okay, ladies and gentlemen, I think I need to take my jacket off. I'm starting to get a bit hot. All right. So, next question: how common is ED? Now, in some prevalent studies, certainly done in the UK, where I live, you see that 13% of men have currently have an erectile problem. I'm afraid this hides a multitude of sins. The main study on ED and prevalence was the Massachusetts male aging study. In this study, they took several men who had, it was over 2,000 men, and they gave them a standard questionnaire, which I'll talk about in a second. And what they came up with, if I go back one, was that in fact, the actual figure was 52% of men between the ages of 40 to 70 had some degree of erectile dysfunction, some mild, moderate, and severe. 52% of men in Massachusetts had some degree of erectile dysfunction. Ladies and gentlemen, this has, of course, been demonstrated in several societies. So I put it to you that if you look to your left or right, the person sitting next to you has some form of ED problem, or their husbands has some form of ED problems. I'll advise you to discuss this over a plate of wache after this meeting. Organizers, what did I tell you? I told you I don't need more time. Ladies and gentlemen, John Elliotson was a general physician in the 19th century. And in his book on diabetes, it's absolutely a fascinating read. But you come across this quote. John Elliotson said, there is also this one very remarkable symptom, the loss of sexual power and desire. And he quotes, I have never found this symptom to be absent. And sometimes it's been the very first symptom noticed by the patient. So as far ago as in 1839, you have a physician demonstrating that diabetes and erectile dysfunction was an extremely common problem. Now, there's been several studies in diabetic patients, and what you see here is that if you're between 39 and 40, at least a quarter have got clear evidence of erectile dysfunction. Once you hit over 80, all diabetic patients have got ED. If you're between this sort of age, thankfully I'm not diabetic, but I'm in this sort of age group, over half have got significant erectile dysfunction. Now, I've often been asked how I got interested in this subject, and there are quite a few reasons. But I got interested in ED work, and I thought I'll just do a small study in Cardiff where I worked. And this was in March 2008. And what we did was an audit of our patients who were in our rehabilitation. So in the UK, if you have MI or you've had an acute coronary syndrome, everybody goes into cardiac rehab. So we gave them a standard questionnaire, which is very well recognized, called the IEF score or SHIM score. This is it here, the Sexual Health Inventory for Men. It's been very well validated. And we gave this questionnaire to them, and these were 30 patients, and we gave them the SHIM score. And the results really did surprise me. I must be honest, I did not expect this. But 60% of these patients had significant erectile dysfunction. And these were, you see here, 5 of them had moderate, and below 15 is moderate and then severe. But a significant proportion had very significant ED. Despite the fact that this condition is so common, this is the attitude of most clinicians, at least in the UK, where they just stick their head in the sand. If you look at this Massachusetts male aging study, only 10% of these patients actually sought help from a clinician. The vast majority basically thought, as you will see, that doctors don't really care about this stuff. This is ED-seeking behavior in a urological office. You'll see 80% of patients did not want to talk to their practitioners because they were embarrassed. There were other reasons, but the main reason is embarrassment. Despite that, the vast majority of these same patients actually want to discuss the problem, but they are too embarrassed by it, and they don't think that anybody is going to be interested. This is a typical patient that I saw in my clinic. 64, lots of cardiovascular risk factors, and as I shall demonstrate to you conclusively, this sort of patient, you can put all your mortgages on the fact that he's going to have erectile dysfunction. Okay? He's got multiple risk factors. He's got lots of vascular disease. This guy says to the general practitioner on 3 separate occasions about his problem, the GP is completely uninterested. Okay? And I suggest this is a case of the doctor blowing hot and cold, for those of you who are still awake. So ED is a common problem. How do you get it? And what indeed are the hard facts? Now, Graham Jackson is the godfather of vasculogenic ED, and I did all my ED studying under him. I sat in his clinic several times to just learn from him. That's the way to learn, of course. It's to be an apprentice and learn. We'll come back to that in a second. But anyway, in his clinic, this was the distribution of patients coming to his ED service. You see 40% have got diabetes, 30% vascular disease. But this accords with what is in the literature. 75% of patients with erectile dysfunction have got some form of vascular disease. In fact, if you look at the entire cohort, at least 2/3 have got vasculogenic ED. So the way it breaks down, 80% have got organic ED, 20% have got cyclogenic ED. It's not as clear-cut as that, but that will do for starters. And of the 80%, 80% of those have got vasculogenic ED. So it works out to be about 2 out of 3 or 66% have got vasculogenic ED. Now to some pathophysiology. So those of you who, I know I've been given the graveyard slot, you've just had your food, you want to go to sleep. So this is the time maybe to start to catch a nap. Those of you interested in basic science, this is for you. So endothelium-dependent vasodilation, you recall the way to do it. You get a wrist cuff, you tighten it right around the brachial artery, you then release it, and you measure percentage dilatation. If you're normal, this is your curve, and if you've got erectile dysfunction, you've got clear evidence of endothelial dysfunction because you're not releasing nitric oxide to cause vasodilatation. This is the work done by Vlachopoulos. He's a Greek interventional cardiologist. He's actually a very good friend of mine. And he did quite a lot of basic science studies. He looked at patients with ED, no ED in the light, ED in black, no coronary artery disease, evidence of coronary artery disease, and you can see here the levels. No, sorry. No. The black shade. The black shade. It's not my fault. Blame Vlachopoulos. And you can see here that the first thing to notice is that ED was associated with an increase in these inflammatory markers and prothrombotic markers. Okay, so if you've got ED, your high sensitivity CRP was up, your IL-6 was up, fibrinogen was up, VWF was up. What is also interesting is that in men with ED only, inflammatory and prothrombotic activation is virtually identical to those who have got ED, who have got coronary artery disease. So if you've got no coronary artery disease by ED, CAD and no ED, your levels were virtually identical. And that's telling you something. So for most of these markers, both prothrombotic and inflammatory, the impact of ED is very interesting, similar to CAD, but also confers an incremental unfavorable effect on impact if you have coronary artery disease as well. So the worst state to be is to have ED and coronary artery disease. Now, you've seen this sort of slide several times. And what I would like to convince you of is that this process of atherothrombosis that is taking place in your coronary arteries, in your carotid arteries, in your peripheral vasculature, it's exactly the same thing that is going on in your arteries, cavernosal arteries and the pudendal arteries, the arteries that supply your penis. Atherothrombotic process that we've been discussing, I'm sure I don't really need to convince all of you here, it's a very systemic illness. So what's going on up there is the same thing that is going on down there. So atherosclerotic disease in the penile arteries, same process going on in your coronary arteries. And they share the same risk factors, not surprisingly. So you've got hypertension, cigarette smoking. I love this idea of cigarette smoking with it bending down. If you, it was singularly the most powerful advert to reduce cigarette smoking was this advert of demonstrating that cigarette smoking can cause your dick to fall. Okay? And then the obesity and diabetes. If you see this sort of gentleman walking into your clinic, you don't really have to ask whether they've got ED or not. They do have erectile dysfunction. Okay. So what are the implications? Erectile dysfunction equals endothelial dysfunction. They share the same risk factor burden, but how is ED particularly related to cardiovascular disease? And this is going to be the subject of the talk for the next few minutes. Can ED, in fact, be a marker for silent cardiovascular disease? Can it be a marker for silent cardiovascular disease? Can we, in fact, use erectile dysfunction just by asking the question? No fancy tools, no having to bribe somebody for some money for nonsense, just asking questions. Can we, in fact, use erectile dysfunction as a means of detecting cardiovascular disease? This is a fascinating study. What they did was to take 2,500 patients, okay, and then they looked very carefully to make sure none of them had any history of cardiovascular disease. They then followed them up over 10 years. And they used the IEF score or the SHIM score that I showed you. And you can see here, if you had no ED, mild ED, moderate and severe ED, it's virtually curvilinear. It's going up over the 10-year period. Your risk of ED, if you had cardiovascular disease, if you had ED, was so much higher than if you had no ED. There was, in fact, a 65% increase in the risk of developing cardiovascular disease if you had erectile dysfunction. This is data that was published some time ago in JACC. Nearly 2,500 diabetic patients not known to have coronary disease, baseline ED 27%, 4-year follow-up, and you can see here the event rate if you had erectile dysfunction, at least twice that of patients who did not have ED. The study by Inman was published in 2009. I remember this study very well because it was very soon after I'd started my ED practice. 1,400 men not known to have CAD screened for ED, and they followed these patients up again for 10 years. And they looked at very hard endpoints. And what they came up with was as follows. Coronary artery disease, coronary event, sorry, this was death MI. So this was very hard cardiovascular endpoints. You either had an event or you were dead. They counted the dead bodies. So these were not some manya flimsy cardiovascular risk. This is proper stuff. Yeah, dead or MI. 11% of cohort. ED increased with age, as you'd expect. The risk of having cardiovascular events that was attributed to ED declined with age. So if you're in your 40s, the hazard ratio of having an event if you had ED was 2 compared to if you were in your 70s. So ED has much greater cardiovascular impact if you're young, this of course means that if you come in young and you've got erectile dysfunction, you really have got a chance of perhaps saving somebody's life. This is the paper by Gazruso. Again, this was very famous at the time. They took 133 patients who had coronary angiography. They had silent CAD on coronary angiography. So they did angiograms. They demonstrated coronary disease. Took another 227 diabetic men, no evidence of coronary disease. And you will see here that ED was present, 34% of CAD patients versus 5%. But this is what interests me in this particular paper. In this particular data set, your odds ratio of having an event was 5. If you're a smoker, if you have microalbuminemia, it was 4. LDL cholesterol was only 2.5. But look here, if you had erectile dysfunction, your odds ratio of able to predict your coronary disease was nearly 15 compared to all the traditional cardiovascular risk factors. So, ladies and gentlemen, ED is a vascular issue, and I hope I've tried to convince you that if you've got disease in one vascular bed, you're more likely to have it in another. This is just a quick one to say, if you've got peripheral vascular disease, in this particular data set, 50% has significant peripheral vascular disease. So ED is systemic. If you have atheroma in one vascular bed, you're likely to have it in another. I'm sure we're all convinced of that. If you have erectile dysfunction, you're likely to have atheroma elsewhere. And unfortunately, all roads lead to a heart attack. But which presents first? ED or your heart attack? Now, these are the sizes in millimeters on average. Okay? So your penile arteries are about 1 to 2 millimeters. These are coronary arteries, about 3 to 4, carotids 5 to 7, femoral 6 to 8. Now you see here I've put Greco-Roman world. Greco-Roman world, just to remind me that in Greece, they were more interested in small penises and penile sizes, apparently, historically. Whereas the Romans, on the other hand, were more interested in very big penises. Now, I was curious about this and tried to look into my own ancestry and discovered that I was actually Roman. I had Roman ancestry. Ladies and gentlemen, the penile size hypothesis is really very interesting, because if you look, because of the penile size, the arterial size, not the penis size, the arterial size. So we're dealing now with the arteries. If you start to lay down atheroma in a small artery, you're bound to have a much bigger impact than if you lay it in a bigger artery. And this is the basis of the artery hypothesis of the relationship between erectile dysfunction and the risk of having an event. So it so happens that if you have ED and you're young, if you follow these patients up over a mean of 3 to 5 years, you find that these patients, a lot of these patients have developed a cardiovascular event. So this data set by Montosi, Montosi is an Italian urologist who's done a huge amount of work in ED. And in this data set, patients with acute chest pain, by the way, they are Montosi brothers. I think one of them is a cardiologist. Anyway, but mean age of 63, ED prevalence 50%. You see that in this data set, 2/3 of these patients had their ED before their coronary artery event. Now, 2 out of 3 ain't bad. Other data sets came along and said, actually, this figure is more like 93%. And I can tell you now, I, at one stage, ran the biggest vasculogenic ED clinic in the UK. I did. And I can tell you now that in my data set, it was nearly 100% of all patients who had gone through our cardiac rehab, who had ED, their ED came before their heart attack. Nearly 100%. In fact, I can still remember the time when this guy, as I was questioning him, I said, yes, so when did you have your ED? Oh, no, I had it after my heart attack. I said, no, you didn't. You must have had it before. No, I had it after. So I took him into a corner, hooked him by the neck and said, you're ruining my statistic, my friend. The recognition that ED as a warning sign of silent vascular disease has led to the concept that a man with erectile dysfunction and no cardiac symptoms is a cardiac patient until proven otherwise. This is a quote from the godfather of vasculogenic ED, Graham Jackson. The recognition that ED as a warning sign of silent vascular disease has led to the concept that a man with ED and no cardiac symptoms is a cardiac patient until proven otherwise. So we can justify classifying ED as another form of secondary prevention that should merit aggressive risk factor management. We can use ED, in fact, as a means of preventing cardiovascular disease. So Paul Holzer says these data serve as a basis for preventing life-threatening events by risk factor management and lifestyle modification just by asking a very simple question with regard to ED. My colleague and very good friend Julian Halcox was just quoted in the Western Mail when he just simply said, improve your sex life and save your life. I really like this. Improve your sex life and save your life. How are we doing for time? How much time have I got? Okay, all right. So, should we... Apparently, I'm saving a lot of lives here. Okay, should we investigate ED patients for silent CAD, and if so, how? Well, the ADH, the American Diabetes Association and American College of Cardiology, recommend that some form of non-invasive testing is probably appropriate for patients who are diabetic with 2 or more cardiovascular risk factors. And that non-invasive testing in patients cardiovascular risk factors has always been a bit controversial, but I want to try and convince you that it's probably worthwhile doing. This is data set from Graham Jackson, which he published with 50 men, those published in Circulation. 50 men with ED, asymptomatic, had positive, had treadmill testing, and you can see here 28 out of the 50 had positive treadmill tests, and of those who went on to have coronary angiography, you can see here they all had significant disease, coronary artery disease. What about using CT that we heard Professor Akama talk about earlier on? So this data set, these patients had virtually no abnormal ECGs. They are two exercise ECGs, I mean. So their treadmill tests were normal, but you can see here when they did their coronary calcium score, there was a very close correlation between coronary calcium scores, mild, moderate, severe, extensive coronary calcium scores with these patients who had erectile dysfunction. I'll go on to the next one, which is looking at subclinical coronary disease in these ED patients. I'll illustrate it with this slide. If you compared ED patients with patients who had no ED, ED in the black and non-ED in the white, you can see that if you had ED, you had a much closer association with patients who had evidence of coronary atherosclerosis. If I go back a second, if you looked at patients with coronary atherosclerosis, there was a very close correlation if you had ED. And the worse your ED, the more the increase in your calcium score. So, how about patients who've got who've already got evidence of cardiovascular disease? So, if a patient presents with ED, I'm saying he's a ticking time bomb, especially if they are young. Okay, they have got silent vascular disease, and these are patients that you should be looking at very carefully. What if they've already got disease, like a lot of patients who came to my clinic? What is the relationship between that and erectile dysfunction? And does severity of ED actually matter? Well, this interesting data set, which seemed to be suggesting that actually the worse your disease, the more extensive your atherosclerotic disease, the worse your erectile dysfunction. So in this data set, your ease of achieving erections, you can see here, was much lower if you had 2 to 3 vessel disease versus 1 vessel disease. Firmness in erection, frequency of erection, everything was much worse if you had extensive coronary disease. So they were bedfellows. The worse your ED, the worse your atherosclerosis, and vice versa. This is a paper by Solomon, 132 patients who had coronary angiography. They then calculated the burden of plaque using the Gensini score, which is quite a common way, at least in the past, of calculating atheroma burden. And you can see here that there was a clear correlation between your Gensini score, which is your plaque burden, versus your IEF score, which is the severity of your erectile dysfunction. So, close correlation here. And these are the p-values. Okay. The Massachusetts Male Aging Study also gave us some very interesting data. 400, if you look at the study, 1,700, 15-year follow-up, 403 died. And you see ED had a 26%. If you had erectile dysfunction, you had a 26% higher risk of mortality, 43% higher risk of cardiovascular death. And ED was a very strong predictor of this. This is a meta-analysis, a cohort study, 45,000 patients, and you can see here cardiovascular events and 47% increase, heart attacks, 43% increase, death, body count, 23% increase. I suspect a lot of us here would remember, okay, I suspect a lot of you would remember On Target Transcend trial, and in this study, if you had erectile dysfunction, you can see your risk was increasing. And everything is to the right. ED predicted adverse outcome if you were hypertensive. This was really interesting as well. Not only did ED predict all these cardiovascular risk factors, there was also a gradation. So no ED, mild to moderate and severe. You can see the worse your ED, the worse your outcome. So these are my rules. The more extensive atherosclerotic burden in one bed, the more likely the burden in other vascular beds. The more severe your ED, the more extensive your vascular burden, and extensive disease equals early death. So very quickly, in the last 5 minutes that I've been given, how do you manage it? Risk factor modification, as you would expect, that we've talked about. Cardiovascular workout, very similar to what you've seen that Alfredoku shared with us. Very quickly, which of these therapies did Malaysian men cite as being useful for erectile dysfunction? Application of squirrel semen to the affected organ, the wife beautifying herself, taking the wife on holiday, drinking excessive alcohol, eating hot chilies, drinking tea made from fungus which has grown where the semen of a mating tiger has fallen on the ground, or all the above. Okay, no talk of ED is complete without talking about Giles Brindley. Now, Giles Brindley, in his seminal lecture in 1983 to the American Urological Association, he, by the way, discovered papaverine, which was the first drug that was used in treating ED. It's a vasodilator. So, 30 minutes before his talk, he went to the toilet, injected his own penis, and during the talk, he whipped out his trousers, went around the room, and invited the audience to feel his very impressive effect of papaverine on his penis. Now, ladies and gentlemen, 30 minutes before this talk, I also went to the toilet and injected a drug. And for the first time in Ghana Cardiac Society, so other ED treatments are sildenafil, vardenafil, tadalafil, and there's now, of course, avanafil. And there are other non-oral treatments. The way we treat ED, we start with PD5 inhibition, and if this doesn't work, because as I'll show you, 50% discontinue, you can go on to penile injections with Caverject prostaglandins, and there are other prostaglandins that you can use, vacuum pumps. If they don't work, penile prosthesis, and other things which I will very quickly go. Phases of the sexual response cycle here. This is worth knowing if you're going to treat erectile dysfunction, okay? There are two sources. The most important drug is nitric oxide. Nitric oxide stimulates guanylate cyclase, and what you get is GTP to GMP, cyclic GMP, guanylate monophosphate. That stimulates a protein kinase, extrudes calcium, and as a result of calcium extrusion, you get vasodilatation, okay? The PD5s work here. So they stimulate guanylate cyclase. So if you're able to stop this from being broken down, you promote this process. By the way, CAMP, cyclic AMP, as in cyclic AMP, adenosine monophosphate, which goes via the prostaglandin pathway, has got similar effects on protein kinases and extrusion of calcium. That's why we can also use prostaglandins. But this is the mainstay of treatment by enhancing the effect of nitric oxide in calcium exclusion and vasodilatation. I haven't got time to take you through this. Suffice to say, this is what your flaccid penis looks like, and when it's erect after vasodilatation, these cavernosal arteries just open up, allow blood in, and then you get your erection. There's a very rigid structure called the tunica albuginea, and when these become very enlarged, they basically squish the tunica. The tunica squishes against the venous system and stop blood from leaving so that you can maintain your erection. And after you've ejaculated, the whole process reverses. Blood flows through and you reverse this. But this mechanism, so-called veno-occlusive mechanism, is also very important in sustaining your erections. Forgive me that I haven't got time to go through this. It's the fault of the chairman. But ED is a vascular, complex neurovascular problem. The mechanism of producing erections is a complex neurovascular mechanism. There's a problem of venous leak. And just to mention very quickly that 34%, about a third of patients have got disease of the arteries that supplies the penis. Unfortunately, time wouldn't allow me to go through this and this, but these are what your PD5s are doing. They're causing vasodilatation in your peripheral vessels as well as in your coronary vessels. This is an important study because it's just showing you that if you compare sildenafil, Viagra, to oral nitrates, there is absolutely no difference in terms of exercise-induced time in patients with angina. So this nonsense of You can't give patients PDE5 because they're on nitrates. Take them off the nitrates and give them PDE5s, ladies and gentlemen. Keep these men happy and stop having miserable patients. Okay. PDE5s actually reduces all-cause mortality. Big studies here that unfortunately I haven't got time to take you through. They also low-dose PDE5 inhibition improves cognition, improves depression, somatization. They do all sorts of very good things, by the way, ladies and gentlemen. And this is some women say no. Anyway, so PDE5 inhibitors. Well, maybe in the question time we might take up some of these things. Okay, I'll just move on. Some patients don't comply or it doesn't work, and you have to have a way of dealing with patients who are either not complying, who can't take it, etc., etc. These are off-label ED drugs, very quickly, which I concocted in my kitchen. The first one is mycoxaflopin. The second one is mycoxafailing. The third one is midixadrooping. The fourth one is midixarising. The fifth one is simply Dixafix. And then there's midixadult. And then my favorite one, I'll be poking. Ladies and gentlemen, the hypothesis is that there's a very similar relationship between angina and ED. If medical therapy fails, my view, you can stent and also you can bypass, okay? No blood flow to an artery, like, by the way, very quickly, Mr. Chairman, 1 minute. So, this is your aorta, common iliac, external iliac, internal iliac. And this artery coming down here is your internal pudendal artery, the single most important artery in a man's body. Now, if you don't believe me, okay, this is normal erectile function, is blood flow. Leriche, you remember Leriche syndrome that we all learned at medical school. If you block off your internal iliac, you end up with impotence, okay? Now, ladies and gentlemen, if you have this sort of this is your left main stem, supplying blood flow to your artery. This is the left anterior descending, ramus intermedius, circumflex. There's nothing going through. Now, I put it to you that if you have this sort of coronary vasculature, you can give all the tablets you like. Nothing is going to happen, okay? You need to fix this either with a stent or with bypass surgery. And I also put it to you, the same thing goes. Now, this didn't project very well, but this is the first patient who had pudendal stenting, performed by myself, by the way, I hasten to add. But this patient couldn't get it up. We threw every drug at him. This was as tight, it was exquisitely tight. And we fixed it. By the way, 10 years later, this guy then phoned me to say, you know how you fixed me 10 years ago? My problems have started again. 10 years later. Okay, so this thing works. Okay, the PUMPI study is what I'm going to end with. I love the PUMPI study. 10 patients with angina and ED had coronary angiography and pelvic angiography. When they came back for the results, they were given a very simple questionnaire. Which of your arteries do you want to know about first? Your coronaries or your pelvic arteries? Guess what? 100% of men said they wanted to know about their pudendal arteries first. 100% of men. That tells you all you need to know about where the brains of men lie. So, ladies and gentlemen, if I had to convince you of the importance of my talk, I'm sure the PUMPI study. So you can do penile Dopplers. This was the first, unfortunately, it wouldn't show, but this was the first stent that I put in, and it was reported in the Daily Mail, an eye-watering new way to perk up a limp love life. It was beautiful. I won't talk about the Zen trial because I've got no time. But ladies and gentlemen, I'm going to end now. There is an evolution of our understanding of cardiovascular disease. There's this interlink of all these cardiovascular risk factors, and ED is part of this global risk. In fact, I dare say ED, as we saw in the Gazaruzo trial, may even be the cream of the crop. So please add the question. You must help make the link. I'm not going to go through these findings. ED is a cardiovascular equivalent. You've got a time window of about 3 to 5 years. Put it this, 3 to 5 years. Get it right. Get everybody involved. And take home messages. Early death, early detection, erectile dysfunction equals endothelial dysfunction. We need to educate both our patients and our colleagues. Okay, now, it's very important, you know, these patients come to us. They're going home, a lot of them, because you've sorted out their coronary disease, but they are going home to a very miserable life. And I put it to you that patients don't only want to live longer, they want to die happy. And with this, I end. Ladies and gentlemen, I stole this slide from Martin Adade. Always do your best, no matter the size of your audience. Thank you very much. With that, I end.
Yes. Thank you, Professor Jenny, for this insightful presentation. Yeah. So we'll continue further. We have our last presentation, which will be done by a rep from BI.
Good afternoon. Good afternoon, everybody. So first, I will really thank Prof. Janning for making sure that all the blood flow was going to the brain and not the stomach or anywhere else to ensure that I had your attention for these few minutes. So thank you so much for this opportunity. My name is Dr. Karen Rotuk. I'm the Medical Science Liaison for Boringa Ingelheim, Sub-Saharan Africa. Regards from Kenya, my home country, where I have come from. And I'm very glad to know that the Kenya Cardiac Society were on the line as well. So today I'm going to talk about acute MI and just go slightly into the impact MI study. And first I want to just recognize that I'm speaking in front of absolute experts. So I'm not going to go deep, and I'll be taking care of what I say just in case I say something wrong, but please put up your hand. So the key takeaways, we're just going to start with a clinical case. Sorry. Just a short clinical case. We'll define acute MI, epidemiology, risk factors for heart failure post-MI. We'll go just a little bit into the impact MI study, the study design, participant selection criteria, the endpoints, and then we'll conclude. And to further make sure that you're awake, there will be a short quiz at the end. And I will request your participation by logging into slido.com, where you'll be able to answer the questions. Okay. So our patient is Mr. KM, a 68-year-old male who presented to the ER. I almost said ED. Who presented to the ER with chest pain that had lasted for 3 hours and shortness of breath. In his past medical history, he had a 3-year history of type 2 diabetes on metformin and hypertension on telmisartan 40 OD. So he came complaining of VS chest pain radiating to the left arm. He described it as a herd of elephants sitting on his chest. Had started 3 hours before arrival, and he reported associated sweating and shortness of breath on exertion and orthopnea. No history of trauma and no relief on resting. So upon initial assessment, he appeared diaphoretic and dyspneic. His vital signs were, as you can see, elevated blood pressure, elevated heart rate, overweight with a BMI of 28, and dyspneic with SpO2 of 88 on room air. On physical examination, lung auscultation showed bilateral basal crackles, cardiac auscultation showed S3 gallop, no murmurs, and he had bilateral pedal edema. ECG findings, sinus tachy, ST segment elevation in those leads, consistent with an acute inferiolateral MI. Lab findings, full hemogram was within normal limits, EGFR was low at 55, NT-proBNP was elevated, uric acid was just slightly high. On echo, he had a new onset, left ventricular EF of less than 45 with regional wall motion abnormalities. So diagnosis of course, an acute STEMI with queries, this complicated with acute heart failure. So this is going to be our first question. I will leave you pondering about what would be the immediate treatment actions for this patient. At the same time, what would be the management strategies and secondary interventions for this patient to prevent further cardiovascular compromise in the future. So we'll come back to that question. So when we go into acute MI, you are the experts from the Joint Task Force. It's defined as acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute MI. So acute myocardial ischemia. So acute myocardial injury, evidence of acute myocardial ischemia, and the rise and fall of cardiac troponin values within more or one value about the 99th percentile, plus one or more of these symptoms indicated there. What is the epidemiology of acute MI? I really wish I had local statistics, and I know that, okay. So we'll skip this, but we know that the numbers are not good, and I also believe that locally there are many patients who suffer from acute MI, and it would be very interesting to know what percentage of them go on to develop heart failure, because that is what is of interest. So these are some of the risk factors for acute MI, and the risk of developing heart failure after acute MI rises with time, and even 5 years later, it is shown that these patients are still at risk of developing heart failure. So what is it that can be done to avoid that? So going into the empagliflozin studies that have been done over the past years. So the EMPA story began from EMPAREG. EMPAREG was a cardiovascular outcome trial that was done on type 2 diabetic patients. The reason they looked at cardiovascular outcomes in a quote-unquote diabetic drug was following the ADA mandate to check on cardiac safety of all diabetic drugs. So EMPAREG showed not only cardiovascular safety, but also cardiovascular benefit. And after that was successful, went into check now specifically cardiovascular outcomes in LV, heart failure with reduced ejection fraction, as well as heart failure with normal preserved ejection fraction. We did EMPULSE with very few patients to check on the benefit of EMPA in hospital initiation in acute heart failure, and specifically in kidney outcomes, but also with an aspect of cardiovascular. So in all these trials, empagliflozin showed cardiovascular benefit, and with the unmet need of these patients post-acute MI going into heart failure, we thought to do EMPACT MI, which is an ongoing study. At the moment, it's at the level of study analysis, statistical analysis, etc. And those who will be privileged to attend the ACC this year will receive the results firsthand. So EMPACT MI, a multi-center randomized double-blind placebo-controlled trial, 5,000 patients enrolled to receive either EMPA 10 mg plus care or placebo plus standard of care. And the composite primary endpoint of time to fast heart failure or all-cause mortality. The key secondary endpoints being total heart failure hospitalization or all-cause mortality, total CV hospitalizations or all-cause mortality, total all-cause hospitalizations or all-cause mortality, and total MI hospitalizations or all-cause mortality. These were the main inclusion criteria. So the mandatory ones are either STEMI or non-STEMI, hospitalized within 2 weeks before randomization, and the other mandatory one was high risk of heart failure. So defining high risk of heart failure as either symptoms of congestion, signs of congestion, or a newly developed LVEF. These were the other inclusion criteria. And this is my summary. I'm running very fast so that we can do some questions. So anybody manage to go into Slido? Slido.com. So just enter slido.com on your phone browser and then enter that event code, Impact MI, and it will guide you to our first question. Slido.com. Our first question is, I hope you've been able to see it. How would you prioritize management strategies and secondary prevention of cardiovascular events in this patient, if you remember him, Mr. KM, with acute STEMI and signs of congestion? Anybody managed? The code is Impact MI. This last one, EMPACT/MI. Okay, I can see some answers coming in. Okay, so majority are choosing C, early coronary revascularization, PCI or thrombolysis, but we also have other choices of aggressive blood pressure control, initiation of beta blockers and ACE inhibitors, IV diuretic therapy. So I believe that all your answers are actually correct. This one is a very easy one. I will skip it because, and this is also a very easy one. So, has anything come up? Okay, this is going to be the last one. Which of the following was added as a risk factor for development of heart failure in the Impact MI trial? This is my last one. Okay, thank you very much for all those who've participated. Thank you for your time and have a lovely afternoon.
Thank you, Rep for BI. Yeah, so we are almost at the end of today's presentations. Let's get questions. Those of you who have questions on, yes. Can we get Dr. Pepra? Is it possible somebody wants to ask a question?
Thank you much. I'm Kofi Techiasamoah. Thank you, Prof. Jenin, for your presentation. In recent times, there's been increased awareness about the role of inflammation in causing cardiovascular disease. And current research directions are looking at the role of colchicine in preventing and reducing repeat events. Do you know if there's been any study in this regard in line with ED, as in the role of colchicine, since we're linking the inflammatory process in ED to the overall inflammatory process of CVD? Is there anything in this direction? Thank you.
Okay. Can we take another question? Maybe additional one or two, and then would answer them, address them all together. I'm asking whether we have additional. We don't have much time, so no other questions. So this will be the last, I think.
So this will be very quick. The answer is no. I certainly don't know of any data, but it does make sense. And you would think that on first principles, drugs like colchicine should have a positive effect on conditions like erectile function. Thank you.
Okay. Okay. So I think we've overspent the time which we had for this section. So we are almost done, but permit me to highlight some few issues that came up during the presentations. On looking at the overview of atherosclerotic cardiovascular disease, I think that it was made clear that the burden is huge globally. You know, the region and including Ghana. And currently in Ghana, cardiovascular disease is the leading cause of death. And it was emphasized that atherosclerotic cardiovascular disease, and this was emphasized throughout the presentations, it's a systemic disease. We should take note of that. And this is being driven by the high burden of the cardiovascular disease risk factors, especially hypertension. And most of the time we tend to forget about the part that dyslipidemia plays. Many years ago, when some of us started practicing, you know, in this country, prevalence of hypertension, we're talking about 10%, 15%. But now, the discussions have changed, 30%, 40%. In the next 10 years, what is it going to be? Dyslipidemia, studies have shown prevalence of about 30% and over. This is very worrying, and we have to take note of this. And I think it was emphasized that because of lack of resources, management in this country is suboptimal, and therefore we have to focus more on prevention, primary prevention and secondary prevention. Coronary artery disease presenting as chronic coronary syndrome is not a stable disease, we were told. It's a progressive disease. And as part of our evaluation, full evaluation, we should always remember the parts that coronary calcium, you know, score plays in the evaluation of such patients. The burden of stroke, we're told, is also huge. And the issue about patients presenting more to us with stroke rather than ischemic heart disease came up. And we all realize that there are a number of areas that need to be explored. And I think this is one of them. The fact that high intake of green vegetables tend to prevent stroke among us. The mechanism is not well known. This is also an area which requires exploration in terms of research. A number of gaps in the management of atherosclerotic cardiovascular disease in this country
have also been identified. And as I said earlier on, the LOC should look at all this, and together with tomorrow's presentation, let's all come up with a communique to guide us. On this note, I think I would thank you all for your patience. We've all stayed through. We also like to thank the presenters for a very good job. I would hand over to the moderators for further, information and direction. Thank you all.
Thank you, Prof. Owusu, for chairing this section for us. I believe today has been a great day. We have learned a lot, received very insightful information. But the day is not over yet. The last section will be a practical session where we'll go up and then we'll learn about, we'll have a workshop on BLS and then ACLS. And then we also have some workshop on basic ECG reading. So the place has been set upstairs. We'll move there and then we'll have those sections. But before we go, I think we'll take a final closing prayer for this session, and then we'll all move up. So shall we close our eyes? Heavenly Father, we thank you for what we have learned today. We thank you for all we have heard. We pray that you will grant us grace to be able to implement all these to help the advancement of cardiovascular practice in this country. We thank and bless your name in Jesus' name. Amen. Okay, thank you very much. So we all move up for the practical session. And tomorrow we will be here again from 8 a.m. to 9 a.m. We hope that we all arrive, and then from 9 a.m. the program will start. So see everybody here again tomorrow. So the practical session will also be online. Yes, yes. So those of us
code. Mega code essentially when you have a patient who has, we are running the full ACLS code for a cardiac arrest. What ideally is supposed to be done before we come to the practicals. Unfortunately, we have trouble with the audio. We're going to play this.
Two-person rescues.
The first rescuer should begin CPR with chest compressions while counting out loud and delivering breaths. Basically, they're handling the situation at first as a one rescuer scenario. The second rescuer is responsible for powering up. The rescuer should begin CPR.
You literally are running it with two persons. Now with a mega code, or when the patient is in cardiac arrest, you are running a code. Ideally, you need 6 people. Okay, talk about the team dynamics, the roles and the response. Way, someone responsible for chest compression, management of the monitor, the defibrillating,
in charge of IV medication documentation and timing. And now you need a CPR coach, someone who is to ensure that the chest compressions are being done effectively as we describe as high quality CPR. So we're going to watch a video to see that demonstrated, then now we'll start the workshop in detail. Thank you.
Impressions? Dana, Lenora, have you managed to establish an IV?
No, not able to get IV access.
target. O2 saturation is 96%, and blood pressure is up to 110/70 now.
Picture 12, lead.
He has a STEMI. Mark, call the cath lab and let them know that we have a STEMI patient that just had ROSC after cardiac arrest. Let them know that the patient is now hemodynamically stable, and we've initiated targeted temperature management.
The return of spontaneous circulation, or ROSC, is not the end of the cardiac arrest protocol. The high-performance team should continue to maintain an acute
So this can happen. It's been happening. Most of us have partaken in codes. We've run in Kolebu, the ER, and it's been like this. Not an exaggeration. It's a fact. Most of you know that. So essentially, if you notice, the patient came in conscious and ended up in cardiac arrest. It tells us that we should always be prepared. So team preparedness is key. And you saw the team dynamics and the roles is essential. So the patient came in, so there's a systematic approach. So when the patient comes in, is the patient conscious or unconscious? So the patient is conscious, so they went along with primary assessments. A, B, airway, breathing, circulation, disability, then the E. So you notice that even though it's A, B, C, D, it is done simultaneously because all team members are trained, and that's what we want to achieve. When all team members are trained, you don't have to do A necessarily before B. Everybody knows their role, and they get to it. So when the patient became unresponsive, then they had to establish that patient was in cardiac arrest, and they did that by checking whether patient was responsive, tapping the patient, and checking carotid pulse, confirming there was no carotid pulse. Then they started chest compression with the ventilation. And they went to the cardiac arrest algorithm. So there's the shockable and non-shockable algorithm. What they went through first was a shockable rhythm because the rhythm was a VF, ventricular fibrillation. So they gave a first shock, second shock, third shock. So for the shockable rhythm, the first shock goes without any medication. The second shock onwards goes with medication. So second shock goes with what? Adrenaline, and the third shock went with amiodarone. To make it easy, you are timing every 2 minutes. And if you are doing your chest compressions at 30 to 2 and at 100 to 120 compressions per minute, and you are not delaying unnecessarily, that should be 5 cycles for each 2 minutes. And so if you do that effectively, what happens is that you are going to time every 2 minutes. You are giving your adrenaline at every 3 to 5 minutes. That was the old protocol, but now you choose 4 minutes. So if you are choosing 4 minutes, essentially, with the first shock is your 2 minutes. The second shock will be 4 minutes. So it goes with adrenaline, okay? The third shock will be 6 minutes. So for even numbers, starting from the second shock, the medication that goes with your shock, if it's still a shockable rhythm, is adrenaline. If it's an odd number, the medication that goes with it is amiodarone or lidocaine, to make it simple. So second shock, adrenaline. Third shock, amiodarone. Fourth shock, adrenaline. Fifth shock, amiodarone, to make it simple. For a non-shockable rhythm, essentially, you are doing your chest compression, your ventilation, and you are giving adrenaline every 4 minutes and looking for the H's and T's, which cuts across. You have to identify reversible causes, which has been summarized as the H's and T's. We'll discuss that whilst we are running the code. For non-shockable rhythms, if you don't identify the reversible causes, you're unlikely going to win. For shockable, you can get your patient back and achieve ROSC, which is return of spontaneous circulation, without necessarily having corrected your reversible causes. But you still have to look out for that and correct them. Then when you achieve ROSC, they went into the post-cardiac arrest care, which is still going back A, B, C, D, and then correcting, and then finally deriving and concluding what caused the arrest and solving it. In the scenario, they thought it was an MI, so you have to activate the cath lab, and patient will have to end up in the cath lab. But you need to preserve neurological function. That is the importance of the targeted temperature control. So please, we divide ourselves into two groups. One group will take the BLS, one group will come to the ACLS. Thank you. Number 1212, all the ones BLS, all the twos ACLS. So we can start from my boss. Boss. Okay. 1, 2, 1, 2, 1, 1. Ken, wing commander. 1, 1, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. 1, 2. So all the ones, BLS, all the twos, ACLS.
Any other considerations? Yeah? 30 minutes. Okay. All right. So you can decide 30 minutes. But even though it's 30 minutes, there are also some other things that will have to. Yes. First is, what were the rhythms? Hmm? What do you think? Decide before you start. So he is saying prognosis. Very important. Would you even want to start? All right. So okay. Okay. So he's saying if DNR, there are like two things here. At what point wouldn't you even want to start? And there's when you've started and you've not achieved the ROSC, at what point do you stop? So yes, if they want to die with dignity or something, they don't want anybody compressing on their chest, and then they sign a do not resuscitate order. Based on that, you wouldn't want to even commence. And like you said, also the prognosis. All right, if the prognosis is bad, this person needs ICU care and it's not available, then you can, and then of course this is a palliative, someone who is on palliative care, you know that you don't want to go ahead and CPR. So in that case, that answers your question. You take a decision as a team for this patient. If he ever goes into cardiac arrest, based on the prognosis or the DNR, or that we're not going to do CPR, it is in that case that you take that decision even before you start. But exactly, yes. Okay. Or like the person has been, what's the word? Decapitated. Of course, you're not going to CPR. Yes. Or yeah. And also, if you're in mass casualty, yes, risky in the war zone, mass casualty disasters. If someone, you've done your disaster triage or your mass casualty triage, and the person is unresponsive, has no pulse, don't go ahead and start CPR. And the reason is simple. By the time you start resuscitating one person, another person that you would have helped will go into cardiac arrest. So before you know it, all the patients go into cardiac arrest. So yes, but his question is still there. How many minutes can you go on? So there are several things which he mentioned. One, which is fatigue. The second is, what rhythm did you get? If you were able to connect the patient to a cardiac monitor, what rhythm? If you were getting an asystole for 30 minutes, you want to call it off. Yes. But when you get something like a pulseless electrical activity, when you get a pulseless electrical activity, what that is telling you is that there's a reversible cause that you need to find and fix. And so long as there's a reversible cause that is fixable, you should continue. The second is, if you're using an AED or you see a shockable rhythm, you cannot stop. So if that shockable rhythm continues for the next 1 hour, you have to continue for the next 1 hour. All right. So the other thing is, so if you can find a reversible cause, you can fix it, the rhythm, then you prognosticate. Been doing this for 45 minutes, 1 hour, and what rhythm. When you put all these things together, you now know whether to continue. But one thing I can tell you, in our own environment, that plays a major role is what? Fatigue. When everybody is tired, the compressions are no longer effective. You now know, but minimum, you want to basically give in 30 to 45 minutes of resuscitation. Yes. All right, so we'll just go ahead and then practice, and then if we have further questions, we can ask. Is that okay? All right. So we want to function at the level of Dr. Loftus, the guy. But you know, the thing about BLS is the BLS is the foundation of the ACLS. If your compressions are not effective, then your amiodarone and the rest of the things they are doing there is not going to be effective. And the emphasis for us who are cardiologists is not just for us, but for our team. When you're there and they are doing resuscitation, so let me ask this question. Why do you think, how effective is the CPRs we do back in our hospitals? How effective? How effective? Not very effective. And so what are the things that play a role in the ineffectiveness of our CPRs or resuscitation? Knowledge, one, okay, basically. So I'll add skill. Good. So even if all of us are cardiologists right now, I'm sure everybody knows how to do CPR. But if someone has a cardiac arrest right here and now, there will be commotion everywhere. Is it because you don't know? No, it's because team dynamics. That's why Ghana crashed out of AFCON. You see, the team has to. So you might have a team of stars. Everybody needs to understand their role and play their role, which is what we're going to talk about in the ACLS. So we need to organize ourselves as teams. The team leader knows his role. The person in charge of airway knows his role. The person with the something as little as connecting electrodes to the patient's chest might actually cause a lot of delay in recognizing the rhythm. Or you ask someone, bring the defibrillator, and the person doesn't know how to operate the defibrillator because he hasn't used it. But if you were practicing as a team, you will know that this person doesn't know how to use this AED. So you probably give that role to someone who can play that role. Yeah. So what else makes our CPR not effective? All right, so lack of items too. Defibrillators, CPRs to CPR board to make it, because sometimes the beds are too high, so most times you're compressing your hand this way. You can't really get the height that you want. The beds are soft. So these things all play a role in making sure that our CPRs are not effective. And these are the things that we should look out for, because these things all affect, at the end of the day, the outcome that we hope to have. So talking about presence of defibrillator, for example, I've had a training where the defibrillator was in the auditor's office. Yes, like 2 AEDs and 1 manual defibrillator. So it boils down back again to knowledge. If you know how important this thing is and you know how effective it is in your resuscitation, then you need to make a demand that your hospitals, we've come to a point where as physicians, as healthcare workers, there are some things that are essential for our work. And if those things are not available, we need to, the way we insist for pay rise, we need to insist that those things should also be part of our work. All right. So I'm just going to go ahead for us to do demonstration, and then we can continue with the questions. And after that, the woman starts coughing out blood, has difficulty breathing, and then asks the guy to bring him to the hospital. On the way to the hospital, just as they were getting to Kolebu, the woman goes into cardiac arrest. And you are the first at the scene. What are you going to do? So tell me. Call for help. Call for help, all right. So help, somebody help. What else? That's the patient here. Check for scene safety. All right, so the next thing I want to do is what? Check for what? Scene safety. Now this person is at the back of a taxi. What can I do at that point? And the person has come to the hospital. The person is at the back of saloon there. Can I do compression there? So the first thing will be to drag the patient out and put on the floor or on the gurney, and then you start your compression. Okay. Another scenario is that, let's say it happens here. Nobody imagines that it can happen anywhere, but the thing is that cardiac arrest can happen anywhere, anytime, and 20%. So the person has collapsed, so I want to check for what? Scene safety. So I check, my scene is safe. Then the next thing is I want to be filled by the victim. And the next thing I want to do is what? Check for. Hello. Hello, are you okay? Hello, are you okay? Patient cannot hear me. Then I call for help. Help! Somebody help! Then what do? I check for pulse, and then I check for what? Breathing. So a minimum of 5 seconds, but not more than 10 seconds. So simply, you could just put your finger and then count 6, 5, 4, 3, 2, 1. Patient has no pulse and patient is not breathing. Then what do? I commence compressions immediately. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 27, 28, 29, 30. After 30, what do? I give breaths. Alright, so when you're 2, we encourage that you use the BVM, back valve mask, but when you're alone, you go ahead and use the pocket mask. Alright. Any questions? So we're going to come out and demonstrate, each and every one of us, and after that, we're going to put ourselves into pairs and then use it. Yes.
Okay, so just as you said that the cardiac arrest can occur anywhere. So assuming it's occurred in church, maybe a place where there's no thing to deliver the oxygen.
Okay,
so I'm monitoring back now.
So,
what way can you give the
so very important question. All right, so if you're in a church, for example, and you don't have an AED, you don't have, first there's what we call hands-only CPR, where you're encouraged to just do compressions, perfuse the brain as much as you can, and then when there's an available transport, you put the person there, continue the CPR while you're at the hospital. that has been found to be effective too. Then, if you have something you can give breaths with, you continue compressions and you can do mouth to mouth, even though with COVID and every other thing, it is at your discretion, user's discretion. But there's also a pocket mask that you can use that has a one-way valve. Now that pocket mask should be in first aid boxes. It's not Flagyl or Cipro and Imodium. What should be in the first aid box is like things to control bleeding. That pocket mask, that is what you should use while you're en route to the hospital. With that, you can compress and you can also give breaths. Right, so maybe I'll get one. Well, it just looks like a face mask. It looks like just this face mask. And then with a valve on it. Yes, we'll get one so that's alright. So this is the AED. We have a live AED in case somebody has cardiac arrest, even though if you have plans, please, we don't want it. Yeah. But this is just a trainer and we just use it for training. So what's the first thing to do when you use the AED? What's the first step you use the AED? Yes, turn it on. So using this for me, there are two instructions. Put it on and follow the voice prompts. That's all. So many people, you give them this and they're scared using it. You need to tell them there's nothing. This is supposed to be everywhere. It's supposed to be at the gym. It's supposed to be in churches, and lay people can use it. You just put it on and follow the voice prompt. For me, I do three. I say there are three things. Put it on. Can you understand English? And then can you follow instructions? So it's one thing to understand English, another thing is to follow instructions. So I'm just going to put this on.
If the patient is a child, press the child button.
If it's a child, I'll press the child button, right?
Remove clothing from the patient's chest.
Remove clothing from the patient's chest.
Remove packet and apply pads on the patient's bare skin.
Apply on the bare skin.
Apply pads as shown in the pictures.
As shown on the picture, so the pictures are drawn.
Remove packet and apply pads on the patient's bare skin. Press pads firmly on skin.
Press it firmly.
Press pads firmly on skin.
Press firmly.
Do not touch the patient. Analyzing heart rhythm.
So everyone clear? Do not touch.
Do not touch the patient. Analyzing heart rhythm.
Analyzing heart rhythm.
Shock advised.
Shock advised.
Do not touch the patient.
Everyone clear? Do not touch.
Everyone clear.
Everyone clear.
Press the flashing shock button.
So I make sure everyone is clear before I press
the shock button now.
You can see the red button, right? So shock. Shock delivered.
Shock delivered. Begin CPR.
Then I begin my compression. Can you hear the beats? This is helping you with your compression rates. And after 30, it will tell you to give 2 breaths.
20.
Okay.
30. Give 2 breaths.
Okay? Alright, so we'll be demonstrating how to use both of them. The question I want to ask, what if the AED says no shock is advised? What should I do? Continue chest compressions. Right. Another question, what if, because I went to a place and they brought the AED and they told me that the AED isn't working. Alright, so you put it on, it doesn't come on. What will you do?
So we do not have a problem with either hypo or hyper.
No, like you put it on and this machine doesn't come on. It sounds common, right? But I can tell you that if you do not practice at the height of adrenaline, just like when you go to an exam, something you knew before entering the exam hall, you get there and it vanishes. So the idea is you need to troubleshoot these things, know how to operate. If you have an AED, you have a manual defibrillator, just turn it on, see how it works. For example, the one we use in the department, we don't have electrodes. We only have the paddles. So you can use the paddles when it is time for rhythm and pulse check to check your rhythm. If you don't have those electrodes, But then I bring it out and I put it, and I'm not getting any electric. It was a resident that showed me how to go to the buttons and change it from the 1 or 2 to pedals. So you need to know the button to press to change it to pedals. Because if it's still at the 1 or the 2 and you're putting the pedals there, you won't see the traces until you change it. So these are the things that before an emergency, you learn and get used to how it works. So any machine you're using, know how it works. All right. So I'm going to give us a scenario. Please use the pad for a minute, but we're going to face this way. So everybody take one mannequin. If the mannequin is not enough, we'll still find time for you to take it. Your scene is not safe. There's water on the floor, there's glasses on the floor. Yeah, all right. So I'll give you a scenario and then you can practice. You all have your AEDs, right? It's only when I tell you there's an AED, that's when there's a free mannequin there. Do you want to do 2 or 1? Let's start with 1. But there's one free one. Okay, yeah. Let's start with 1. All right. So, Paul, do you want to help us with this scenario?
All right, sure. So this man has come to the hospital. He has come to pay the bills. People has come. So he has come to pay the bills in the hospital. And then he just collapses on the hallway. You witness him fall to the ground. Over to you.
All right. So what's the first step? So check around, look around, ask yourself, is my sin safe? All right, your sin is safe, proceed.
Are you okay?
No response. Check for pulse. Check for pulse.
3, 2, 1, no pulse.
Hold on. So you didn't check for pulse? Remember, how long did you check for pulse? 5 seconds. All right, it was faster than 5 seconds. All right, so we're going to start again. Check, there's a free mannequin there. Okay, all right. Okay. Someone can take when she comes. All right, so we're starting. Don't stand up. So your sin is safe. What's the first step? Let's go through it. Check for response. Tap the shoulder. No response. Check for the pulse. I want to see pulse. 5, 4, 3, 2, 1. All right, call for help.
Help is on the way.
All right, position your hands for compression. You know what? Just position your hands. We will come round. Make sure your hands are in the right place. Where should your hand be? The heel of your hand should be lower half of the breastbone, right in the middle. Okay? Make sure you're not at the xiphosternum. Okay? And then you want to be above. Your hands should be straight, as straight as a line drawn with a ruler. Okay? All right. So, 3, 2, 1, let's go. 1, 2, 3, 4, count. 6, 7, 8, 9, 10, 11, 12, 13. You should get 2 green lights. You're not getting 2 green lights. Take a pause. We're going to go again. 1, 2, 3, let's go. Go back to compression.
1, 2, 3, 4,
6, 7, 8, 9. Count aloud.
12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 24,
All right, take a pause. We're going again. I want everything you did this afternoon to go. 1, 2, 3, let's go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
All right, so go ahead and use the AEDs, everyone. Put your AED on. Don't use your AED.
Adult patient.
After that, we'll pay ourselves.
If the patient is a child, press the child button. Remove clothing from the patient's chest.
What's the first step?
Remove packet and apply pads onto patient's bare skin. On the child's bare hands as shown in the picture. Apply. Press pads firmly on skin. Apply pads as shown. Press pads firmly on skin. Do not touch the patient. Analyzing heart rhythm. Do not touch the patient. Analyzing heart rhythm. Shock advised. Do not touch the patient. Everyone clear. Press pads firmly on skin. Do not touch the patient. Analyzing heart rhythm. Do not touch the patient. Do not touch the patient. Everyone clear. Clear. Flashing shot glass.
Clear. Clear. Everyone clear. Oh, what's in the winter? All right, so continue compression.
Do not touch the patient. Analyzing heart rhythm. Begin. 30. Give 2 breaths. Do not touch the patient. Everyone clear.
Yeah. All right, we'll talk about that. When we now reach the 2, the second person will be all right.
20. 30. Give 2 breaths.
Okay. Thank you very much.
30. Give 2 breaths.
So you can put up the AEDs now. 20. Oh, we haven't practiced. Who hasn't practiced? Put up the AEDs. You can remove it here.
For those who have done the training, there was a miss in the time. So after the second shot, if he had alerted the time of the last adrenaline,
so any questions before?
There's a reason why he got caught up with the next step, so he had to respond. So it was the third one that we gave that later. So technically, it was the second dose of adrenaline.
2 breaths.
Remember we said from the key numbers, going so you said the position of the hand should be about adrenaline.
Yes. Yes. So the position of your hand, the heel of your hand should be at the center.
Still a very good training.
Lower half, but above the xiphostenum. The reason is that when you're going towards the xiphostenum, you're going towards the stomach. And what happens when you compress on the stomach? The person is going to have aspiration. So we use it as a safety net to make sure that we're not going anywhere close to the stomach. Yes. So that your compression doesn't end up causing aspiration. Any questions? Who hasn't practiced? You haven't, so pick a mannequin. So yes, so if you still want to practice, you can go ahead. Who hasn't practiced? Yeah, you haven't practiced. All right, so there's a mannequin here too. So who wants to give us a scenario? All right. So the man is giving us a scenario. So, all right, so go ahead.
So you are in the emergency room, and there's a patient who is being managed for heart failure. You observe that suddenly the patient has stopped breathing. Take it away.
All right.
Either PEA or ACLS.
Okay, she wants to use this one. All right. So go ahead. Scenario again.
So you are in the emergency room, and there's a patient who's been managed for heart failure. You realize that the patient has stopped breathing. What do you do?
So let me make it a bit nicer. You guys are doing rounds. And you're on the patient, discussing on the patient. And then the patient codes, or you notice the patient is no longer breathing. What will you do?
All right, safety. Is my scene safe?
All right, look around.
Yes, your scene
is safe. Your scene is safe, so proceed.
Hello, sir. Hello, sir.
If this person is unresponsive, your tapping will not wake him up.
Help, somebody help.
Help is on the way.
Okay.
All right. Check for pulse. Check for pulse. We'll talk about it. Hold on. Yeah.
After tapping that you call for help, or you check the pulse before you call for help.
All right, so it is not hard and fast. The idea is that after tapping, if the person is unresponsive, call for help. Because the patient is unresponsive, so you need help any which way it is going. But then when you check for pulse and check for breathing, it's assumed that the help must have come to you then, so that you can now give more specific instructions. So the first one is help, someone has collapsed. By the time you check for pulse and check for breathing, you now know this person is in what? Cardiac arrest. So the help now comes, you're asking, get the members of the code team, get the AED, get the crash cards. So the first help is just to draw attention to where you are. Then by the time the help comes, you now tell them exactly what you want them to do. Is that okay? So I would say call for help. Immediately you know the person is what? Unresponsive. Yes. And another thing, you want to be selfish. You don't want to go into CPR for a long time before the help comes. So even before you're starting, you're getting reinforcement. It can be tiring. So the person has collapsed. Let's start from the beginning. Your scene is safe, so check for response. Okay. So.
Hello, sir. Somebody help. Somebody help.
Help is on the way. Check for
6, 5, 4, 3, 2.
Alright. No breathing. Alright. So position. Alright, let's all start together. Just hold on. Position. I want us to start together. We'll come and make sure your hands are in the right place. We're all standing together. All right.
That person falls out to their right, and the next person comes in.
Are we starting?
Hold on. All right, we want to start together. All right, 3, 2, 1, let's go. 1, 2, 3, 4,
5, 6, 7, 8,
9, 10, 11. Count out loud.
13, 14, 15, 16, 17, 19, 20, 21,
Take a pause. We're going back to compressions. 1, 2, 3, let's go.
Go back. Good. 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. When it's straight, say 9, 1, 2. So it's from your shoulder. So that's why you have this. Go. Let's go. So 1, 2, 3, 4, 5,
6, 7, 8, 9, 10, 12, 13, 14, 15, 16, 17,
Let's go green. That's green. Good. All right. Go ahead and use the AEDs now.
So let's put on the AED. So open it. Just open it.
What's the first rule when the AED comes on?
Adult
Put it
patient.
on. Find the on button.
Patient is a child. Press the child button. Remove clothing from the patient. Adult patient. If the patient is a child, press the child button. Remove clothing from the patient's chest. Remove packet and apply pads onto patient's bare skin. Apply pads as shown. Press pads firmly on skin. Apply pad. Press pads firmly on skin. Do not touch the patient. Analyzing heart rhythm. Do not touch the patient. Analyzing heart rhythm. Shock advised.
Shock advised.
Do not touch the patient. Everyone clear. Press the flashing shock button. Shock delivered.
Oh, the man was there. Man was there.
That's okay.
All right. Are we done? So the thing is, all right, Hello. Before you press the shock button, look around and make sure no one is touching the patient. It is the only thing I'm going to tell you. It is very easy to use, but make sure you observe no one is touching. I've had a colleague. We were doing CPR. She was the one at the airway giving breaths. And she was telling others, clear, clear, clear. Meanwhile, her hand was on the pigment. So I was holding the paddle. And I'm like I had to shout at them because I was aware of what I was holding. So someone could be telling you, go ahead and press, deliver shock. Meanwhile, the person is absent-minded. So holding it, you take responsibility of using it. This is a real AED. So I put it on. It works the same way.
By removing all clothing from the patient's chest.
So just for you to know that it works the same way.
When patient's chest is bare, remove protective cover and take out white adhesive pads.
And all this while you're doing compressions until it tells you analyzing rhythm.
When patient's chest is bare, remove protective cover and take out white adhesive pads. Look carefully at the pictures on the white adhesive pads.
So it's just basically following the instructions.
From the yellow plastic line.
Any questions? So let me ask my questions. So someone has now come. You've asked for help and the help has come. What would you ask the help to do? So someone goes into cardiac arrest, you've started CPR, you've shouted for help and the help has come. What would you ask the help to do? Yeah, so they can get more help and then you can now tell the person to get ready to swap. But then you need an AED, don't you? You might need to secure the airway. So you can just say, if you have a code team, you can tell them activate emergency response and call the code team. Or you could just tell them, get the AED and get the crash cart. Because you know the crash cart will have everything you need. Alright? And the best time, who knows the best time to prepare for cardiac arrest? Before it happens. Everybody knows their roles. And everybody knows which role the person is going to play, and then they know to make sure your equipment is in order. Yeah. Any questions? Any questions? Okay, so I want us to practice in teams. Are you ready for Okay, so we can practice in teams? Okay, cool. So can we pair up? This time around, one person is going to do compressions, then the other person will use the AED and the back valve mask. Alright, so Paul, can we practice so that they will see? Alright, so no, let me work with Paul. Then you see what we've done, and then you can practice. So which mannequin do we use? Maybe this one. Okay. Alright, so who wants to give us a scenario? Someone else. Give us a scenario, but simple one. Who wants to give us a scenario? Someone else should give us a scenario. Good. And it will not happen. Excellent scenario. So someone has just slumped to the ground now. So the first thing is, please, can we give some room? Can we clear? All right. And let's say it's in church. And you know, if it's in church, if it happens in church, what do you think is the first thing that happens? People gather around, people are praying and all that. So what gives you the right to clear all of them and then walk through them? It's going to be difficult. So please, everyone stand clear, stand clear. I'm a medic, I'm trained. Please, let me assess the patient. You have to introduce yourself for them to give you some space. All right, so my seat is safe. All right, and the person is lying on a fair, flat surface. So what do I do? Hello, hello, can you hear me? Can you hear me? Patient is unresponsive. Help, somebody help.
Okay, I'm coming.
No pulse, no breathing. Is my help around?
Yeah, what's going on?
Please, this person has collapsed. Please get the AED and activate emergency response, please.
Okay.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 21, 22, 23, 24, 25, 26.
So we have it. So in the instance that I do not have this, I'm the first help, so I would have called for others to bring this thing, okay? I have this, so. Okay. Kevin, I have the AED.
All right.
I know how to use the AED.
Okay. Go ahead. I'm doing hands-only CPR until he's ready to give breaths.
Patient. If the patient is a child, the child bite. Remove clothing from the patient's
Clothing
chest.
removed.
Okay.
Remove packet and apply pads on the patient.
I'm not stopping compressions. Am I stopping? Good. Can you put it
Pads firmly
That's the
on
highest
skin.
for this one.
2. Can go.
Do not touch the patient. Analyzing
Do not
heart
touch.
rhythm.
I'm tired of compressions.
Do not
Take over
touch the
compressions
patient.
while I take over breaths.
Analyzing heart rhythm. Shock advised.
You see, we've swapped roles,
Do
right?
not touch the patient.
Do not touch.
Everyone clear.
Okay?
I'm clear. Are you clear?
I'm clear. You are clear?
Okay.
Watching, no one is touching.
All right.
Shock delivered.
Shock delivered.
I'm resuming CPR.
Begin CPR.
All right. When you get to 30, let me know so that I can give breath.
10,
13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 28, 29, 30.
1, 2. Continue compressions.
1, 2,
I just give
3,
breath,
4,
and then he will
5,
continue.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
1, 2. Any chest rise?
Yes, chest rise. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 24, 25, 26, 27, 28, 29, 30. Sit down, third one.
Okay.
1.
All right. So we can stop here. All right. So after every 2 minutes, what will happen? The AED will tell you analyzing rhythm. So at that point, we'll switch roles again. I will now go back to compression while he will go back to the airway. You don't remove the pads when it shocks. You leave it there because it will help you with your compression rates and it will help you analyze the rhythm because the person might need more shocks.
Do you need more time? Yes.
This song actually gives you 110 minutes.
Okay, so when they're ready, we'll swap. We're almost done. Almost like 10 minutes. All right, so select your teammates and choose between your teammates who's your first responder and your second responder. I know they want. So, who's your team member? Because if you have a team member. So you don't have a team member. So where's your manager? Who's your team member? This is, you have one person. We have this is you. This is your manager. Have to make sure. Is there anybody here?
Yes, he's there, but he doesn't have to take this out.
So you use this one. We just want to make sure you have space. Come on, use this one. Maybe you can come to
So who doesn't have a team member? See that? Who doesn't have a team member? Evelyn, do you have a team member? Evelyn doesn't. Yeah, sure. So you need a team member, right? So I can work with you. So the two of us will be here. So you will be Alright, can we practice how to switch roles? So somebody should be at the side and the other person will be at the head. So you can be here while you're here. No, you don't kneel down yet. So whenever you hear analyzing rhythm, when you're using the AED, or once it's 2 minutes, you switch. And how do you switch? You move here, you come this way to the airway. Alright? You need to switch. You move this back. Yeah, Alright, so can we practice again? So analyzing rhythm, let's switch. Easy. Alright, let's get it here. Alright. Analyzing rhythm, let's switch. You move this way. You see, you're not running into each other, and you don't have to go through the leg. That's why the head of the bed, as soon as someone has the CPR, should be pushed forward, and then the bed lowered. Alright? So, analyzing rhythm, let's switch. No, he was here before. Yeah, so you move this way. Don't worry, we'll get it. Analyzing rhythm, let's switch. Great. Analyzing rhythm, let's switch. You are switching with an imaginary friend. That's all right. Okay, let me join her, please. Analyzing rhythm, let's switch. Great. All right. So, who is the first responder? You are the second responder. I'm the first responder. So, second responders, please go over that way. Now, if your team member doesn't know you by name, like if they say, help, help, how would you help? All right? So, call your team member by name. So, let me start. Good.
Always the case that you have to know the person.
You don't have to. I mean, you don't have to. You don't. But because we have a lot of. Has this ever happened? This has happened to me before. So I asked someone, get me an ambu bag. Everybody leaves me with the patient to run to get an ambu bag. Because I wasn't specific enough. Alright, okay. Alright, so scenario.
Alright, so we have a patient in the ED. The patient has chest pain. Doctor has ordered for ECG. Now we observe this patient gasping, agonal breathing. Over to you.
Agonal breathing. Okay, scene is safe.
Your scene is safe.
Alright. No response. Help.
No, I'm here.
What do you want?
So go on with the assessment.
Alright.
There's no ball. There's no ball. Go ahead. Okay, start your CPR. Then second rescue, just come and listen to them. Don't bring it. Just listen. So come and listen.
Evelyn, please bring me the ambu bag and bring me the AED, please, the BVM. Thank you. I'm here now. All right, go ahead. Connect the AED for me. Please connect the bag. First of all, you have to connect the
child. Remove clothing from the patient's chest. Remove packets and apply pads on the patient's bare skin. Apply pad as shown in the picture. Press pad firmly on skin. Apply pad as shown in the picture. Apply pad. Do not touch the patient.
Shock advice.
Touch the patient.
All right.
Everyone clear.
Everyone clear? Are you clear? Good. All right, press the shock button. Yes. Shock delivered. Continue CPR.
Begin CPR.
Midline. Midline. You're healed. Let's go.
30. Give 2 breaths.
Go deep as you can. Can we switch roles? Give 2 breaths. Hold on. Let me give 2 breaths. 1, 2. Continue compressions. Go. Count.
10.
You didn't get to 30. 1,
20.
2. Continue compression. 29, 30.
Give 2 breaths.
So, 1,
10.
1, 2, 3, 4, 5, 6, 7, 8, 9,
20.
So his voice is not the AEC. 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Hold on. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14, 16, 17, 18, 19, 20. 23, 24, 25, 26, 27, 28, 29, 30. Give 2 breaths. Analyzing rhythm. Analyzing rhythm. Switch. So let's switch.
Stay clear of patients.
Shock not advised. Shock not advised.
Resume CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19.
Your patient has started moving.
Patient has started moving. All right, continue giving breaths.
You check a pulse.
All right.
Check a pulse. There is a pulse.
All right, start giving rescue breaths.
Give rescue breaths, 1 breath every 6 seconds.
And then open the airway.
So give breath 1, and 2, and 3, and 4, and 5, and breathe.
So hold it
breath
and give.
1, 2, 3, and 4, and 5, and breathe. So 1 breath every 6 seconds. 1, and 2, and 3, and 4, and 5, and 6, and breathe.
It's the seal.
4, and 5, and 6, and 4, and 5,
Pulse check. Pulse check.
But if the person has a pulse,
he has a pulse. now if that's continuous. So 6, 5, 4, 3, 2, 1. 6, 5, 4, 3, 2, 1.
Get that. All right. So for you to use this, you need to be at the head. That's how you become a full efficient test. We are good.
You run a tool to get a patient back. Shock 1, 2, 3, we get the patient back. We realize what's it.
So when you're doing
we cannot get IC.
compression statistics to 2,
and in front of us,
when the person has a pulse, when you move any questions before we switch? So let's do it better. If I get it, I take your time. Is that okay?
Thank you very much.
We'll share, all right.
This is
your course.
So try it.
Well, we're not getting the clamp correct.
Yes, the clamp, that's right. You get it. Yes, and open the airway. Yeah. Good, nice. Right. It's tough. Yes, I expect it. Because the same thing you did. So the thing is, when you give birth the first time, the chest is not right. So the advice is you can push it more to expand the lungs, and then you can now reduce. Or you make sure your clamps are intact. So any question before we start? Any question? All right, so thank you guys. I hope you teach people around how to stand up. So the cameras can now go there. We are tired of the cameras. So you can move there.
We hope it was beneficial. Go a short So now they are going to do the ACLS.
All right, so someone just asked the question, why do we do compression 30 times and not 20 times?
Sorry.
Before giving breath. Someone is asking,
okay, so
why do we do compression 30 times before giving breath?
okay, so welcome to our station, our little ACLS station here. The free answer, UJ. Okay, Dr. Nama, everybody, Dr. But doesn't matter, we are all different people. Okay, great. So we have just rules of engagement over here. We try to simulate this as best as possible. Try to make it as realistic as possible, because in real life you are going to try, like most of the time, information is going to come in real time. Our defib here is a live defibrillator, emphasis on live, so please try not to mess around with it. Okay? We don't want any casualties here. Great. But we'll take you through how to use the defib so everybody's comfortable with it in case you are assigned to that, you'll be able to manage it well. Great. We have a mannequin here, airway mannequin. We can actually put in stuff and it will bag nicely. You see we have our little syringes over here, there's fake, everything is here. So anytime you are going to do something, we want you to try and act it out as best as possible, right? Okay, so we'll quickly take you through the defib, that's the most important thing for now. Make sure everybody's safe there. And then we'll run a little simulation, let you understand what we expect of you.
So now,
okay. For online people. Okay, so we'll go through the defib quickly, all right, so that everybody's comfortable, everybody's safe around it, nobody's scared of it, because a lot of times in our scenarios, in our settings, when we assign someone there, everybody's just standing back, running away from it, okay. Hopefully after this, we'll be able to run into the defib when there's a CPR attempt, right? Okay.
So this is a defibrillator. We have the monophasic and the biphasic. The monophasic is old school. If you see a monophasic anywhere, then there's a problem. Okay, so currently most defibrillators are biphasic. Okay, now for the monophasic, the defibrillating energy, the joules, is 360. For the biphasic is 200 joules. So it's actually written on the device whether it's a monophasic or a biphasic. Now a defibrillator some defibrillators can act as AED, just as you use the BLS or use it as a manual defibrillator. For healthcare workers, we want you to use it as a manual defibrillator because it saves time. Notice the AED, analyzing it. If it was my boss, he has decided it's a VF, he will shock straight that way. But it is still analyzed, so you can lose some time with the use of the AED. Okay, so basically, you get to know your defibrillator and how to use it. But there are same principles that run across. So it has to be powered. Okay. Then if you look at this button, you see here off, you see on. You see here A, you understand? So your defibrillator has to be connected to your patient to be able to read the rhythm. So if your patient is not connected, you can't read the rhythm. So in this case, we simulate you connecting the patient to the defibrillator. In this case, our defibrillator is serving as the monitor at the same time. You may have the monitor separate from the defibrillator. So we expect you to connect the patient with this for us to say, for you to tell us the patient has been connected before we turn it on for you. Okay? So you connect, then we tell the patient it's on. This, even though it's live, it's also for what? For teaching. Okay, so this is a rhythm simulator. So immediately you put it on and you tell us it's on or we notice it, then we can do the rhythm. Okay, then your team leader at a time can delegate someone to check the pulse and make a decision whether there is a pulse or there is no pulse, and you act on it. Okay, so let's assume we select this as the rhythm. Okay, and there is no pulse. Okay, so this is a wide complex tachycardia with no pulse. So VT, you understand. So we've made a shockable rhythm. Okay, so your team leader is a shockable rhythm, resume CPR. So the one at the monitor has to now defibrillate. But to defibrillate, you need to select your energy. Okay, so this is the button for selecting energy. Other defibrillators, this is like a clock. Other defibrillators is plus, minus. So you just have to know your defibrillator. So let's say it's biphasic, so 200. Okay. Now after selecting, you have to what? Charge. Charging, most defibrillators have the charge on the button, on the paddles. You can also charge from here. You see the arrow down. So if you press the 2, it will charge. If you press the yellow here, it will charge. Okay. Applied your gel. Otherwise, your patient will smell like burnt meat, burnt goat. You understand? You don't want that. We don't want you to apply the gel on the pad and rub it together. You are playing with electricity. It can be dangerous. Okay? Now, so if you press this yellow button, it begins to charge. When it's full, it makes a noise to alert you. So you see that it's fully charged. Now you see the noise has changed. Now, this is... Okay, so where you see the metals, because it's for teaching, if you place it, it actually will release the energy. Okay, so then you make sure that the environment is clear, and those around have to respond what? Clear. You understand? So it's again for now. Go back. It's to protect you. If you are delaying too much, then assuming you as an error, it turns off so that you don't mistakenly, you understand, really. So please, the clearing is important. Just, it depends. Yes, it depends. Some will stay, but please remember to clear before you defibrillate. These are paddles. Some defibrillators come with pads, so you just apply the pad position. Then you are just pressing buttons. Charge, defibrillate, charge. So, but for now, most centers have the paddles. Okay. we are, because of time, we are just doing the shockable. But a defibrillator can do conversion, synchronized cardioversion. This can even do, but we are not running the full course. We are focusing on the cardiac arrest. So at least we will run, whoever will come out to the monitor will guide you on how to use it while we are running the code. All right? Yeah, I'll give the scenarios.
Yes. 1, 2, third person. Okay, great. So, hi team. Can I get names? Oh, there are plenty of people. Dr. Bo, Dr. Conte. Hey, Dr. Conte. Okay. Dr. Baini. There are plenty of people. Henry. Okay, great. There are plenty of people. Senior cardiology. Okay, great. So. Your questions. You don't want your okay. That's he's telling me he can't do compression. So what would you like? You want to be a very okay. Okay, so I have extra people. So I want you to. Yeah, I have 2 people on my airway. You can't tell. Everything well enough, okay? My 2 compressors, you can be there. I mean, no. Okay. Let me just relax. Okay?
Hello? Hello? Please, am I speaking to the doctor on duty at Konfanochi Teaching Hospital Emergency? This is this is EMT Kojo Nkansa Lowen. Please, we were called to see a 60-year-old diabetic and hypertensive with sudden onset chest pain. We arrived at the house. The patient is sweating and clenching his chest. BP is 100/60. Pulse is 100 beats per minute. The sugar is 7.0 millimole per liter. And oxygen saturation is 92% on ambient air. You are the closest facility. We think this patient probably might be having a heart attack. We had some aspirin. We've given him 300 milligrams of aspirin to chew, and we are on our way to your facility. Can we come there? Unfortunately, we don't. All right. 5 minutes.
So let's prepare. We've assigned our roles. Let's be ready to receive. Hi.
Hi, Dr. Sana.
Right.
Yes, about the 60-year-old we are suspecting. Okay. Chest pain is simple. Yes.
Hello. Hi, sir. Oh. How are you doing?
I'm not well, man. This morning, and all of a sudden, I felt this chest is like an elephant is sitting on my chest.
Oxygen connect.
Patient connected to monitor.
Okay, my patient is on monitor. Can I know the reading? That's your rhythm. Okay, great. You said the patient had chest pain. Yes. Okay. Well, we are not using this feature. Give me an ECG. Okay.
Yes. 12 ECG on the way.
IV line, take samples for ABGs, cardiac troponins.
So what's content?
Patient is unresponsive. Checking for a pulse. Okay. That's thank you. All right, so let me step aside, and then everybody will be great. Great.
Test of pressure, please increase your compressions.
The charge ready?
You can
Yes,
use the tool,
charge.
it will make it easier for you.
You are ready. Charge is ready.
Charge ready. Clear the patient, everybody. Clear. Are we clear?
Everybody. What's the diet?
Short deliver.
So please, you are doing 30 compressions to 2 breaths.
IV fluids running.
Are we getting some ventilations?
Yes, please, we are.
How many minutes are we doing?
Your pH is 7.0. Your bicarb is 12. PO2 is 60. PCO2 is 35.
There is no pulse.
Resume compressions, please. Please charge to 200 joules and deliver shock immediately. Placing on medication to the stomach. Please charge generally 1 milligram and deliver after the shock.
Clear the patient. Everybody. Short deliver. Pulse check.
Okay, hold. Okay. Please hold compressions. Checking for a pulse. There's no pulse. We are still in a shockable cycle. Okay, please charge and deliver shock. Some of get amiodarone 300 milligram ready and deliver. Administer after our shock.
Are we clear?
Amiodarone has been given. Are we getting good chest right? Yes, what's our PCO2 now? Which ABGs?
The ABG machine is fault.
Okay, that's fine, no problem. We have an early.
Rhythm check.
Your chest is clinically clear, just some transmitted sounds in the lung bases. So 12 lead ECG done shows ST elevation 4 millimeters in lead 2, 3 AVF, and 2 millimeter ST elevation in V1. So rectal temperature is 30 degrees Celsius. Okay, so the patient has been assessed by the interventionist and has accepted patient needs urgent catheterization. So patient has been moved to the cath lab. It's regimental. Oh, it does. So just to give an overview, you should note that the patient came in first of all conscious. So the systematic approach, that is where it starts from. You need to determine which pathway. The patient was what? Conscious. So he started with what? Primary assessment. So airway, breathing, circulation, DE. So he was going through that, and when he wanted a 12 lead ECG, patient what? Became unresponsive. So you have to confirm that indeed the patient is what? Unresponsive, and that's why he hits over the clavicles. And it shouldn't be a romantic touch. You want to be sure patient is what? Unresponsive. There has been circumstantial response. People jump onto their chest and the patient screams, Ajay. You understand? So you want to be certain. Because respiration is unresponsive, has no central pulse, has agonal or absent continuous breathing. So then he went ahead to check the carotid pulse, and there was no pulse, no breathing. So patient was in cardiac arrest, and straight away he went into BLS. Even though we are at the ACLS stage, the foundation is CPR. So activated compressed 32-rod rescue breath. And now the monitors were connected. The immediate monitors were connected. You pause. You want to know your rhythm because you need to know which pathway you are, whether you are along the shockable pathway or you are on the non-shockable. And straight away, he was able to determine his rhythm as shockable and made a decision, gave the ahead to defibrillate at 200 joules and went straight away to resume chest compression because chest compression is still the foundation. If your defibrillator is jamming, don't say so. You are just waiting for your Dr. Conte was ready, he and defibrillated, and straight away resumed chest compression. You don't defibrillate as you see in the movies and go and check pulse. Because when you defibrillate, you are shutting the heart down to ground zero, and you want the heart to restart, hoping that it will start with a normal organized rhythm that will translate into mechanical activity. Not every organized rhythm translates into what? Organized mechanical activity, because you can have a PEA. And that is why you are doing the 2 minutes, hoping that at the end of 2 minutes or 5 cycles, hopefully, if there is a rhythm that is organized, it should translate into a pulse, which is the mechanical activity. second shock, and that is when he gave what? The adrenaline. Continued the third amiodarone. So remember, with adrenaline, all numbers, then he's still looking for what? The H's and T's, the reversible cause. So he asked for his pH, he was asking for hypoxia. So that is how, don't be idle. You should be looking for causes to what? Correct. You understand? In an environment, it can be difficult because ABG, you won't get the electrolytes. But if there's any reason to suspect acidosis, treat. If there's any reason to suspect hyperkalemia, treat. If your patient is on end-stage renal disease, nothing assuming hyperkalemia, because you are anyway. So you have to make a decision and act on it. And when he achieved ROSC, the return of spontaneous circulation, which is evident by the presence of a pulse, he said he had achieved ROSC, and there he reevaluated and went to post-cardiac arrest, because your patient can achieve ROSC and be in respiratory failure. So his airway, he already had his airway in. But he did not stop there. He assessed the advanced airway by checking what? Saturations. Is it effective? If you have ABG, you check. If it's not, you go a step higher. The blood pressure was low. He wanted to correct it. He gave fluids. If it's not responsive fluid, he would have added what? Inotropes, if necessary. Remember, if you were unable to check your H's and T's, post-cardiac arrest, you do check. So if you have a patient might have a tamponade, you can ultrasound there. Understand? Then he wanted to prevent further neurological damage at the D. So he said, no command. He couldn't. So you have to institute targeted temperature management, because you want to keep the temperature between 32 to 36 for the first, 24 hours. Then he was able to establish the cause of the MI, of the arrest as what? A STEMI, involving the inferior leads and also the possible right ventricle, because V1 had ST elevation and he cut lap. So you see how it is. But when he finished and the patient was moved, he didn't stop. Find out each day. Said, did we better? See the wording. The next one, he said, what can we do to improve? He didn't say, what did we do wrong or what did you do wrong? It's not a blame game. Tempest can. So you need to manage the team. Tempest. Good job. Let's give our hands. Let's clap for ourselves. Let's clap for ourselves. Yeah. Okay. Yeah. Yes. Delayed. Yes. Yes. Are CPR enabled? Get a cup. For the adrenaline. Because 3 to 5 minutes is an odd number, and you are timing every 2 minutes, so it can be confusing. But if you choose the 4 minutes, it means that every other rhythm and pulse check, if it is a non-shockable rhythm, you can give your adrenaline. And I get your point in if there's a delay, but that's why you need to practice to get better. But if you've delayed, it's better to give than not to what? Not to give. But it comes with practice. He says, then, so you have to chart 15 seconds even ahead of the next rhythm and pulse check. But remember, we don't have the full time. Like we said, if we are doing the training, it's a 4-day training. So ideally, you have to chart 15 seconds ahead so that it makes it a shockable rhythm. Yeah. When you saw the video, team member can politely the reminder to give later on. Our team has to know that what is expected, so that you work as a team. Anybody who is doing ACLS and is not a team member cannot run a code, ACLS code. Imagine 2 minutes is, and you're prompted is 2 minutes. Before you realize you've done CPR only for without notice.
Where people think that the timekeeper is the most unimportant because they are not extremely important, but you are actually playing a very critical role. You are the one who can remind the team leader. Team leader, we haven't done our H's and T's, we haven't done this. The timekeeper also role to play. It's not as
and the one documenting, because at the end, when the team leader for a summary is the one documenting who will tell the team leader, we started CPR at this time, we have done this. Yes. You have a team leader. That's the team dynamics. So you alert the team leader.
I can try to Dr. Bani, our target compression rate is
let's go a little deeper. We are not. There are some. You can download a metronome onto your phone. I like using music when we are doing metronome. It actually has a of 100.
The caveat I have with the music is that, in an environment, if there's a relative around, be careful. They may misinterpret and think the patient is about, and you are playing music. So be careful how you look at. So you have to you have to look at it in the context. So it happens. See, with that CPRs in the you've called for help and they snub you and walk away because they got tired or said and really, but it comes with practice and we all learn. But trust me, tempers can flare. I believe there have been several cases where I've called people for CPR and not even it won't work. So they are not even bothered. It won't work. Why? Because they've not seen effective CPR being done in a long time. So they've seen a lot of failures. But when some people see success, and I can tell you now, ER in Kolebu, when they are running a code, you know that this is a code. It's done per the letter, polyclinic, Bafo is there. So if people do it and success and they call you, if I call binding for CPR any day, he will come. Why? Because seen us achieve it. So people have been doing it over a long issue time and need to change the thinking. There should be a paradigm shift. I understand we are challenged. If it's semi, Catla, a few places, where is it even available? Do you have money? Don't they ask me, Eugene, who is paying? The realities on ground. But I keep saying, let's be achieving the ROSC as the first target. And now we can start pushing for them to ensure that cath lab becomes subsidized. You understand? But when you're not achieving the ROSC, you don't even have an indication to ask for a cath lab. You understand? So let's give patients a chance. Let's push. A patient is brought in unresponsive. You don't know how long the patient has been unresponsive. At least assess, run a cycle or two, and work to the relative and say it wasn't successful. Imagine it was you and your relative, you brought your husband. Gets in, they say BID. And how will you feel? Compared to he's received, quickly they activate code, they check, they run CPR, check sugar, basic, and say we did not make it. You understand? Because you don't know when the person became unresponsive in that heat. Okay, maybe he was conscious in the taxi. At the time he got to the ER, that was when he arrested. You understand? So unless there's evidence of death, right, or other things, so that's where institutional protocol comes in. The patient unresponsive, we don't do CPR. Fine, you are protected. That's the institutional rule, irrespective of the duration. You understand? Or for us, when we don't know the duration, the AHA, when you don't know when the patient became unresponsive, you will do CPR. Because you don't know. If the patient was out of hospital and did not receive a shock, and it was a shockable rhythm, you will continue. You understand? You don't just decide that patient is, because in cardiac arrest, people should be fixed and dilated, unreactive. The absent has sounds. Cardiac arrest equals clinical death. You understand? That is why you need to ask questions. And in the heat, you can ask, how long if they ask you, you brought your husband, says, and now, how long has he been unresponsive? And he said 1 hour. Has been unresponsive for 1 hour. If he said he was unresponsive 5 minutes ago, you may have a better chance. You understand? So, environment, the challenging thing is that, in fact, when you look at the chain of survival, chain of survival, because in the environment, especially when you cardiac arrest, the success is low. So when you are seeing that patient who is breathing, that airway has to be taken over. Not go and put the 15 liters and leave the person. Because that breathing is what? Agonal. You are moving around. This patient's blood pressure had been 180 over 110. The next check, all of a sudden, is 90/60. You say it's normal. You've not given any medication. Even 180, 110 to 90/60, then you say it's normal. Then you walk away. You understand? Those are the things. You identify the day someone has been lying down, and all of a sudden, respiratory rate is now 35 cycles per minute. Respiratory rate is increased. Then you leave. Then you come back, and like we say, patient was found unresponsive.
Patient's condition has.
The warnings were there. Let's say you even notice the patient is having agonal breath, and you put the person into. But you see, let's start demanding it. Keep pushing it. But if we accept it like this, things won't change. You understand? Are we okay? All right. There was a role that we mentioned. So apart from the CPR coach, and the job of the CPR coach is to observe and ensure that the chest compression is being done right and the airway is being managed, so that the team leader can focus H's, the T's. Where are we in the algorithm? So that he can focus. At first, as a team, about the algorithm, we are thinking about the H's and T's, and you're also doing what they're supposed to do. You can be running a code, and you're one of the airways on the phone. It's on the phone. Probably had to pick the call. So as a team lead, you have to lightly tell the person that, please, we are not achieving. So kindly, do you want to be reassigned? Do not keep someone in a role that is inefficient, because we are dealing with time. Time is critical. That's why when you call someone to help, the person is not willing, don't force the person. The person will become. You understand? Instead of chest compression, we'll be doing abdominal compression, and your patient will aspirate. You understand? So as much, and when you practice the day, patient comes in responsive, how will you be cool if you're not practicing? You get rusty with time. So every patient that becomes unresponsive, people fixated. I've said that the relatives, be like, unless we are definite that there has been, do not resuscitate, an advanced directive, or you've discussed with the relative that this is palliative care, prognosis, so there should be a definite pathway. It should not be choose and choose as and when. Okay. I think Dr. Sana wanted to ask something.
Oh, no, I think you can just say so. As a team, your last question, if you are not comfortable with the rule, just say it. Because that will not be the best. That he says that, yes, you are in charge of the defibrillator. You don't even know where to turn it on. Then you go like, I say, no. Exactly. So please, if you are not comfortable with the rule, just communicate to the
We will not be involved.
not be involved. So who wants to be the team leader? Biden will be the team leader. Select your team.
Okay, my team. I'm more of a timekeeper.
You can go to strings, or some defibrillators monitors actually have a way to track that. Usually, that's a way of tracking this. So then that makes the job easier for either the team leader and or CPR coach to monitor the quality of CPR. And you can set a target 110, but you're doing 98. It makes it easier for everybody to track. Again, it's about if we don't ask for the thing, the people who are doing procurement.
And your team.
Yes. So Amwaba, you be on the defibrillator. Dr. Tobo, you'll be the timekeeper. Dr. Conte, you'll be the CPR coach. Tobo, CPR. Sorry. Chest compressions. Dr. Kamara, take over the line. Obed Airway.
You can come with
Okay, Airway. Could you please be the CPR coach? Do I have my team set? Come. Okay, please help Dr. Okay, compression. Yes, this is Dr. Kamara. Dr. Kuwin Komanatobo and then Bo. Dr. Conte is a timekeeper. Yes. Amwaba is defibrillator. Documented. Sure.
On duty. Suddenly became breathless, and so called the EMT service. So the EMT service arrived at the house and noticed an old man who is breathless, respiratory rate of with oxygen saturation in the 80s, blood pressure 90/60. Okay. set a line and started the patient on normal saline. So that is the call you receive.
Okay.
They are coming to your point.
So team, we just received a call from the EMT, old man who's a diabetic and had sudden onset of breathlessness. They're on their way. Let's get into position to receive this resuscitate. Can I say the oh. Yeah, so this is a 70-year-old diabetic who had sudden onset of breathlessness, immobility. So I'm thinking the likely diagnosis here will be a pulmonary embolism, right? So we will get ready to receive the. Hello. Yes.
Please, are you Dr. Binding?
Yes, please.
This is EMS with no cancer, no way.
Right.
I spoke to you about a patient who was breathless. And please, that. It seems not to be responding to oxygenation.
Okay, great. Dr. Kamara, please check the SpO2. Kamara, please check the pulse. Check the pulse.
Okay, so SpO2 is 84%. It's swinging between 80 to 84. SpO2.
All right, so checking
Dr.
pulse.
Daniel, please give oxygen via the nasal prongs.
Nasal prongs, okay.
Yes, and maintain ID access.
So we can assume this is the oxygen is somewhere here.
So someone kindly connect the EC patient.
All right, so connecting cardiac monitor to patient.
Please, what is the pulse of this patient?
This is 120 beats per minute.
Can we look at the rhythm?
I'll give you the rhythm. It's connected.
Take samples for ABGs, potassium, check blood sugar.
So monitor connected.
Check the temperature as well.
So your monitor is connected. So temperature is 36 degrees Celsius.
Rhythm. Dr. Amwaba, can you check? Okay, let me check the patient's chest.
Ventilation. Why do you want to take over the airway? Let me conscious.
We can use it.
Okay. So non-rebreather max. Okay. Right. Is it?
Are the results of the ABGs ready?
ABG. Okay. Yes. All right. So your pH is 7. PCO2 is 20. Your bicarb. Lactates. 1 per now. Ventilating. Suddenly, patient has stopped breathing. Checking out. Why are you checking the pulse now?
No, use the check from the central.
So who is checking for
the carotid pulse?
So patient has no pulse. So when he's checking the pulse, patient is unresponsive. What's it?
We need to start CPR.
Okay, give your command.
So kindly start CPR immediately.
Okay, CPR started.
Okay.
So they are doing chest compression. What do you want to be done at your airway?
Okay. Put in there. And connect there.
Ventilate
the patient.
So when patient is in cardiac arrest, they cannot ventilate. So if you give oxygen, it is waste. You have to ventilate before you oxygenate. When a patient has spontaneous breathing, they are ventilating. That's why you give. But when they're in cardiac arrest, and oxygenate. So That's why you have to give ventilation, the back mask, or you can decide to advance as soon as possible. And you should remember that even though you are doing 30 to 2, the 30 to 2 is when you don't have an advanced level. So when you have a skilled team, you understand? Pardon?
Let's check the blood pressure. Let's check the fluids are going. And let's check the SpO2.
So wait, before we check with them, fine, you did very well. Your decision was pulseless electrical activity. So which part of that? So apart from chest compression,
I need to give an instruction for adrenaline.
so you see exactly. So already you've lost. So he decided it was right is the found. Now him give 1 minute. You understand? Because remember, for non-shockable rhythm, you have every 4 minutes. So far as it's non-shockable, and you are correcting the H's and T's. So within that 2 minutes, they are doing the CPR with the reversible course. You understand? With the one by the. You are part of the team. You can offer suggestions to your team lead that based on the presentation, team lead, I think this patient has an MI. I think this patient has a PE. I think this patient has severe. You are part of it. So you can offer, not just there doing chest compression, but to be out. It's a go through your H's and your T's, correcting the reversible course. Because remember, for a non-shockable rhythm especially, until you reverse the reversible courses, you're unlikely going to achieve loss.
Let's
okay, so 2 minutes is up.
Kindly give adrenaline.
So pause. Why do you want to give adrenaline? He's already given adrenaline already when you gave your command. So when the next 2 minutes is up and you think it's still a non-shockable release, you ask him, when was the... But remember, you are giving adrenaline every 4 minutes. So you have to... So who's checking your pulse for you?
Dr. Charles, can you check the pulse?
There is no pulse. So what's
Kindly let's continue CPR.
So what's your decision?
Pulseless. So if the pulse will give you.
No. So another one is not used for, another one is for shockable rhythms. You understand? Yes, so this adrenaline every 4 minutes. It's still a PE, as you rightly said. Alright? So you need to always define where you are. So this non-shockable, you have to look for your H's and T's. Which in this case, the scenario taking some clues.
Alright, so echo is on the way. We are bringing the PE to this.
No, so what we don't want to use the word echo. Bedside ultrasound. What are you interested in? They should you see.
Continue the chest compression.
Oh, you said pause and rhythm check.
Alright, so pause and rhythm check.
What's a rhythm check?
Check the pulse.
Okay, sorry, I'm coming.
So we still have...
No, wait. What's a rhythm check? Wait. That's your rhythm. There is no pulse.
Alright, so I think we have deep picture.
To let the team leader. The team leader has to
Please
be
charge the
That's why you have to make your decision and tell them to resume chest compression. If it is that chest compression, what you are seeing on the monitor is the chest compression. Okay, so this is not there. This is not your rhythm. But I agree, he said it was a clear. It's a short.
So now, charge the pad.
Alright, so charge it. Set
200.
200, yeah, 200.
And tell me when you are ready. Let's continue chest compression.
So charge it.
How's my airway?
Yeah.
Okay, clear for the shock to be delivered.
Clear. Everybody
Take off the
clear.
oxygen from the table.
Everybody clear?
You didn't take it away.
All right, so
Apply it.
oh,
don't wait.
Okay, let's resume chest compression. Please compress as change to advanced airway. Change to advanced airway. Camera. Get PG, potassium, SpO2.
So the patient is in cardiac arrest, so me giving you SpO2 won't change anything much. If it's an AP. When there was applied, so the whole room is smelling like bent coats. Okay? Always remember that. Which other thing do you want? You are asking for advanced airway. So what is the difference in the chest compression?
Now you got everything.
Continuous chest compression and advanced airway. So add one. Okay. For rhythm, so you rhythm and pulse check. Who's checking your pulse? Pulse, that's your rhythm.
It's still past
Wait, what shock is this? First or second?
This is the second.
Second shock. The second shock. Second shock, not the third. So he has to take that. So the next. So far as if you are following it, it always falls within it.
All right, what do I do?
Is it time?
So because of time, 2 minutes is up. Rhythm and pulse check. I can see my people are tired.
Okay, we are back inside.
Okay. So what are you supposed to do?
The pole. Check the pole. It means that we are achieve Ross.
So where are you now? Post cardiac arrest test.
Okay.
So use that landmarks so that you know where you are.
So we alert the police team.
But before you alert them, it's good. But post cardiac arrest care, A, B. So are you happy with your airway? He's using an LM. Time you want to probably do an ETT. You understand? Secure your airway. Yes. It will not run a 12. First time to run a 12 EDC because patient had arrested. 12 EDCG comes and says S1, S2, S3. Okay. So your blood pressure is low. What do you do? You give fluid. Reassess. So what do you do? You may consider enriching. So that's how you keep. And I mean, so like this patient. So I think you get the concept now. Yeah. So let's assume where. Going through. And where do you want to manage this? See the eyes? Let's clap for ourselves. Ultrasound. Oh, you still do it. So while they are doing it, that.
Again, if you develop this, cardiology ethics. It's